for Mahanavami and Dasara to all of you. I am Dr. Renu Raina Sehgal, Chief of Ops and Gynae at Artemis Hospital, Gurgaon, and I am going to be your hall in charge for the first session today. On behalf of AOGD and Sir Gangaram Hospital, I welcome all of you to this e-poster presentation on the high-risk pregnancy today. Organizing conferences in these current times has been challenging, but also has provided us with more opportunities in terms of participation and wider reach. So though we have a tough task of judging 20 posters in limited time, I hope we have a binge learning on the way. Without further delay, I would like to introduce the esteemed panel of judges joining me today. So we have Dr. Sharda Patra, Professor in Obstetrics and Gynae, Lady Hardinge Medical College, who is presently pursuing a 2-year fellowship at in Gynae Onco at Dr. B. Barwa Cancer Institute, Guwahati. And that just shows how much of interest, and she's now traveling and joining us in between. Thank you, Dr. Sharda, for joining us.
Thank you so much.
We have Dr. Kalpana Mehta, Senior Professor in Ops and Gynae at SN Medical College, Jodhpur, Rajasthan. Thank you, Dr. Kalpana, for giving us your time. And we also have Dr. Anupam Nidhi, Senior Specialist in Ops and Gynae at Guru Gobind Singh Hospital, Delhi. I welcome you all to this session. Let's start right away. Our first poster will be from Anupriya Narayan. Her poster is on pregnancy with tubercular pericarditis, presenting as cardiac emergency, review of a rare case.
Good morning, everyone. Am I audible?
Yeah.
Okay, ma'am. I'll just share my screen. Should I start, ma'am?
Yeah, I think we can start with a brief intro, and then the judges are going to ask you the question and answer. So what we are going to do is that you will all of you will present a little summary, and the judges will ask the questions very quickly. When I call, you share your name, you unmute yourself and share your poster on the screen. Judges have already gone through your posters, so they have marked you on relevance, material, methods, and visual appeal. So in this session, we are going to have real-time question and answers, and 2 to 3 minutes for each of you. The judges will mark you accordingly. Okay, wishing you all the best. So start.
Good morning, everyone. I'm presenting my poster on a case with pregnancy with tubercular pericarditis, which presented as a cardiac emergency. My patient was a 35-year-old Gravitas 6 para-2 live 2 A3 who presented at 31 weeks period of gestation in the gynae casualty with sudden onset breathlessness and dry cough. And on examination, she showed the features of hemodynamic collapse with a tachycardia of pulse rate 102 beats per minute, BP 94/60, a higher respiratory rate, and almost maintaining the saturation with 95% on room air. The respiratory system showed reduced air entry on the left side. From the obstetric point of view, she had no specific symptoms or signs. Immediately, keeping in mind this presentation, the ECG was done, which showed sinus tachycardia, and on an urgent basis, a 2D echo was done, which suggested pericardial effusion with cardiac tamponade. An urgent cardiac consultation was taken, and a 2D echo-guided pericardiocentesis was done, where they tapped 1.5 liters of amber-colored fluid. And with this tapping of 1.5 liters, the patient showed a drastic hemodynamic improvement. The fluid was sent for biochemistry and CB-NAT, which confirmed the diagnosis of tubercular pericarditis, and ATT was started for the patient. The patient showed improvement and was subsequently discharged. But again, within a span of 10 days, she again presented at 32 plus 4 weeks with chest pain and breathlessness, and again she was hemodynamically unstable, for which with the help of the cardiology team, a pericardial pigtail insertion was done, which was kept in situ over 1 week, and the patient improved symptomatically. And during this admission, the patient at 34 weeks went into spontaneous labor and had MSL, but no fetal bradycardia, and under strict fetal maternal surveillance, she delivered a healthy baby of 2 0.35 kg vaginally. The postpartum period was uneventful, and she was discharged in satisfactory conditions on category 1 antitubercular therapy.
Any questions, judges? We have 30 seconds.
It's a nice presentation, Dr. Anupriya.
Thank you.
It's very rare. I don't know what does the literature say about this. I mean, in Indian context, like you have written that in Western, so it's very common. But what about in Indian context?
No, ma'am, in the overall incidence of TB in pregnancy in high burden countries like India ranges from 0.07 to 11%. This broad range is because of the HIV positive status and negative status. Broadly, it is 0.07 to 11%. Out of this, 1 to 2% of these patients of TB may present with tubercular pericarditis. So actually, it is a rare presentation, but being a high burden nation, the 70% of the tubercular pericarditis of the pericardial patients are because of tuberculosis. So the main aim of presenting this poster and this case was that, ma'am, you have to keep a high index of suspicion for even non-obstetric causes of cardiovascular collapse who present to the obstetric emergency. And as we all know, the mind knows, the eye sees what the mind knows. So we have to keep this high index of suspicion and know that we are a high burden country, and a patient presenting with such collapse.
So she had only pericardial. What about her pleural and what about her chest X-ray and all? They were normal?
Ma'am, just X-ray, ma'am, this picture is a little short. She had few lymph nodes, and but mainly she showed what the main area
Thing was
involved was
pericardial.
pericardium. Yes, ma'am.
Okay. So how long do you think AT2 should be given? Is the same as that we give in a normal conventional
Yes, ma'am. We
cases?
discussed. We in collaboration with the team also we discussed, and because it was the new case, so category 1 treatment for 6 months will be given, and then further evaluation will be done post 6 months.
Thank you, Dr.
Okay.
Anupriya.
Thank you.
so much.
Thank you, ma'am.
So we move on to quickly to the second speaker. The second speaker, Dr. Monica, is not there. The third speaker will be Dr. Nitesh C. Dr. Nitesh C has a poster on mitochondrial fission factor gene mutation, a dilemma for invasive prenatal diagnosis. Yeah, I think we'll go ahead with the question answers directly. Nitesh, you can tell us very briefly in 1 minute something about your presentation. Hello, Nitesh, can you hear us? Hello.
I think he's muted his mic. Is he there?
Yeah, he's there. The presentation is there. I can see the presentation. Nitish. Has he joined?
Has joined. I think his audio, he's facing a problem with his audio.
The audio. Can we go on to the other one?
Yeah, we can just go on to the.
Yeah. Let me call Dr. Smriti Anand. Dr. Smriti, are you there?
I think Nitesh has joined.
Okay. Okay. So let's go with Nitesh first.
No, it's audio.
The audio problem. I think his video is there, but the audio is not.
Okay, Smriti, I think.
You could move on to the.
Ma'am, we can move on to the next one.
Yeah. Yeah. We can move on to Dr. Smriti Anand. Dr. Smriti Anand is going to present a non-communicating rudimentary horn rupture at 25 weeks, a diagnostic dilemma. Hello, Dr. Smriti.
Yes, am I audible?
Yeah, you are audible, but your screen is not there. Can you share the poster, please?
Okay, now my screen is visible now.
Oh, it's not visible. Mr. Sumit can do the
Dr. Smriti, can you
Ma'am,
have a share screen option?
share screen with us, Smriti.
Please click on share screen. Dr. Nidhi,
Hello. Yes.
ma'am, can we move to the next one?
Yeah, the next poster is Dr. Soumya Darshan. Dr. Soumya, can you hear me? Are you there?
Yes, ma'am.
Yeah, Dr. Soumya Darshan has a poster on fetal sacrococcygeal teratoma with full-term delivery.
Am I audible, ma'am?
You're
Yeah,
audible? Yeah, thank you.
you can just summarize your case, no?
Yeah, just summarize and
Ah.
then we'll quickly ask the question.
Good morning, ma'am. I'm Dr. Soumya Darshan, junior resident from Maulana Azad Medical College, presenting poster on fetal sacrococcygeal teratoma. Ma'am, my patient was 37-year-old, gravida 5, para 4, life 4, a Burmese woman. She was an unbooked case, referred to our hospital at 33 weeks of gestational age, and she came with ultrasound report, a large mass in the fetus, and then we did MRI, which was suggestive of sacrococcygeal teratoma of size approx 13 into 12 into 11 centimeter, and it was of type 1 of Altman classification. And there were no other complications like hydrops or polyhydramnios or hemorrhage. We followed up in ultrasound for any complications, but the antepartum went uneventful. And at 38 plus 2 weeks of gestation, we took the patient for elective lower segment cesarean section, and it was a difficult cesarean section. Then it was successful, and female fetus with an intact teratoma was born, and baby was of approx 4.5 kgs and with good outcome score. And after 2 weeks of life, surgical excision of the tumor was done successfully, and baby was healthy, ma'am. The
Start the question answer now.
Yes, ma'am.
Question, judges. Hello. Do we have any questions?
Yeah, hello, Dr. Soumya.
Yes, ma'am.
Hello, yeah. But I just wanted to know, you must be having a great difficulty delivering this patient during C-section. Were you there? Were you assisting?
Yes. No,
How
ma'am.
was the baby? How was the baby delivered? I mean, it's such a big mass.
Yes, ma'am. We gave a liberal incision, ma'am, curvilinear incision in the lower segment, and first that teratoma only came out. It was little
Okay.
abbreviated, ma'am. It came out, and then buttocks came out, and legs came out,
I think
and
our time is up.
Okay, fine.
We have to quickly start the question answer. Thank you, Dr. Soumya.
Okay.
thank you,
Can we
ma'am.
go to Dr. Raja? Dr. Raja will be presenting a pregnancy with breast cancer. But Dr. Nitish is back. I think Dr. Nitish, can you hear us now?
Good morning, ma'am. Can
Yeah,
you hear
Dr.
me?
Nitish with mitochondrial fission factor gene mutation. Yeah, go ahead quickly. Dr. Nitish? Hello. Hello. Dr. Nitish?
That was Dr. Raja who responded. Audio of Dr. Raja is working. So we
Okay.
could.
Renu, can we
So-
move to Dr. Raja?
Okay, yeah, Dr. Raja, pregnancy with breast cancer.
Good morning, ma'am.
Yeah.
I'm Dr. Raja. So, are you able to see my screen now?
Yeah.
Good morning, everyone. I'm myself, Dr. Raja from AIIMS Bhubaneswar. I'm going to present a case of pregnancy with breast cancer. So, 38-year-old primary gravida presented at 20 weeks of gestation with a history of lump in her breast since past 6 months, which is increasing in size after conception. So we performed the investigation, diagnostic investigation, examination, and Bruker biopsy with the immunohistochemistry of ER negative, PR positive, and HER2 new receptor positive, with the clinical staging of P3, N2, M0. With the USG of axilla showed multiple axillary lymph nodes enlarged. On clinically, they were matted. We put her on a neoadjuvant chemotherapy with adiramycin and cyclophosphamide for 4 cycles, which has shown up with the improved clinically. The patient responded clinically with decreasing tumor size and disappearance of axillary lymph nodes clinically. So we planned for elective LSCS at 35 weeks. With at the same setting of radical mastectomy, and she was also diagnosed with the left ovarian dermoid cyst. So we planned it. We planned the elective LSCS with radical mastectomy and left oophorectomy, as was on the day of surgery, but the patient refused due to the anesthetic complications, anesthetic risk. We only proceeded with the emergency elective LSCS with left dermoid cystectomy. So patient delivered a healthy female baby of 2.1 kg and discharged. Patient got discharged at the postpartum period.
Okay, we take the question answer now. Any question, judges? Dr. Kalpana, Dr. Anupam? Any questions for him? Hello?
Hello. Yeah, Dr. Raja.
Yes, ma'am.
Yeah, that's a very nice case, you know. I mean, in pregnancy, dealing with breast carcinoma. I just wanted to know, have you come across any effect of these chemo drugs on the pregnancy?
Ma'am, no, ma'am. We performed serial growth scans every month, so we did not find any, and even TIFA scan before starting chemotherapy. There were no any congenital anomalies or any growth retardation during
Because
throughout the.
we're using cyclophosphamide, you know.
Yes, ma'am.
And, okay, fine. No, in the literature review, have you reviewed the literature?
Yes, ma'am. Not thoroughly with the cyclophosphamide. I didn't come across any.
Okay, fine. Thank you. Thank you.
Thank you. Thank you, Dr. Raja. Can we move on to the next speaker? Is Dr. Nitesh ready now, or should we go to Dr. Sarika Gautam? Hello? Dr. Sarika Gautam?
We can move.
Dr. Sarika Gautam?
Yeah, ma'am, I'm here.
Yeah. Dr.
should I-
Sarika will present edema of the anterior lip of cervix and unessential postpartum referral.
So my screen is visible, ma'am.
Yeah.
So my case was para 4L4. She received as a referral case in our casualty. I'm working in PGIMS Rohtak. So she received in our casualty on day 0 with a referral written that a globular mass of 4 into 4 centimeter was present on anterior lip of cervix. When it was examined, when she was examined, her vitals were normal and uterus was well contracted, and local examination there was no bleeding, excessive bleeding. So provisional diagnosis was made of only edema of anterior lip of cervix and caused premature bearing down effort. Patient was kept on serial vital monitoring and swelling size observation. Swelling subsided by its own and reduced to half after 24 hours. And patient was successfully discharged in satisfactory condition. So in my case, it's a normal labor progression, cervix dilatation, and head descent occur simultaneously in presence of uterine contraction. As these contractions are painful for some women, sometimes, and it lead to early urge to bear down, which may lead to catching of cervix between the pelvis and fetal head. And with each urge, it leads to undue swelling of cervix, which increases gradually with further contraction. And after delivery, it leads to unessential referral in agony of cervical cyst or mass. So my take-home message that early pushing urges is still misunderstood, and in a busy setup it tend to lead to unnecessary panic in obstetrician mind, and very limited evidence existed on this optimum for this condition and optimum management of early pushing.
Thank you, Dr. Sarika. We'll take questions at this.
Yeah, please.
Dr. Kalpana, Dr. Nidhi. Any questions?
Hello, Dr. Sarika.
Yeah.
This swelling of the cervix occurs in mild degree of CPD also, but it can never. Is it always taken as unnecessary referral, or in setups like periphery where doctors are not working, ANMs and staff nurses are working?
Ma'am, this referral was from a secondary care hospital where the gynecologists are available. So in they can keep the patient under observation because her vitals were complete. For my case, I'm defining for my case that patient was having completely normal vitals, and on per speculum examination there was soft cystic granular mass, which can be means for a hour, at least for at least 2 hours they can keep the patient under observation. So that was my view.
I wanted to know whether the message, take-home message which you are giving, should it be universalized to all, or it should be only specific to your case?
Only, no, not my specific to my. It should be only for those candidates who are presenting with normal vitals at the referral site. If patient is having any deteriorated vitals, then patient can have some spontaneous hemorrhage or something else. Then they should be referred.
Thank you, Dr. Sarika. We move on to Dr. Aditya. Dr. Aditya Pati. Are you there?
Yes, ma'am.
Yeah, Dr. Aditya.
Am I audible clearly? So I'll start sharing my screen, ma'am.
Yeah. I can see you have Takayusi's as arthritis in pregnancy.
Yeah, ma'am. Is my screen visible, ma'am?
Yeah, it is visible. Yeah. Go, start.
Okay. Good morning, judges. I'll be taking you through a case of Takayusi's arthritis in pregnancy masquerading as severe preeclampsia. A 30-year-old G2P1L1 female at 32 weeks 4 days presented with uncontrolled hypertension and underwent emergency C-section in view of uncontrolled blood pressure and suspected aberration, delivering a preterm 1700-gram female baby. Intraoperatively, placental abruption was noted, and the baby had a good Apgar score. Postpartum persistent hypertension warranted evaluation for secondary causes of hypertension and renal artery Doppler and CT angiography, by the help of which Takayasu arthritis stage 4 was diagnosed. And with the ETA score of 9, prednisolone and azathioprine was started, and a strict antihypertensive regimen of alpha blocker, beta blocker, and diuretics. The blood pressure was very much under control, and a coronary angiogram with EVAR is planned in the remission phase of the disease. So my take-home message will be thorough cardiovascular examination of gravid female presenting with uncontrolled hypertension, and overall development of maternal health should be our goal. Thank you.
The questions from the judges, please.
Okay, Dr. Aditya, it's again a very good case. I just wanted to know, hello, am I audible?
Yes, ma'am, you're audible.
Yeah. Now what? Now that she has this chronic hypertension because of renal artery, now how you're going to plan her next pregnancy, and what contraception are you going to advise?
Ma'am, currently, pre-conceptual counseling is mandatory for this case. So as the disease activity is very high, we are planning to continue the treatment with prednisolone and azathioprine, and after that she will undergo EVAR, and then after a gap of 1 or 2 years, we are planning to counsel her for the next pregnancy if she wishes it.
Okay. So which contraceptive you think would be beneficial for her?
Ma'am, copper.
The MSC criteria, WHO MSC criteria.
Ma'am, copper T will be better, ma'am.
You think copper T will be better?
Yes, ma'am.
Thank you.
Thank you, ma'am.
Any other questions? The rare case. Any other questions from judges? Okay, no questions. Thank you, Dr. Raja. So, sorry, thank you, Dr. Aditya.
Thank you,
And
ma'am.
can we move on to Dr. Nishtha? Dr. Nishtha Handa?
Yes, ma'am. Good morning, ma'am.
Yeah, good morning. Dr. Nishtha is going to present pregnancy after uterine artery embolization. Okay, can we have your screen, please?
Yes, ma'am.
Yeah, start quickly.
Ma'am, can I? Okay, ma'am. Good morning, everyone. I am presenting my poster on the topic pregnancy after uterine artery embolization, a rare case report. I'm presenting the case of 28-year-old Paravan Livan Abortavan female who came in the OPD with complaints of pain in lower abdomen for 4 years and abdominal mass since 2 years. She had no change in menstrual habits. On examination, there was an 18 to 20 week abdominal pelvic mass, irregular with smooth margins, non-tender, and lower end of the mass could not be reached. On parvaginal examinations, the findings were confirmed. On further investigations, there were large intramural fibroids, 2 large intramural fibroids, one in the right lateral myometrium and 8 into 7 centimeters, and one in the right lower myometrium, 7 into 6 centimeters, respectively, and multiple other small intramural and submucosal fibroids. Patient was put on medical management but did not respond. Then patient was counseled for surgical management as well as UAE, but patient opted for UAE. Patient underwent bilateral uterine artery embolization. Immediate post-op period after UAE was uneventful, and on follow-up after 3 months, the fibroid size had decreased to 5 into 4 centimeters and 3 into 2 centimeters respectively. To our surprise, after 3 months, a patient presented with amenorrhea of 6 weeks and a live intrauterine pregnancy was confirmed on ultrasound. Investigations in an antenatal investigations and in level 2 scan we saw a slight increase in the size of fibroids, largest being 7 into 6 centimeters, and but normal color Doppler parameters for the rest of the pregnancy. There was no degeneration of fibroids seen during the antenatal period. She was put on luteal phase support in the first trimester and the progesterone support in the rest of the pregnancy with tablet acosprin also. Patient was taken for elective LSCS at 37 weeks in view of oblique lie. In the intraoperative findings, there was large intramural fibroid, 7 into 7 centimeters in the right lateral wall with multiple seedling fibroids, as well as a small fibroid 6 into 5 centimeter in the lower uterine segment. Therefore, a vertical segment incision was given, which was slightly oblique and extending into the upper segment. 2.7 kg healthy baby was delivered as cephalic, and patient withstood the procedure well. There was no PPH, and post-op period was also uneventful, ma'am.
Okay, the questions. Dr. Kalpana, Dr. Anupam, Dr. Patra, any questions for her?
Nishita, now since the fibroid was reduced in size by anterior artery, uterine artery embolization,
Yes,
do you think now you had during this cesarean section the opportunity to open the abdomen, a myomectomy should be done simultaneously?
Ma'am, that was a thing that was considered then, but ma'am, it was very recent in the literature, and then ma'am, it was the surgeon's choice, and ma'am, she did not go ahead for the myomectomy. That was a dilemma that we were in, that whether we should go and should not go. But now the literature has come then, and we should proceed for myomectomy in the similar setting of the cesarean section, ma'am.
Do you think myomectomy is going to be safe during LSCS, during the cesarean section?
Yes, ma'am. There are studies which have shown that in a carefully selected patients, ma'am, myomectomy has no extra, ma'am, comorbidities or post-operative complications in patients when it is done in patients along with LSCS, ma'am.
Any questions on the uterine artery embolization choice, ma'am? Dr. Sharda?
Yeah, thank you.
Dr. Sharda?
No, ma'am, no questions.
Okay. So thank you, Dr. Anishta, and we will move on to Dr. Monica Kanyal. Dr. Monica, are you there? Dr. Monica? Dr. Monica?
Good morning, ma'am.
Yeah. Dr. Monica will be presenting a classical cesarean section for a large cervical fibroid, right?
Good morning, ma'am. My patient was a 33-year-old gravid to para-1, living 1, 37 plus 4 weeks with previous LSCS 2 years back with transverse lie with hypothyroidism, and she was referred to our hospital because she has a large cervical fibroid of around 10 into 9 into 7.7 into 12 centimeter. So the decision for an emergency cesarean was taken, and intraoperatively the uterus was enlarged with cervical fibroid of around 10 into 12 centimeters involving the anterior lobar-uterine segment. Bilateral adenics were completely normal. So a decision for classical vertical incision was taken, and it was given on the uterine fundus. Baby was delivered as speech, which cried immediately after birth, and uterus was closed in 2 layers. Bilateral tubal ligation was also done by modified Conroy's technique. 1 unit TRBC was transfused intraoperatively. Postoperatively, she was fine, and she was discharged on day 8 after suture removal. Since then, the patient is on regular follow-up.
Questions?
Dr. Monica, supposedly this patient was bleeding. There was torrential hemorrhage. So what kind of hysterectomy you are going to do in this patient? Are you going to go for a total hysterectomy or a subtotal hysterectomy? Because she's having a cervical fibroid.
A total hysterectomy can be planned.
Dr. Monica, are you able to listen to me?
Yes, ma'am.
Supposingly, if we require a hysterectomy in this case because of hemorrhage, what type of hysterectomy you are going to proceed for?
Ma'am, I think a total hysterectomy will be good for this patient.
Yes.
Because
it is a cervical fibroid.
Yes, ma'am. And the patient has also completed her family, so we can give her the option of total hysterectomy.
Total hysterectomy. Okay.
Any more questions? Dr. Anupam?
Dr. Monica, since she has completed her family, did you do ligation for this patient along with this cesarean?
Yes, ma'am. Bilateral tubal ligation was done for the patient.
Suppose she had not completed her family. What type of contraception would you have advised for her?
Ma'am, barrier contraception can be advised for her.
That has a significantly high failure rate, and
Yes.
in case she gets pregnant.
Yeah, yes, ma'am. And I used DMPAs can also be advised to her, and we can also give her contraceptive pills.
And what about the use of PP-IUCD in such patients?
Cases when we are expecting bleeding intraoperatively, sometimes we refer the patient to an interventional radiologist pre-op.
These patients have high risk of bleeding. They have high risk of postpartum
high risk of bleeding. Sometimes we refer them to interventional radiologist. Do you think we can go for such type of a reference in this case?
Yes, ma'am. If the patient is bleeding intraoperatively,
like in the last case, we have discussed about uterine artery embolization.
Uterine artery embolization can be done for this patient if she, and if she does not want fertility further in her life.
Any further questions? Thank you, Dr. Kalpana. Now I'd like to invite Dr. Pancham Preet Kaur.
Hello.
A very good morning to all of you. Good morning, judges. I will just share my screen.
Yeah, Dr. Pancham Preet is going to present a poster on maternal hyponatremia leading to neonatal seizures, a case series and review of literature.
Is my screen visible and I'm audible?
Yeah, it's visible and you are audible. You can start.
Yeah, thank you. So I will just take you through the case series of 3 cases who the mothers had maternal hyponatremia, which was diagnosed retrospectively in 2 of the cases, which presented in the neonatal form in the form of neonatal seizures. So out of the 3 cases, 2 were in spontaneous labor with Robson's classification of 1, and case 2 had was in Robson's 2. And oxytocin was not delivered in any of the cases except in case 2, that too in the low dose form. I just brushing through as you can see through the slides, we gave Entonox in case 2 and the intake output charting was maintained in all the 3 cases. The first patient was asymptomatic, second was a bit drowsy, and also she was given Entonox, and the third presented with postpartum seizures. She came in spontaneous labor, progressed spontaneously, had an uneventful delivery, and immediately after 15 minutes of delivery, she had seizures. And she was all were low-risk mothers. And when we saw postnatally, all the 3 babies at 7, 5, and 4.5 hours of life, they had neonatal seizures. When investigated, they were found to have significant hyponatremia. And in case 1 and 2, when we retrospectively saw the sodium profile of the mothers, both the mothers were having hyponatremia of 122 and 124. And surprisingly, at 122, the patient was really asymptomatic. So going through the literature, we found out that hyponatremia is seen in 26% of laboring mothers. And also it has been observed, as RCOG has recently, they brought out a guideline which shows that if the intake output balance is like, if the deficient, hello, anyone is saying something?
No, nothing. Go ahead.
No, go on.
So if the balance exceeds 1500 milliliter of the positive balance, it results in 26% of the mothers showing the hyponatremia, and the incidence gradually reduces to 1% and 5% if the balance is 1.5 liter and the 1 liter. So in our case, it was like adequately maintained, and we were surprised to see hyponatremia in all the 3 cases. Also, we would like to point out that low dose intosinone should be given in normal saline if at all it is contraindicated otherwise. And oxytocin has slight antidiuretic properties, as observed before, because of the structural similarity to the antidiuretic hormone also. So, but in the low dose form, it is it should not cause hyponatremia. And Entonox use may mask the early signs of low sodium levels, and we should have a low threshold for seeing the signs of this.
Okay,
so,
we'll take the questions.
Yes, sure.
Yeah, Dr. Pancham, what are the babies now? Are they fine? And the mother baby?
Yes. All the 3 babies are fine. The second one had an MRI brain, which was normal. And all 3, they didn't have any recurrent seizures. They were managed with normal saline of 3% as per the body weight of 1 milliliter per kg. And all 3 are doing well.
This is quite interesting because see, we often do not come across such cases, you know.
Yes.
I mean, going retrospectively and doing the electrolytes and how, I mean, what was the interval of these cases? Like, did you get it consecutively 3 cases?
These were over a span of 1 year.
In 1 year, you got 3 cases such.
Yes.
And any antecedent cause you could find out in the mother?
Yes. What we believe is like, see, in I will just share my screen again. So in the first case, there was no cause, like 300 and 500 intake. She had 6.5 hours of the first stage. There was no cause in the one. But yes, according to the literature, it has also been seen that its incidence increases in instrumental deliveries. So maybe that can be associated, but that cannot be the cause of hyponatremia. So that is just a causal reference. Also in case 2, we can say because of the intravenous fluids of 2150, that was like, yes, and the oral fluids, we don't have a proper charting, so that can be the reason that proper intake output of isotonic fluid should be maintained rather than giving only water and clear fluids. So because
Dr. Pancham,
yes,
I wanted to know whether she had some underlying condition, some
that
underlying medical condition. That is what Madam wanted to know.
I wanted to know that.
Disease. Usually kidney patients or some underlying heart ailment leading to electrolyte imbalance.
Even maternal dehydration can cause, but not such electrolyte imbalance. Like one case 3, I can see her sodium is 113 and she was symptomatic also.
And usually when we are having hyponatremia patient, they complain of intractable nausea and vomiting.
Yes, but all the 3 patients,
we cannot treat.
Yes, but all the 3
patients, did you have any such kind of symptom?
No,
nausea, vomiting?
Not at all.
Usually these are hyponatremia patients.
I mean,
they come with vomiting and which does not respond to even ondansetron.
No, not at all.
That is why, yes. Hyponatremia needs to be corrected and only then the vomiting is going to subside.
Yes, but not at all.
You did not have any such symptoms.
No.
That's quite interesting. I mean,
So
should be looked upon.
So now what have we done as when we saw
But
these
this
cases?
hyponatremia led only to neonatal seizures.
No, in
It
case
didn't
The
have
mother
any
had.
symptoms on the
in
mother.
Three
case
also, the mother
in
had
3
seizures.
mother had,
Ah.
and she was in spontaneous labor, nothing. Matlab she came, she progressed, she delivered. It was and she had a second degree tear. There was no episiotomy. She really progressed fast. There was and delivered in left lateral position.
And
So
there was no
very nice.
IUGR. The mothers weren't getting any.
No. All the babies were term and
And
with
you
good,
think this
normal
could be a
size.
transient? This could be a transient hyponatremia?
See, what I
You
feel
think-
is like maybe because these days we encourage clear fluids and so during labor till second stage, right? Because mothers should be hydrated properly. So what we inferred is we should encourage isotonic fluids more so. Like now we have switched over to Gatorade drinks or normal which are isotonic to the mothers. So that has really
And
reduced
what was
the
their
incidence.
profile? I mean, were they from the very low
No.
socioeconomic
No.
status,
They were
nutrition status, malnourished mothers?
No, they are from high profile families.
But I
All
think
three.
symptom 3 of hyponatremia needs more investigations.
Yeah, that's what I'm doing.
So in the babies, they had investigated fully. So nothing. And retrospectively, when we saw all the mothers were the first two, they were doing fine. They were corrected for the hyponatremia because they were asymptomatic. But yes, the sodium levels were less. So we had to correct it so that she should not go into that complication stage. So, but they were doing fine. And the third one, she responded to sodium normal saline. She was given levetiracetam for seizures. Then she was given Maxel because initially we thought that it could be eclampsia. When she threw scissors, we thought it is eclampsia and we gave her Maxel. Although her BP readings were around 120/90, albumin was traced. But when we investigated and hyponatremia was found out, we corrected with normal saline and she responded to that. So the crux was
because hyponatremia, it's an electrolyte imbalance and it's a sign of an underlying disease. I mean, it itself is not a big.
I agree.
That is
but,
what, yeah.
But in labor, it has been seen around 90 to 20 cases since 2002, and 11 cases of neonatal seizures, which have been documented by Moinvi et al. By BGOG, and this is because of the delusional hyponatremia. So there are various factors. In first of all, the oxytocin, instrumental, prolonged second stage,
Oxytocin
prolonged
also
first
because
stage.
Okay, I think the question hour is over now.
Okay.
Thank you so much.
I agree with you. That's why we wanted to report this case.
Yeah, thank you so much, Pankaj. It was a very nice presentation.
Thank you so much. Thank you.
Okay, we move on to Dr. Nitika Pandey. Dr. Nitika, are you there?
Good morning, ma'am.
Yeah, Dr. Nitika, can you share your screen, please?
Yes, ma'am, I'm sharing my screen.
Dr. Nitika is going to present massive ascites in severe preeclampsia, a rare complication.
Good morning, ma'am. My case was a 21-year-old primigravida female with a period of gestation 31 weeks with an impending eclampsia. She was referred from ESI Gelman, and at the time of admission, her blood pressure was 160/110 with the presenting complaints of blurring of vision and headache. On per abdominal examination, her uterus was 20 to 30 weeks, presentation, fetal heart was closed, uneffaced. Her hemogram was 11.5 gram HB and platelet was 63,000. Fundus examination was within normal limit. For the raised BP, patient was given IV Lobate. She has already received Lobate from a previous hospital, and she was also started on injection DEXA for fetal lung maturity, followed by Mexelf. Despite Mexelf and Lobate, the BP was not controlled and decision for termination was taken. On opening the abdomen, there was the ascites fluid of around 500 ml, and a female baby weighing 1.1 kg was delivered. Post-operatively, the BP was on the higher side, and Mexel was continued for the patient. On post-op day 1, her
Sorry, I think we just lost her connection.
Ma'am, on post-op day 2, her drain output was around 900 ml, followed by on post-op day 3, her drain output increased to 2600 ml. Her total protein was around 4.9 gram per dl and albumin was 2.9 gram. And on post-op day 4, again the drain output was around 2400. The patient was started on albumin and followed after starting the albumin, the urine albumin, after starting albumin, the drain output reduced to 300 ml. And after 5 days of albumin, the drain was removed after doing a USG whole abdomen.
Nitika will start the question now. Yeah, Dr.
Yes,
Shah.
ma'am.
Nitika, I wanted to ask, do you think it is a rare complication, massive ascites in severe preeclampsia or HELLP syndrome? I think it is very common to find ascites.
Ascites is common, but ma'am, more than 2 liters of ascites is a rare
it is common. Even we get 2 liters. And do you think we have to insert a drain, intra-abdominal drain to drain out the ascitic fluid?
That's a physiological fluid.
If patient is not symptomatic. If patient is not symptomatic, she is not having any respiratory discomfort, should we drain out the ascitic fluid? Or like you said, you have given her albumin and she responded and her ascites gradually reduced.
Ma'am, in normal scenario, we should not put a drain, but
sorry, your
audio.
Practically, we have put
your
that because.
Voice is breaking.
Ma'am, am I audible?
Yeah.
Yes.
Ma'am, am I audible?
Yeah. Go on.
Quickly go ahead. Answer the question.
Ma'am, prophylactically, we have put in the drain. In the normal scenario, we should not put the drain because ascites will resolve on its own if the patient is not having any symptoms.
Because we have said that there was hypoalbuminemia. Albumin levels were low. And also in severe preeclampsia, there is capillary leak. So we have got excessive fluid in extravascular compartment. We can also have bilateral pleural effusion.
Yes, ma'am.
Yeah. Thank you, Dr.
But chest X-ray was normal. She was only having.
Nitika, do you think there could be any other comorbidity apart from preeclampsia? Like something, I just wanted to add on it. Like, could it be some chronic liver disease, portal hypertension? Because the albumin is very low. In preeclampsia, we don't get such hypoalbuminemia.
Yes, ma'am.
So there
Patient can have a liver cirrhosis, can have tuberculosis also, nephrotic syndrome.
Not in this case, in your case. So we have to look upon the other causes also. As such, albumin levels, I'm not happy with the albumin. 2.1 is too low. What about her postpartum? I mean, did the albumin come up to a normal level after that?
Yes, ma'am. Postpartumly, when we started to give albumin, then only her albumin raised. Before that, albumin was low only. When we given her albumin, then only the albumin level came back to normal.
Okay.
But other disease, ma'am, we have done the LFT also for the patient, but LFT was normal.
It's normal.
Thank you, Dr.
Thank you.
Thank you, ma'am.
We move over to Megha Azmani. Megha, are you there? Hello.
Hello. Good morning, ma'am.
Yeah, Dr. Megha,
yes,
can you
ma'am.
start the screen? Can you share?
Yes, ma'am. I'm sharing it. Just a second.
Dr. Megha is going to present a joint urogyne approach to surgical management of placenta previa percreta with bladder invasion.
My screen is visible, ma'am?
Yeah.
Good morning, all the respected judges. So this is a case report of a 27-year-old female. She was gravida for para 2 life to abortion 1. She came with, she had a history of 1 lower segment cesarean section, and she came to us with at 23 weeks with a complaint of bleeding PV. She had 2 episodes. So considering it to be a warning sign, we admitted her and we did an ultrasound for her. And in the ultrasound, it revealed central placenta previa with morbidly adherent placenta, and there was involvement of bladder with the presence of bladder clots, as we can see in this figure. So there was involvement of the bladder here. And so to confirm it, we did an MRI also. In the MRI, there was a disruption of zone between the uterus and the bladder. So indicating that it was a placenta percreta with the involvement of bladder. So we tried to manage her conservatively for about a period of 1 week, but she developed frank hematuria. So we did a bladder irrigation for her for the clots removal, but because of the drop in the hemoglobin levels and decline in her blood parameters, we decided to take her for emergency laparotomy at 24 plus 3 weeks POG. And we took a urology assistance for her. We did a cystoscopy for bladder clots removal, and then a decision for emergency hysterectomy was made. So bladder was advanced and pulled up. As we can see here in this image, there were dense bladder adhesions which were present in this. So there was torrential bleeding which could not be controlled. So we decided for a subtotal hysterectomy, and in order to achieve hemostasis, bilateral internal iliac artery ligation was also done. So we even did an intentional cystotomy for bladder clot evacuation, and ureterostomy was done with bilateral DJ stenting, and bladder closure was done. So intraoperatively, approximately 5 liters of blood loss was there, and multiple blood transfusions.
Megha, can we have the questions now, please? Questions, Dr. Anupam?
Dr. Megha.
Yes, ma'am.
Yeah. What intraoperative complication you think we could, encounter?
Intraoperatively, there could be, as already placenta prurita is there, so bladder involvement was one such thing. Then there would be ureter injury could be there. Then massive blood loss was there. Then history of massive blood transfusion. When we give that could lead to complications of massive blood transfusion like trally. Then she also have hypotensive shock.
Because I can see, I think there was 5 liters of blood loss.
Yes, ma'am. Approximately 5 liters was lost. Yes, ma'am.
Dr. Megha, you did not mention, did you deliver the baby or not?
Yes, ma'am.
They took out the fetus.
But,
Yeah.
It was.
What incision did you give? What
That's
type of incision did you give on the uterus?
Ma'am, away from the uterus, a transfundal incision was given, like posterior.
Transfundal vertical incision you used.
Yes, ma'am. Yes, ma'am. But the baby was a 23-weeker, so there was already attendance where prognosis was explained.
Yeah, Dr. Megha, before embarking on this, do you think there's a role of internal iliac ligation? Because I could see the blood loss is very, very high.
They've already done
No, previously
You have done that?
stage.
You have done that internal iliac before?
Yeah, they have done the internal.
Yes,
Okay.
we have done internal
But
iliac
still
ligation.
she bled.
But still she bled, yeah. That's why she was sent to ICU also for about 1 day, but she recovered well. And she was sent home with a Foley's catheter in situ for about 3 weeks because of the bladder involvement.
Dr. Megha, I wanted to know, because it was a case of placenta accreta, so you must have left the placenta in situ.
Yes, ma'am. Placenta was left in situ, and then subtotal hysterectomy was done.
It was done. Okay. So did the placenta bleed or not? Sometimes the placenta bleeds. There is torrential hemorrhage from the placenta, because we had such case 7 to 10 days back. It was a twin pregnancy with a 28 weeks pregnancy. One placenta we could remove, but the second placenta, it was densely adherent. It was perquita. So we had to leave the placenta. We did a subtotal hysterectomy, and patient was in bad shape. There was at least 5 liters. She had total loss of blood, 4 liters of hemoperitoneum we had. So what we did was we left the placenta in situ, and we took mattress sutures, and we opposed the anterior and posterior uterine walls.
Okay, ma'am.
But I think, Dr. Kalpana, in this case, the patient already had bleeding from the bladder. She was having hematuria.
Yes, ma'am.
Yeah,
She was
that's why they had removed everything into
everything, yeah, including the bladder was also clots were removed from the bladder also.
Yeah.
And ma'am, similar case we had also here also in 1 week back. We did a uterine artery embolization for that patient, but still she bled massively. Initially, we left the placenta in situ, thinking it to be preserving her uterus, but within 1 day later, she bled massively. So we have to take her for a re-laparotomy. In despite of doing uterine artery embolization for that patient, we need to open her again.
Thank you, Dr.
No, because you had already called a urologist, I wanted to ask one thing.
Yes,
you could have proceeded for a total hysterectomy.
Yeah.
Because you had a urologist, he could have separated the bladder, done and repaired the bladder. Sometimes we don't have that much time.
That. No, they have removed the bladder, part of bladder also.
Placenta accreta, when it is involving the cervix, because if you are going to do a subtotal hysterectomy, the patient has chances to bleed again, and she might not give you another chance because she's already in bad shape. So in placenta previa, it is better to do a total hysterectomy if possible. Because if we are going to leave the placenta in situ, then she'll always have a chance of secondary hemorrhage, having a bout of secondary hemorrhage.
Thank you, Dr. Megha.
Right.
Thank you, ma'am.
Going to call now Dr. Sonali. Dr. Sonali Barik, are you there? Dr. Sonali?
Hello,
Dr.
ma'am, am I audible?
Yeah, you are audible. Can we have your screen, please?
Yes, ma'am. Yes, ma'am. I'm sharing, ma'am.
Dr. Sonali is going to present uncorrected tetralogy of Fallot with associated preeclampsia, an enigma with management dilemma.
Ma'am, are you able to see my screen?
Yeah, we are able to see. Go ahead.
Yes, ma'am. Respected chairs and my fellow participants, today I'll be sharing my experience of managing an uncorrected tetralogy of fallow patients, which was further complicated by preeclampsia. This tetralogy of Fallot as such is very rare, and it is 5 to 6% cases. It constitutes 5 to 6% of all congenital heart
You
disease.
can go ahead with your case presentation.
Yes, ma'am. This 23-year-old patient, G3P1L1, presented at 37 weeks, 3 days, having uncorrected OFF. She was not in failure and belonging to NYHA class 1 and modified WHO risk category 3. The patient also has stage 1 fetal growth restriction, and it was complicated by preeclampsia. And on clinical examination, as we can see in the figure, she had central cyanosis along with grade 3 clubbing, pan digital grade 3 clubbing, and on cardiac examination she had pansystolic murmur with palpable thrill, and she tested COVID-19 infection negative. She was judiciously managed with IV antibiotics, oxygen supplementation, and IV fluids, and 2D echo also confirmed the tetralogy of fallopathology. Patient was allowed for spontaneous preparation of labor, and she delivered a male baby weighing 1585 grams following forceps application to cut short the second stage of labor. The postpartum period was uneventful, and the baby was in NICU for 3 days just for observation, and the baby also screened negative for CSD. Then CTVS opinion was taken, and the patient was advised to undergo cardiac CT, which again confirmed tetralogy of fallopathology, and the patient was advised to undergo intracardiac repair after 3 months. Now
Judges will take the question now. Judges, please. The questions. Hello, Dr. Anupam, Dr. Sharda, questions?
Yeah.
Can we ask? Hello?
Hello. Dr. Sonali, I wanted to know, she was asymptomatic in her first 2 pregnancies, or did she give any history?
Ma'am, actually, she gave childhood history of dyspnea, but according to her, she does not have any as such history of dyspnea or any activity limitation. She herself said she used to do every like daily activities without any difficulties. She did
So
not
her disease was not diagnosed. It was diagnosed during this 3rd pregnancy.
No, ma'am.
She wasn't
Actually,
undiagnosed.
no, ma'am. It was diagnosed when she was around 12 years old, when she had some history of cyanotic spells in her childhood. But then, ma'am, she does not have any such complaints of
She did
breathlessness.
not have any complications in any pregnancy, so she decided.
That's great. I mean,
Yes, ma'am.
she never
Yes,
needed
ma'am.
any medical attention and all. And this time,
Yes, ma'am. Yes, ma'am. Previous delivery was also
even
vaginal
the
delivery, and
pregnancy was taken up to 37 weeks.
Yes,
So
ma'am.
now
Yes, ma'am.
what? Now what? What is, as an obstetrician, is our duty to do?
Yes,
Are you
ma'am. Actually,
supposed to do to her? I mean,
unnecessarily. Now
she'll again come up with the pregnancy, or what are you going to do to her?
no, ma'am. We have counseled her for contraception, and she agreed for taking
Contraception you are going to advise.
Yes, ma'am.
What
contraception?
Yes, ma'am. Like if it is not complicated with like in such patients, progesterone only pills can be given, and
What about, because she had a normal delivery, no?
Yes,
So,
ma'am. Yes, ma'am.
do you
PPIUCD.
think
Yes,
that we could have given her a PPIUCD?
Yes, ma'am. Yes, ma'am. We could have given. If it is like uncomplicated with hypertension, we could have given copper IUCD. As such, like if the pregnancy is complicated with hypertension, we generally, ma'am, we tend to avoid copper IUCDs, ma'am. But yes, ma'am.
So there is contraindication to a PPIUCD, isn't it?
Yes, ma'am. Yes, ma'am.
Okay. Thank you, Dr. Sonali.
Okay, ma'am.
We move over to Dr. Nirupama. Dr. Nirupama, are you there? Dr. Nirupama Sine?
Yes, ma'am.
Yeah. Can you share the screen, please?
Yes, ma'am.
Nirupama is going to present a case of deep vein thrombosis in mid-trimester pregnancy. Okay, go ahead, Nirupama. Quickly, and then we'll take the question.
Is my screen visible?
No.
Share your screen.
Dr. Nirupama?
Yes, sir.
Yeah, you have a share screen option there. Please click on share screen. Hello.
Hello. Can we move to the next speaker, please, in the meanwhile?
Yeah, ma'am.
Dr. Teshengla, are you there? Dr. Teshengla?
Hello, good morning, ma'am. Yes, I'm here, ma'am.
Yeah. Can you share your screen?
Of course, ma'am. I'm trying to share my slides.
Yeah. Dr. Teshengla is going to present meconium peritonitis with non-immune high drops.
Now it will come. Slide. Just make screen.
Yeah.
Okay, ma'am. Ma'am, is my full screen visible?
Yeah, it's visible.
Yeah.
You can go ahead.
Okay, ma'am. So good morning, all chairs and my fellow presenter. Today I'm going to present a rare case, which is meconium peritonitis with non-immune high drops, a rare case. So I'll go directly to my case presentation.
Yeah.
22-year-old primary gravida at 31 weeks gestation was referred with preeclampsia, fetal ascites and polyhydramnios diagnosed at 28 weeks. Ultrasound showed AFI of 32.1 centimeter and fetal NIHF. Now the fetal ascites was turbid with calcifications on the intestines and undersurface of liver, suspicious of meconium peritonitis. Hydrops fetalis evaluation ruled out isoimmunization, fetal anemia, torch infection, fetal cardiac anomalies, as all the aforementioned tests were normal. Patient was discharged at 32 weeks after antenatal steroid cover and was planned for a weekly follow-up. However, she defaulted and presented at 34 weeks gestation, in this time in established preterm labor. She went on an emergency cesarean delivery for non-reassuring fetal status, and an asphyxiated hydropic female baby weighing 2.73 kg was delivered. The baby had respiratory distress syndrome, received surfactant, and was put on mechanical ventilator support. And postnatal NCCT abdomen confirmed meconium peritonitis, for which the baby underwent exploratory laparotomy on day 7 of life, where ruptured large meconium cyst with hemorrhagic fluid was seen. So resection, adhesiolysis, and end-to-end ileocolic anastomosis was done with placement of PVC drain. Incidentally, the mother had significant ascites intra-op, and upon evaluation was found to have chronic liver parenchymal disease with portal hypertension and esophageal varices. After 2 months of follow-up, the infant demonstrated normal growth without any gastroenterological complications. So the differential diagnosis of our case.
Yeah,
Yes, ma'am.
we'll take on the questions.
Yes, please, ma'am. Yes, ma'am.
Yeah, Dr. Sharda, Dr. Kalpana.
Yeah.
Is Dr. Anupam Nidhi there? I can't see her.
Yes, ma'am.
Dr.
I'm there, ma'am.
Yeah, any questions? Any questions? Quickly, we have 2 minutes.
Any questions, judges, please?
Dr. Teshengla,
yes, ma'am.
I mean, what do you, expect in the baby now? I mean, what the baby is going to behave in later life with these kind of presentation?
Ma'am, actually, we can this after postnatally 2 months of follow-up we have done, and there was no gastroenterological complication. So probably we can expect gastroenterological complication in this baby. Like she can have this following bowel obstruction or case of volvulus, unknown idiopathic bowel perforation again, because meconium peritonitis can result from all these causes. So basically we can expect.
What could be the cause of this meconium peritonitis? I mean, why the baby? Of course, it could be a mirror syndrome.
Yes,
I could see because hydrops is there.
Yes,
but what is the, prognosis for this baby? Any genetic ailment, any genetic disease that we have ruled out?
Ma'am, actually, we have cystic fibrosis can cause this meconium peritonitis, but according to literature, as I've mentioned in the slide also, cystic fibrosis is rare in Asian population. So at the time this report we have sent, the licensing report is still pending. So this acts as a limitation in my case, but still in the literature, in Asian population, cystic fibrosis is very rare. However, in case of Western literature, 40% of the cases can be because of cystic fibrosis. And in any case, we have to rule out cystic fibrosis.
Yeah,
Can I ask
that's
a
what I wanted to know.
I just wanted to know, you said the patient was lost to follow up.
No,
Would
no,
our
ma'am.
management, no, in between it was lost. I mean, she did not turn up, but would
Yes,
our management change based on our findings?
Ma'am,
still remain the same. I mean, we couldn't have helped her then, and we couldn't have done it.
Yes, ma'am. The only thing is that if we can, if she presented to us every weekly, our only aim was also to monitor the increase in ascites, the increase in polyhydramnios, and the condition of the baby, so that we can keep the patient in our track only, ma'am.
She's a primary gravida, I
Yes,
think.
ma'am. She's a primary gravida.
Yeah, and she's 22-year-old.
22-year-old.
And at 22, she has this cirrhosis and everything. That's what I.
Cirrhosis is not there, ma'am.
Liver disease.
Chronic liver disease
yes,
is
ma'am.
there.
Yes, ma'am. After postnatal, we have evaluated her for secondary causes of hypertension, where in ultrasound we have done, and spleno-hepatoportal axis, and then CT scan was also done. All this shows features suggestive of chronic parenchymal liver disease with features suggestive of portal hypertension also.
Thank
There yes, ma'am.
Thank you, Teshila.
Thank you,
so
Teshila.
much. We'll move
Thank you,
over
ma'am.
to Dr. Gabita Sampanna. Are you there, Dr. Gabita Sampanna?
Ma'am, how can I share my screen?
Yeah, you can share your screen. Gabita is going to present myomectomy during pregnancy. Earliest but possible. I like that.
Yeah.
Okay.
Yes, but possible.
Yeah. I'm a great proponent of myomectomies.
During pregnancy.
Okay, Gabita, can we have your screen, please? Two surgeries versus one. I would rather have one.
I know there are two schools of thought.
I know every time.
Some do not want to touch it.
Dr. Gabita?
Are you able to share your screen, Beta?
Hello.
Hello.
Dr.
I think we
Gabita?
are having problems with screen sharing a lot today. Dr. Gabita?
And we should move to the next one.
Yeah. Dr. Meenal, can we have your poster in the meanwhile? Dr.
Yes, ma'am.
Yeah.
Am I audible, ma'am?
Yeah, you are audible. Can we have your screen, please, Beta? Pregnancy following augmentation cystoplasty, a course of 3 pregnancies.
I think Dr. Gabita is sharing her screen.
Are you there? Who's going to start, Meenal or Gabita?
Ma'am, I'm not able to share my screen because I think Dr. Gabita has started sharing hers.
Okay, okay, we'll call you. Okay, Gabita, you can go ahead.
Dr. Gabita?
It's still not visible.
Maybe there is some issue with the network.
Okay, then we go ahead with you, Meenal.
Yeah.
Yeah, Meenal, you can go ahead with.
Ma'am, is my screen visible?
No, yeah, now it's visible. Yeah, go ahead quickly.
Yeah. A very good morning to one and all present here. I am here presenting my case on pregnancy following augmentation cystoplasty by following a course of 3 pregnancies in a woman. Introducing briefly, augmentation cystoplasty is a procedure involving utilization of bowel segments to increase capacity in case of defective bladder function. Briefly summarizing my case report, my patient, 26-year-old with a history of augmentation cystoplasty in childhood, had her first pregnancy 6 years back when she presented with pyelonephritis preterm labor and was managed conservatively. Her second pregnancy was 3 years back when she presented with 3rd-degree uterovaginal prolapse and was managed with a silicone ring vaginal pessary. She presented with hematuria and preterm labor and therefore the pessary had to be removed and reinserted 3 days after delivery. Her third pregnancy, which was an year back, the silicone pessary was removed prophylactically at 28 week itself. Still, the woman presented with hematuria, preterm labor, as well as bilateral moderate hydronephrosis. She was managed conservatively, and in all the 3 cases, she delivered vaginally, and all the babies are alive and healthy. Coming to the discussion part of this rare event, in our case, the pregnancy was complicated by a uterovaginal prolapse, making it a further rare case scenario. Our patient, since she hadn't completed her family and was unwilling for corrective surgery, therefore it was a viable option to manage her prolapse by a pessary. Coming to the hypothesizing why she presented with hematuria, earlier we thought that in her second pregnancy, this hematuria was due to the pressing of the fetal head on the bladder wall and therefore leading to hematuria. But in the third pregnancy, she suffered from that condition again in spite of the removal of pessary. Therefore, it was hypothesized that the hematuria was due to the descent of the fetal head pressing on the distended bladder venous channels. Analyzing.
Okay, we'll take the questions now.
Yes, ma'am.
Yeah, any questions?
What's the age of the patient? 26. At 26, she had augmented cystoplasty.
No, ma'am. She had augmentation cystoplasty.
At the age of 11 years.
Yes, ma'am.
So it could be something related to some muscle weakness, congenital, that's leading to this dysfunction and prolapse also.
Yes, ma'am. It could have, ma'am, patient ma'am, the surgery of augmentation cystoplasty was due to the bladder injury because patient fell from a bicycle at the age of 11.
Okay.
And therefore, due to the faulty innervation due to the surgery at that time, and as the vaginal delivery itself predisposes the patient to a prolapse, therefore, she might have suffered this condition in the second pregnancy.
No, but at 26 and 1 pregnancy, why would she have this prolapse? No.
Did she have any fractures or anything, any injury
leading to just, I mean, what's the cause of prolapse?
Ma'am, the pelvic musculature, the innervation, as well as the vaginal supports maintain the complete pelvic architecture of a female. So, in case she went complicated surgery of augmentation cystoplasty, which might cause her nerve damage in the patient, which might be predisposing her to prolapse. And she did not develop prolapse in the first pregnancy. She developed it subsequently in the second pregnancy. Vaginal delivery.
Dr. Meenal, what madam wants to know is, did she have some collagen disorder?
Yeah,
usually
any Ehlers-Danlos syndrome.
Usually in primary gravida, we don't have
such
prolapse unless her labor has been mismanaged. Unless the labor has been, so she might, and because you are saying that bladder augmentation cystoplasty was done, so we are going to have prolapse if the pelvic nerve system, pelvic nerves, they are damaged. Usually the prolapse is because of collagen disease, some collagen disorder,
Ehlers-Danlos syndrome,
deficiency, some estrogen deficiency.
Into
considering the accident, she had some problem.
Or she had some prolonged second stage of labor.
Yeah.
Or some mismanaged labor.
How do you describe her this prolapse? Yeah.
That is what madam wanted to know. Did you
and
evaluate
the cystoplasty, I don't think is going to affect her pregnancy.
Cystoplasty is not going to lead to prolapse.
Yeah.
She was unfortunate to have a prolapse.
Yes,
after having augmentation cystoplasty. No. So did you evaluate her? Why did she have prolapse? Or she had a mismanaged labor during her first pregnancy.
Okay.
She was delivered by a midwife. She was given fundal pressure. Or she had a prolonged
and that too, she had a third degree uterine prolapse. Yeah. And any divarication of the recti, anything, what is a walk? I mean,
and what type of prolapse she had?
Third degree likha hua hai.
Paravaginal, no. The defect, did she have a cystocele?
Yes, ma'am. She
was a central compartment defect or a paravaginal defect?
Paravaginal. Third degree she is written.
Also have idea what type of defect it was, paravaginal or the central. The rugosities were there. We can know whether it was a paravaginal or a central compartment.
Why, Dr. Meenal, we are asking these questions? Because because she's very young. Now she already had this bladder repair and everything. But now again, you have to look upon her prolapse case, isn't it? Because she's very young. And at this age, she already had 3 pregnancies.
Yes, ma'am.
Now we'll have to offer her a solution. That is what they're saying. What solution will you offer her now?
Yeah, that we are.
Ma'am,
and usually, Meenal, usually what happens, the patient who is having pelvic surgery, she develops adhesions, and it then
Prolapse
usually
will not
prevents prolapse. So what type of prolapse
She
it was?
must be
There was
having some muscle
or
weakness
she had
or
some
something like
cervical
that.
elongation. You did not mention the type of prolapse she is having. Whether
She's
it was
written
cervical
3rd degree.
elongation.
She's written 3rd degree uterine
Third
prolapse.
degree, yeah, third
That
degree
means
uterine prolapse.
cystocele,
What is
rectocele.
Cystocele, rectocele was there?
Ma'am, she was associated with cystocele. I forgot to mention it.
Yeah,
Okay.
you should
And
have
what
been
type
very
of-
specific. Yeah.
Yes, ma'am.
And what type of defect it was? You did not mention.
That's what Dr. Kalpana is asking. No, whether it's a paravaginal, then the anterior vaginal wall will come down. Without the cystocele, only the vaginal walls will get relaxed.
Yes.
And that is, I think that could happen with this type of cystoplasties.
Okay.
Yes, ma'am.
Sorry, we are running short of time. Thank you, Dr. Meenal.
Thank you, ma'am.
And we move on to Dr. Divya. Dr. Divya Kanwar. Are you there?
Yes, ma'am. Yes, ma'am.
Can we have your screen on, please? Dr. Divya is going to present cholangitis in pregnancy in a rare case of maternal near miss.
Yes, ma'am. I'm trying to share my screen, ma'am.
Yeah. No? Any problems?
Yes, ma'am.
Hello, डॉक्टर दिव्या
Yes, sir.
मैम वहाँ पे शेयर स्क्रीन का ऑप्शन आ रहा होगा राइट नीचे
Yes, sir. Sir, yes, sir. I have clicked on that icon.
मैम आपके पास ऑप्शंस आए होंगे कि आपको क्या क्या शेयर करना है
Yes, sir.
तो उस पर आप क्लिक करके शेयर करेंगे
Yeah.
Sir, I think there's some problem.
First, you have to open your presentation.
Yeah, that's it. It's coming. It's coming. It's okay.
Coming, ma'am?
Yeah.
Yeah, yeah. Enlarge it, enlarge it.
Enlarge it a little bit. Yeah. Go ahead. Start.
चला क्या?
बेटा पहले आ रहा था.
हाँ, ठीक था.
The other tab. The other tab. Move to the other tab.
Yeah.
Yes. Go ahead,
Enlarge
go ahead.
it. Enlarge it.
That's okay. That's okay. She enlarges and it goes. Go ahead. Go ahead. Start presenting, bete.
Ma'am, I'm presenting a case. I'm presenting a case of a 29-year-old female, G3P1 L0A1 with 32 plus 6 weeks of gestation, with jaundice, with history of laparoscopic cholecystectomy, followed by CBD stenting 2 years back in 2018. She presented to our casualty with complaints of breathlessness, fever with chills, and epigastric pain since 1 day. The patient was unable to maintain saturation on room air and even on oxygen, and so she had to be shifted on BiPAP. She was kept nil per orally and given total parenteral nutrition for 3 days because she was unable to tolerate orally. Her liver function tests were deranged and serum and amylase levels were raised. Patient's respiratory symptoms were suggestive of ARDS, but at the same time, we had a high suspicion of COVID also, for which we sent her nasopharyngeal swab for RT-PCR, which came out to be negative. Finally, a diagnosis of cholangitis associated with ARDS was made after the initial evaluation. Chest X-ray was done, and which is suggestive of bilateral pleural effusion and ARDS. USG whole abdomen was suggestive of dilated CBD with stent in situ with an echogenic sludge, which was most likely due to cholangitis. A multidisciplinary approach was taken, medicine and anesthesia opinion was taken, and it was concluded that the patient's lung condition was due to her cholangitis, and uterine decompression in this case will not help. We sent her blood culture, urine culture, pleural fluid cultures also, and they were suggestive of E. coli, which was sensitive to piperacillin and tazobactam, on which the patient was started, and patient improved symptomatically. Finally, MRCP was also done, which was suggestive of obstructive biliopathy, query stricture of distal CBD. There were multiple ill-defined focal hepatic lesions in the left lobe of liver. And in this clinical setting of cholangitis, the findings were likely suggestive of cholangular abscess. Ma'am, from this case presentation, my conclusion was that in such cases of maternal near miss, we can give a trial for conservative management. It's not that when a patient presents in such situation, we always
have to
terminate. We have to terminate the pregnancy immediately.
Okay, we'll take the questions now from the judges.
How is the patient now?
Ma'am, patient delivered 1 week back by normal vaginal delivery. We at 37 weeks of gestation, we induced the patient with Cerviprime gel, and after.
Why you induced? What was the indication?
It was a high-risk pregnancy. She had deranged LFTs.
Oh, okay, fine. And what are the
She was
LFTs?
still having delay. You said you managed conservatively.
Yeah,
and then
and she was
improved.
fine, and
No,
she went.
Even at 37 weeks, her LFT were deranged. Supposingly, if you are not having deranged LFT, then was there some other obstetric indication for preterm delivery? Usually, we wait for 38 or 39 weeks to be completed before we proceed for induction.
Because she had cholangitis, there
Why
was
did you
abscess,
do?
and she came out of it.
Yes, ma'am, she
So
came
what was
out.
the
And you
indication
are
for
saying now,
induction?
Ma'am, no, there was no other high risk apart from this. Patient did not develop any other comorbidity like usually.
Then at that time, she is just like any other pregnancies, isn't it? Cholangitis was an event.
Yes, ma'am. It was an event because she was already predisposed because of a significant surgical history.
There was a stent inside, so there was an
Yes,
infection
ma'am.
that you
Yes.
controlled. She was fine, and that's why she was sent home. And
Yes,
when the patient was discharged, what were her LFTs?
Ma'am, when the patient was discharged, her LFTs were borderline, ma'am.
I mean, what is borderline?
Ma'am, like her SGOT and SGPT were, ma'am, SGOT was 96 like this, and SGPT 100, and her alkaline phosphatase was I think, ma'am,
What about
200.
the markers, viral markers?
Ma'am, viral markers were non-reactive, ma'am.
She was negative for that.
Yes, ma'am.
What was the bile acid like?
Bile acids, biles.
Ma'am, bile acid was also within normal range. We thought that maybe she would develop IST.
Cholestatic,
but it was not that, ma'am. We did bile acid, but it was normal. It was below 10.
Thank you, Dr. Divya. Thank you for your presentation.
Thank you.
Now we move over to Dr. Manisha.
Yes, ma'am.
Yeah, Dr. Manisha, can we have your presentation on the screen, beta?
Yes, ma'am. I'm trying to share this. Ma'am, is my screen visible?
No, it is not. Dr. Manisha has bromocriptine and novel management in peripartum cardiomyopathy. Now that's interesting.
Yeah, that's very interesting. I wanted.
Yeah, that's very interesting. Come. Okay, go ahead, beta. Manisha, we can see you. Go ahead. You have 2 minutes.
Okay, ma'am.
Present your case here.
Ma'am, my screen is visible now.
Yeah, it's visible. Go ahead.
Ma'am, my patient is a 29-year-old lady, gravida 3 para 2 living 2 with 28 weeks period of gestation, came to the casualty with complaints of breathlessness and history of raised BP records since 1 week. On the day of presentation to the casualty, her vitals were, pulse rate was 68 per minute, blood pressure was 150 by 104 millimeters of mercury, respiratory rate was 22 per minute, and SpO2 was 98% on room air. Her bilateral chest was clear and urine albumin was +2 and pedal edema was present. She was given labetalol 20 mg IV, after which her blood pressure dropped to 130/94 millimeters of mercury, and she was started on tab labetalol 100 mg TDS. And per abdominal examination, her fundal corresponded to 28 weeks, cephalic presentation, and FHS was present regular 140 beats per minute. One day after the admission, the patient condition suddenly deteriorated. She developed sudden onset of breathlessness, and her pulse rate was 103 per minute. BP blood pressure rose to 160/110, and SpO2 was 88% on room air. And she developed bilateral crepitations in the chest. So she was intubated, given injection Lasix, and she was taken for emergency cesarean section for decompression. A live preterm baby girl was born of weight 900 grams, and she was shifted to NICU in view of prematurity. Post-operatively, she was intubated and she was kept in ICU, and she was extubated on post-operative day 2. And then chest X-ray was done, which showed cardiomegaly, and the 2D echo, which was done on day 2, showed left ventricular systolic dysfunction with the ejection fraction of 30 to 35%. And then, so she was actually diagnosed with peripartum cardiomyopathy and was started on amlodipine, bromocriptine from post-operative day.
Okay, we'll start the question now.
Yeah, I'm very curious to know, Dr. Manisha, why you started her on bromocriptine. I mean, she was extubated. She would recover over time because it's peripartum cardiomyopathy. It takes 6 weeks. So what was the rationale of using bromocriptine?
Ma'am, because there was a reduced ejection fraction of 30%, so we have started on her own bromocriptine.
No, how bromocriptine helps, and how is that, and how could you be sure that this bromocriptine is, she would recover with this? I mean,
ma'am, actually, there was a hypothesis that due to the oxidative stress of the pregnancy, there is release of cathepsin D, and this cathepsin D leads to the proteolytic cleavage of prolactin, and this results in the production of a 16 kilodalton prolactin fragment, which is cardiotoxic. So in order to inhibit this prolactin fragment, bromocriptine was given as a trial.
And what was the dose?
Excuse me, ma'am?
Dose.
Dose, she was started on bromocriptine 2.5 mg HS dose, and she was given for 8 weeks.
Okay, thank you. Thank you, Dr. Manisha. Now we move over to the people we missed because they couldn't connect. Is Dr. Nitish there?
Hello, ma'am.
Yeah, Dr. Nitish.
Hi, yes, ma'am. Am I audible?
Yeah, you are audible. Can we have your screen now?
Yes, ma'am. 1 minute. Is my screen shared now?
No. Yeah. Go ahead quickly. Go ahead. Very brief gist of your case. Just
okay, I just directly go to the case presentation.
Yeah.
There is a multigravida female, 29 years old, presented to the ANC OPD at 18 weeks of gestation for a prenatal genetic testing. Because of her previous baby had a history of cerebral palsy and global developmental delay. A exome sequencing of that baby was done. A defective mitochondrial paroxysmal fission 2 was identified, and the Sanger sequencing of the parents was done. Mother came out to be homozygous for the same variant, and father was found to be heterozygous for the same variant. Both are phenotypically normal, and it is an non-consanguineous marriage. In the current pregnancy, amniocentesis was done, and the fetus was come out to be homozygous for the similar variant, similar mutation. Has we counseled the patients, but the couples continued the pregnancy and delivered a healthy baby with a normal development till date. Now presently it is a 11-month-old age. Mitochondrial fission factor gene mutation, it is a rare mitochondrial fission disorder, and only 6 cases has been identified throughout the world, and none from the India. And the 3 cases had the history of optic atrophy, peripheral neuropathy, external ophthalmoplegia, ophthalmoparesis, neurodevelopmental delay, microcephaly, and the recent case was the 11-year-old 11-year-old boy with epileptiform encephalopathy. And in our case, it is a 5-year-old boy with a global developmental delay and cerebral palsy and accidental identification of the MMF mutation gene.
Go to
Yeah?
the conclusion, please.
As per the ACMG guidelines, ours is a variant of unknown significance. Has this patient?
That is what I wanted to hear. Okay.
Yes, ma'am. Because the patient's expectation befuddled appropriate decision making.
Yeah. Okay. The questions, please. The question, judges.
Is it very rare? I think, no?
Yeah.
Yes, ma'am. It's a rare case.
The question is of significance, I think.
Yeah.
How significant is it? You have diagnosed it, but how significant? Even the mother is homozygous.
Yes, ma'am. Actually, what we have seen is from all the 6 cases which has been identified now, all these are affected are male babies only. And
Yeah,
the
this is a female one. This is a female.
This is the female one, sir, ma'am. It's a female one, and it's a normal development till date. It's 11 months until now. It's 11 months of
I
age.
know what implication is going to have in her future life. I mean, this baby
That
girl.
we have to see, ma'am, in the future what we have to do. As we have explained that, as we have seen that only male babies have affected till now. So none
Because
from
it's a
the female babies.
paternally, I mean, it's a paternally transmitted disease, no?
Yes, ma'am. It's a non-consanguineous marriage also for the sake.
Okay. Okay. Thank you. Thank you, Dr. Nitish. Can we
thank
have
you.
Dr. Smriti now? Dr.
Yes, ma'am, I'm here.
Yeah. Smriti, can we quickly have your screen?
Yes, ma'am. Is it visible, ma'am, now?
Yeah. Non-communicating rudimentary horn rupture at 25 weeks.
Yes.
Okay, go ahead.
So
Please
very good,
present
very
directly.
good morning to all of the judges. Myself, Dr. Smriti Anand, Assistant Professor in PGIMS, Rohtak. So coming to the case report, patient came with a diagnosis of G3P2L2 with 25 weeks of pregnancy with fetal demise, which was referred to our hospital in view of failed induction. She has already received 3 doses of tablet misoprostol per vaginally and Foley's induction after that for the same at the same hospital. And when she came at our hospital at the time, she was severely anemic. Pallor was of about 3 to 4 gram percent clinically. Pulse rate was 110. BP was 90 by 60 mm of mercury. And on per abdomen examination, there was soft distension present. Her uterine contour was not maintained. And there was generalized uterine tenderness present. And on per vaginal examination, cervix was only 2 finger loose and uneffaced, and it was pulled up. And presenting part was also very higher. And on suspicious of uterine rupture, we have done paracentesis, and that was found positive. And for the same, she was taken for emergency laparotomy. And intraoperatively, we have found that there was a rudimentary horn rupture, as shown in the picture. This was the normal unicornuate uterus, and this was the rudimentary horn. And in that horn, the pregnancy was present, which was get ruptured, and fetus was lying in the peritoneal cavity. Post-operative period was uneventful, and patient was discharged on 5th day after adequate blood transfusion. So coming to the conclusion part. Okay, ma'am.
Yeah. Dr. Anupam, Dr. Kalpana, Dr. Sharda, questions?
Dr. Smriti, like, should have come directly to you. You think we could have diagnosed this rudimentary horn pregnancy?
No, ma'am. We could not diagnose with this rudimentary horn.
No, we can't diagnose rudimentary horn pregnancy in a PV examination in ultrasound.
Ma'am, in this case, we have done a rapid ultrasound.
No. Before this rupture, she probably was a referred case.
Yes, ma'am.
She was from outside, and for for IUD, there was this termination must have been done. Listen, usually, like we also had come across such case where misoprostol did not act. Then you really get suspicious, isn't it?
Yes,
and the rupture could have been because of the misoprostol that was used, isn't it?
Yes, ma'am.
So my question is, she would have come directly to you with IUD. Can we diagnose a rudimentary horn pregnancy in ultrasound or in the PV examination?
Ma'am, in the PV examination, we can have like adnexal mass.
Yes.
So you can feel the
And in ultrasound also we can see a normal uterus.
Yes, ma'am.
Yeah, that's easy. It's not difficult.
Yes, ma'am.
So the take-home message should be, to others that before you, embark on inducing, if with 2 or 3, and the cervix would be like tightly closed because the pregnancy is elsewhere. It's
Yes,
then
ma'am.
ectopic pregnancy, isn't it?
Yes, ma'am.
That's it.
PV examination should be done in a pace
Yeah.
Thank you,
pain
Dr.
abdomen
Smriti.
like this.
Thank you. Sorry, we are running short on time.
Yeah. Good.
We'll go to the next presenter, Dr. Nirupama. Are you there, Dr. Nirupama? I think we had missed Dr.
Yes,
Nirupama.
ma'am. Yes, ma'am.
Yeah, Dr. Nirupama, go ahead.
Is my screen visible?
Yeah, but your presentation is not. Yeah, go ahead now, quickly.
Ma'am, I'm presenting a case of mid-trimester DVT. I'm presenting the case of Mrs. Tanu, 27 years old female. She is G3P1A1L0, and she presented with complaints of complaint of persistent pain in left lower limb since 1 month, and there was history of emergency section done 3 years back in view of abruption with IOD at
What
36 weeks
gestation
of.
she presented?
Ma'am, she presented in second trimester at 25 weeks of gestation. And ma'am, there was a history of emergency section done at 3 years back in view of abruption and IOD. And following which, after 10 days, she developed pain and swelling in left lower limb. After which, she was diagnosed to be a deep vein thrombosis of left femoral vein and its branches. Ma'am, patient received anticoagulant therapy of long-term equilibrium
In the
therapy.
previous pregnancy, was she started on this anticoagulant
Yes, ma'am.
therapy?
In previous pregnancy only, she was
And she
diagnosed to be.
continued to have this in this pregnancy also.
Yes, ma'am. Ma'am, in this pregnancy. Yes, ma'am.
Was she having anticoagulants from the starting of the pregnancy? No.
Ma'am, she was
this
having.
Pregnancy also.
Yes, ma'am. She was having ecosprin therapy. She was taking.
No. Why she was because she was having a history of DVT. We start on
previous
low
pregnancy.
molecular weight heparin because she's
Yes,
having
ma'am.
a history of DVT. Right from the beginning of the pregnancy. Usually we start on low molecular weight heparin.
No, ma'am. She was taking only ecosprin. But then when she presented here in our OPD, then we have started her on thromboprophylaxis with the ecosprin, enoxaparin 40 mg OD.
Okay. She has a bad BOH case, isn't it?
Yes, ma'am.
One abortion is also like there's one abortion also.
Yes,
okay,
ma'am.
fine. Go on. The discussion part.
No, I just quick question. What do you propose doing in future? I mean, now this is delivered and you've given her the thing. Do you think we should investigate her on something?
Yes, sir. We should be investigating about the thrombophilias or other
That's what we
diseases.
wanted to hear.
Thrombophilia profile we should be doing.
We should be doing.
Yes, ma'am.
Okay, because she's going to get pregnant again, and you're going to give her prophylactic also. So not that it will make a difference. You will have to give her thrombophylactis in the next pregnancy, and then.
No, what life-threatening complication can she have in the present pregnancy? I mean, with this profile.
Yes, ma'am.
Any life-threatening complication we foresee in this case?
Ma'am, she can develop a pulmonary embolism.
Yes.
Yeah. Thank you, Dr.
Okay, thank you.
Dr. Gabita, are you there? Dr. Gabita?
Yes, ma'am. Good morning.
Yeah.
I'm
Can you
going to
have
share
your
my
screen,
screen.
please?
Yes, ma'am.
Okay. Myomectomy during pregnancy. Quickly, because we are already.
Yes, ma'am. Is my slide visible, ma'am?
Case presentation.
Yeah.
Good morning, all the judges and my co-presenters. I'm going to present a case. A 33-year-old primary gravida presented at 17 weeks, 4 days of gestation with complaints of pain, abdomen, and vomitings for 1 day. On per-abdominal examination, there was a 28 weeks mass palpate towards the left side of the uterus, which was found to be a large subserosal myoma measuring of about 12 centimeter into 10 centimeter, and it is arising from the right lateral wall of the uterus, as it was shown in the figure number 1. This is the ultrasound finding showing a large pedunculated submucous fibroma. And despite the conservative management, patient was not pain-free and was planned for surgery after informed consent regarding all the possible adverse events and outcomes with respect to the pregnancy and to the surgery. We have operated her. Emergency open myomectomy was performed at 19 weeks, 4 days of gestation, and both intraoperative and postoperative periods were uneventful, and the patient was discharged on POD 5 and advised to continue on POD 5, and in antenatal period she was advised to continue injectable progesterone till 36 weeks of pregnancy. And we have followed up the patient antenatally. We have done all the ultrasounds like during the antenatal period, which was shown a normal growing fetus. And after the surgery, which was done at 19 weeks 4 days of gestation, then after that histopathology features was consistent with benign leiomyoma, showing secondary changes in the form of hyalinization and red degeneration. And patient was admitted again at 36 weeks, 4 days of gestation in view of dull aching right-sided lower abdominal pain, and we have ruled out UTI, possibilities of pain abdomen like UTI, vaginitis and abruption, and she was conservatively managed and planned for elective LSCS at 39 weeks of gestation, and she delivered a healthy male baby weighing 3.2 kg by lower segment cesarean section.
Okay, we'll take the question now.
Yes, ma'am.
Was elective CS done in this case?
Yes, ma'am. Because of cesarean delivery on maternal demand, we have done elective cesarean section at 39 weeks.
Okay. It's not for the myomectomy that you did, no? Because
No,
that was a pedunculated one. And of course, it's not going to
endometrium.
There was no breach in the endometrium, no breach in myomectomy.
Yes, ma'am. Yes, ma'am. We have done elective CS at 39 weeks. There was intraoperatively also there were no complications, and it was postoperatively also the patient was fine.
Any other questions?
And what was the indication of myomectomy?
Ma'am, because we have ruled out torsion and we suspected degeneration.
No, did she come with no? Does a subserous fibroid have degeneration? Because that's not connected with the uterus, no? I mean, it's this with the stalk.
Ma'am, we have given conservative management. Even after the conservative management, pain was not relieved, so we suspected degeneration. And because of the degenerative features, we have gone.
There is a risk of torsion, as you said. So that is
Yes,
the only
more of a risk.
Yes, ma'am. We have ruled out that, and after that, we have suspected degeneration. We have gone through emergency myomectomy.
Okay. Thank you, Dr. Gabita.
Thank you, ma'am. Thank you so much.
Thank you, everyone, for an enthusiastic participation in the prelims of the.
Thank you, ma'am.
All the best and happiness in the festive season. And I am passing on the baton for the second session to Dr. Ankita. I think she's already there on time as usual.
Thank you, Dr. Renu. Thank you so much. I mean, it's really humble to be a part of this online poster, you know. It's a very great experience, I would say, because I was having my tea, I was having my breakfast.
And if anyone didn't have emergency calls, that's a blessing.
Yes.
So my wishes to everyone. And Dr. Ankita, are you there?
Yes, ma'am.
Okay. So good luck for the next session. I take your leave now.
Thank you, Dr. Maya.
Thank you, ma'am.
Thank you.
Bye for now. Milenge. Next year I'll join Harding, you know, in July.
Great.
So
we are waiting for you to come.
Yeah. Bye. Thank you.
Bye.
A very good morning to respected judges and delegates. I welcome you all to the 42nd Virtual Annual AOGD Conference to Session 2 of e-poster presentation. Let's start the academic extravaganza. I take extreme pleasure in inviting the judges. Dr. Harsha Khullar, ma'am is Senior Consultant, Institute of Obs and Gynae, Sir Gangaram Hospital, New Delhi. Welcome, ma'am. Dr. Anjum Ara, ma'am is Associate Professor, Department of Obs and Gynae at RML Hospital and Special Interest in High-Risk Pregnancy. Welcome, Dr. Anjum Ara.
Thank you so much.
Dr. Shivani Sabharwal, Ma'am is obstetrician and gynecologist, laparoscopic surgeon, and infertility specialist at Jeevan Mala Hospital and Apollo Spectrum Hospital. Welcome, dear judges. I now call upon the first presenter of the day, Dr. Sabina. She'll be having COVID duty, so she wants to make the presentation first. She'll be presenting on Undying Quest for the Male Child, Leading to Violation of Fundamental Rights, a case report. Her paper code is MIS19. Dr. Sabina.
Hello, can I start? Hello?
Yes, please.
Good morning, judges. Today, my case presentation, she was a 35-year-old female, gravida 5, para 4, live 4. At 8 months of amenorrhea, she presented with a penetrating abdominal wound resulting from a stab injury by her husband. She was referred from a district hospital in UP to Safdarjung on day 2 of injury for further management. On examination, a vital space stable, her GCS was 15/15, and approximately 8 centimeter rent was found on the upper abdomen, extending from the right hypochondriac region to umbilical region, with bowel and omentum protruding out along with the baby's foot. There was no external active bleeding. She was immediately taken up for emergency exploratory laparotomy under GA. Her abdomen was opened by extending the wound incision vertically in midline. Per op, a 3 × 3 centimeter rent was found over the right uterine fundus. A male stillbirth baby was delivered by breech extraction after extending the incision horizontally over the upper uterine segment. The uterus was repaired in 3 layers and a partial omentectomy was done. Other internal organs were explored and were found to be healthy, except for a small serosal tear over the small bowel, which was repaired. She was shifted to ICU for intensive monitoring, and she was extubated on post-op day 2 and was recovering well. The discussion part, the incidence of trauma during pregnancy is in 1 out of 12 cases. Generally, in non-pregnant patients, the small intestine is the most affected organ, whereas in pregnant patients, it is the uterus. Intestinal lesions are rare because of the uterus involvement. Petronius conducted a study where he reported that there is a risk of 16% fetal mortality after abdominal trauma, which increases to 73% when it is a penetrating type of trauma. In this case, we had evisceration, intestinal injury, perforation of the uterus associated with intrauterine fetal demise. To conclude, our patient recovered well despite of a delayed referral as there were no big vessel injury or bowel injury. The occurrence of abdominal trauma during pregnancy should be referred to a tertiary care as it necessitates a multidisciplinary approach. And I would like to recommend that there should be many programs directed towards educating the masses regarding gender equality, enforcement of stricter laws against domestic violence, and emphasis on women empowerment by making them financially independent and for protecting them against these heinous crimes. Thank you.
Yes, Dr. Sabina, I think it was the same case which was reported in the paper also, because I had seen this case in the paper where they had reported that the husband just cut open the abdomen. So what do you think, that how can you change the mindset of the people? Once you said that that is by educating the people.
Yes, ma'am.
So other thing, what can you do?
More stricter laws should be made, ma'am. Like
yes. What laws? But because I think in this case, the husband should be punished.
Yes, ma'am.
Right?
Yes,
he should be behind the bars. And I think and that strict action should be taken against him. Okay. So you are lucky that you could save this patient. So what are the chances that this patient may have got this supposed infection and all? Then what could have happened?
There would be high chances of maternal mortality, ma'am, and morbidity as well as, because if there was bowel injury or perforation, then colostomy would have been done, and then again she would have been bedridden and prolonged hospital stay, and those other complications would have occurred. Yeah, puerperal sepsis being one of the most common.
Right. Good. Okay. So the other judges, they can ask the question. Dr. Shivani and Dr. Anju.
Did you offer her? Just one small thing I want to ask is that whether the MLC was made in your hospital or it was made from the referral hospital?
Referral hospital, ma'am.
So the MLC was already made?
Yes, ma'am.
Okay.
Dr. Shivani, you want to ask some question?
Dr. Sabina, very good presentation. Unfortunate case it was, which was, as Dr. Harsha ma'am said, it was very much in news. Did you do sterilization for this patient since you didn't mention it?
We have done, ma'am. Bilateral salpingectomy was done, ma'am.
Okay. And anything for the husband? You didn't, these patients?
No, he was arrested.
Consult for vasectomies or not?
He was arrested, like he was.
So I think male sterilization also should be a protocol for all antenatal visit for patients who are second or third gravida, especially in the tertiary centers, healthcare
Sure,
centers.
ma'am. Yes, ma'am.
Not only female sterilization. I think the government should stress on male sterilization also.
Yes,
But good
ma'am.
presentation. Unfortunate case and well saved.
Thank you, Dr. Sabina. It was nice presentation. So let's move to the next case. And I think, Ankita, you can tell that who is going to come.
The next presenter is Dr. Neha Rashmi. She's presenting on A Pretty Colorful Life, Uterine AV Malformation, Management and Challenges During the COVID-19 Pandemic. Her code is MIS1.
Good morning, respected judges, seniors, and my fellow colleagues. Am I audible, ma'am?
Yes, Neha, please be short and take only 2-3 minutes to present your case, okay? Then there will be time to ask questions, right?
Yes, ma'am. Good morning, respected judges, seniors, and my fellow colleagues. Today, I am presenting a case report of uterine AV malformation. She is a 35-year-old parity 2 living to abortion 1, presented at our center with a complaint of heavy menstrual bleeding on and off for 3 years. Her obstetric history was significant for having a molar pregnancy 8 years back, which was treated by suction and evacuation, followed by 2 cesarean sections 6 years and 3 years back. And she was a known case of the uterine AV malformation and having 2 previous embolizations 6 years and 2 years back following her cesarean section. She presented at our center with a complaint of heavy menstrual bleeding for 3 years, and at the time of presentation, her per abdominal and per vaginal examination was unremarkable, and 2D ultrasonography revealed a normal sized uterus with a multiple hypoechoic lesion in the myometrium. Colored Doppler show intense vascularity with a multidirectional flow suggestive of uterine AV malformation. As she had undergone CT angiography before, so we did not offer CT angio to her, and we performed total abdominal hysterectomy with the right salpingo-oophorectomy and left salpingectomy, and histopathology was also suggestive of uterine AV malformation and the previous embolization. This is in sort of my case.
Acha, what was the treatment you had given? You have.
Ma'am, we performed total abdominal hysterectomy with right salpingo-oophorectomy and left salpingectomy.
Why not conservative management in this case? What conservative management you could have given?
Ma'am, we can offer her medical management like methyl alcohol, Norvine, Danazol, OC pills, but she underwent 2 times embolization failure, so she opted for the hysterectomy.
She offered, but she was offered, or she wanted that hysterectomy because she is young, 35 years only. So any other treatment you could have done? And secondly, yes, I think you have removed one side ovary also. Why one side ovary was also removed?
My question also.
In third images, there's a vascularity. There's a vascularity with the vascular, the area has a various high network of the arteriovenous in right side that extending into the broad ligament. So to prevent the further surgery, as he underwent two-time embolization failure, So to prevent the recurrence, we did the salpingophorectomy, leaving the left ovary.
I just want to know that what was the histopathology report of the ovary removed?
Ma'am,
You have not mentioned that.
That was normal only.
You didn't mention, huh? Can any other treatment be done in such case? Can partial resection of the uterus be done? Because in case she wants to preserve her uterus, so can we do that partial resection where the AV malformation is there?
Yes, ma'am, we can offer that also. But that has a high chance of recurrence. So
see the cause. What is the cause of this thing forming AV malformation? In this case, she had delivered or she had abortion?
Ma'am, 8 years back she had molar pregnancy. That also is also a risk factor for the AV malformation, and she underwent 2 cesarean section along.
Okay, thank you. It was good presentation. What other judges, they want to ask any question?
No, I think, ma'am, you have already asked the ovary question. Even I wanted to ask. I think it's very.
I know.
Yeah.
Okay.
Just a small query. What was her delivery? Both she had previous 2 cesareans. She was diagnosed AV malformation 6 years back itself. So was it diagnosed her during her first pregnancy delivery time, or was it diagnosed after that? You have mentioned the duration saying 6 years.
Yes, ma'am. After the 15 days of postpartum period of first pregnancy, she had multiple episodes of the heavy menstrual bleeding. And after that, she was diagnosed to have uterine AV malformation.
So it was episodes of heavy menstrual bleeding, or whether it was secondary PPH?
Ma'am, that was confirmed by CT&G also, uterine AV malformation.
My question is that you told me 15 days after delivery, she had episodes of heavy menstrual bleeding. Will you call it heavy menstrual bleeding, or will you call it secondary PPH?
Secondary PPH, ma'am.
Okay.
And one thing more, that was the histopathology confirmed?
Yes,
that
ma'am.
it was AV malformation only because she had previous molar pregnancy also. What was the beta HCG like, and was there any molar, invasive mole and all?
Yes, ma'am. We offered beta HCG for her, and that found to be normal. And
okay, and what
was suggestive of multiple dilated vessels with embolic material in that, and with giant cell reaction surrounding that vessel.
Okay, thank you so much. Thank you, Rashmi.
Thank you. Now we go on to the next presenter, Dr. Akanksha Mohanty. She'll be presenting on Quest for Male Child. Her code is MIS2.
I think it's the same case which has been presented by Dr. Sabina.
I think it is the same case, ma'am.
You are from the same hospital, Safdarjung Hospital. So why 2 entries from the same hospital by 2 different speakers? I just want to know that. And pictures are also looking the same. Okay, just present now. You have given. Let's see what you say extra. Start your case, please. Dr. Akanksha, are you there?
Dr. Akanksha?
Yes, ma'am. Am I audible?
Yes.
Yes, you are audible. Yes, you can start your case now.
Good morning.
Please be short. We know about the case. You just tell us the salient points only.
Okay, ma'am. I'll come directly to the case presentation. A 35-year-old woman, gravida 6, para 5, live 5, was referred at 8 months of amenorrhea with history of physical assault by husband 1 day back. On general examination, the patient was drowsy and afebrile. Her BP was 112/70, pulse was 102 beats per minute, and saturation maintained at 98% on room air. Per abdominal examination revealed a 10 into 3 centimeter stab wound over the supraumbilical region extending from right to left hypochondrium, through which omentum, gut, and a foot of the fetus was jutting. On laparotomy, incision was given in midline, extending from lower wound edge up to 4 centimeters supraumbilically. Uterine wound of 6 into 3 centimeter was visualized on the fundus with foot prolapse. A hematoma extending bilaterally towards the mesosalpinx was noted. Uterine incision was extended bilaterally and a 1.7 kg macerated baby boy was delivered. Small serosal tear of 0.5 into 1 centimeter on the jejunum was repaired by surgeons along with partial omentectomy, which was also done. Estimated blood loss was 2 liters. The patient was shifted to ICU post-operatively. On the day of stitch removal, she developed wound infection for which she is currently undergoing vacuum dressing. So maternal health outcome is influenced by various risk factors. And despite several government incentives, such as the enforcement of the PCPNDT Act, declaration of National Girl Child Day, Beti Bachao, Beti Padhao Yojana, among others, which have been taken to incentivize the birth of girls, still health systems' neglect of issues remain the core of the problem. Primary factors influencing health outcome include age, parity, socioeconomic status, among others. So on a concluding remark, we need to evolve a comprehensive national policy response to this deeply resistant ailment instead of targeting just one symptom, that is sex selection, which mandates necessity of action at all levels and most importantly in developing enforced policies and programs for combating gender inequality. Thank you.
Dr. Akanksha, we've already discussed that what all factors they can help in resolving this issue.
Yes,
but I just want to ask that when was the first cesarean section done and why it was done? What did the person saw? And after that, he decided that I think we can take out the baby per abdominally also. Can you recall from your book?
The first cesarean section in history, ma'am.
Yes.
No, ma'am. It was, ma'am, as the name suggests, Caesar itself.
No, Caesar, but what this thing, Julius Caesar was born with that, they say, but this thing, how? Why? What came to his mind, whosoever has done this cesarean, first cesarean abdominal delivery, I mean? No, it was just a pregnant woman going in the market. Suddenly a bull comes and just hit it on the abdomen, and this thing abdomen just opens up and the baby comes out.
Okay, ma'am.
So he was going and he saw that, oh, baby can come out through the abdomen also. Right?
Right, ma'am.
Right. So that is the thing that it came to his mind. Okay, we can take out the baby per abdominally also. Where the patients were dying from this thing, obstructed labor and all. So,
so the easier way out would be to take from the abdomen.
Right. Okay, thank you so much.
Yes, ma'am.
But it was a repetition from the same hospital, same case, same photographs. Okay, we'll see.
Yes.
Chalo. Thank you so much. Okay. Dr. Shivani and Dr. Anjum, would you like to ask any question?
No, ma'am.
I think this has been nicely discussed. Thank you.
Okay, thank you.
Thank you, ma'am.
On to the next presenter, Dr. Shivani Shankar. She'll be presenting a rare structural malformation and a chromosomal abnormality. Her code is MIS3.
Yes, ma'am.
Are you able to share your screen?
Yes, ma'am. Good morning. Good morning to all of you. My topic is OIS complex with tetraploid mosaicism, a rare structural malformation and a rarer chromosomal abnormality. I'm presenting a case of a 29-year-old lady, Gravida 3, Para 1, Live 1, A1, having non-consanguineous marriage, was referred to the fetal medicine OPD of Lady Harding at 19 weeks of gestation. With ultrasound showing fetal omphalocele. The reviewed ultrasound was done then in our department showing omphalocele associated with bilateral talipes equinovarus. The liquor was adequate, but bladder was not seen. Hence, the extrophy of bladder was suspected. Then the spine was not visualized clearly. Now, the couple was counseled about this, and decision for amniocentesis was taken for karyotyping. The couple opted for termination of pregnancy, and a baby of 494 grams with large omphalocele with bladder extrophy and with anal atresia was born. There was also a spinal deformity in the form of gibbous in the lumbosacral region. The diagnosis of OIS complex was made, and the karyotype report of the baby shows 60% of the metaphase showing normal chromosome complement, and the remaining 40% shows tetraploidy. In this, if there is a prenatal diagnosis of omphalocele, then other abnormality should be also looked for, as omphalocele is associated with 60 to 80%. In 60 to 80%, omphalocele is associated with other abnormality. So the diagnosis of OIS complex should not be missed. Hello. And chromosomal abnormalities may be associated with multiple defect. The association of mosaic tetrasomy with OIS complex is a novel finding.
These tetraploidy cases, how many cases have been reported? And can it be an artifact?
Yes, ma'am. In literature, it can be the artifact, as ma'am, during the process of amniocentesis, there is 10% of in 10% of normal amnion cells, the tetraploid is a normal thing. So it depends on if in the sample we have taken, if we have taken the amnion cells instead of the fetal cells, then this can be artifact. And this should be confirmed, ma'am, by the tissue or the blood of the fetus which was born.
In this case, what were the chromosomes of the parents like?
Ma'am, parental karyotyping was normal.
You did that?
Yes, ma'am. In next pregnancy they came, so karyotyping was done, and it was normal, ma'am. Both parents were of normal karyotype.
Any history of any abnormal baby in the family? Was it a consanguineous marriage or what?
Ma'am, it was non-consanguineous marriage, and in family, they were having previous live issue, and it was completely normal.
Suppose it's a normal baby, no abnormality at all. So in that case, due to the artifact, can you get this tetraploidy due to contamination with the maternal blood?
Yes, ma'am. We can have this artifact.
Have you seen it before, the tetraploidy?
In only literatures I have read that the tetraploidy but baby has born normal. It was normal baby, but tetraploidy was seen. So it has been taken. That it is a question like, is it a artifact in literatures?
Then post delivery, were this chromosomes for the baby done? Amniocentesis showed that, but in after delivery of the baby, were the chromosomes done? Just to differentiate whether it was artifact or whether they were really tetraploidy?
No, ma'am. The confirmation was not done, as the blood or tissue of the fetus was not saved.
Okay, thank you. So Dr. Shivani and Dr. Anjum, you would like to ask some questions?
Dr. Shivangi, could this be detected earlier? Anything in level 1 or anything in markers you could have thought?
Ma'am, like level 2 scan showed omphalocele. Patient came in our OPD with only omphalocele as a finding. So, ma'am, ultrasound should be done to rule out, ma'am, other associated abnormalities. And also, ma'am, serum alpha fetoprotein, increased alpha fetoprotein concentration can be done as a biochemical test.
My question is, could this be detected earlier if this patient would have come to you earlier?
Ma'am, ma'am, before 11 weeks, as ma'am, it is a physiological herniation. So it is of no use. If it would be before 11 weeks, so we cannot say that it is a omphalocele, ma'am, because it is a physiological phenomena. So after 11 weeks only, we can rule out that omphalocele abnormality.
So next pregnancy, what are you going to do?
Yes, ma'am.
In next pregnancy, ma'am, we will counsel the patient for early ANC registration, and we will do a level 2 scan, ma'am, to see any abnormality, and if abnormality would be found, we will counsel the couple for amniocentesis.
Excuse me, you will wait till this level 2 scan? Before that, can you do anything?
Ma'am, we can, we will give a patient, ma'am, a preconceptional folic acid should be given to the
during
patient.
Pregnancy, I am saying that during pregnancy.
Before
going for the level 2, would you like to do something else?
How early can you diagnose this patient with having it? That is the question madam is asking.
Would you like to do the chromosomes in next pregnancy?
Yes, ma'am. Ma'am,
what are the chances of recurrence?
sampling.
What are the chances of recurrence?
Ma'am, recurrence, ma'am, OIS complex, there is, recurrence is not found in literatures, ma'am, as it is very, it is a very rare abnormality, ma'am. Is incidence in 1 in 2 lakhs, so not much studies are there. And
Surprises
in
can
the
always be
studies,
there. Surprises can always be there. So you'll have to follow up the patient. You can do early mid-trimester scan also.
Yes, ma'am.
Yes, recurrence has been
Okay.
reported in OSS cases, and the answer is we have to get an early level 2 scan in such patients, those who have history of OSS complex. Then also, do you think that what is the prognosis of this baby? Do we require termination for such deformities, or can the baby survive such anomalies? My question is that.
Ma'am, as it is also associated with the spinal defect, so associated spinal defect, spina bifida, it can lead to, in 70 to 80% of the cases, mental and physical subnormality remain in the child. So we can counsel patient, explain the prognosis, and then we can take decision regarding termination, or if parents would lead to allow the pregnancy to continue, because the baby may have surgeries, and baby required surgery and also neurosurgery for this case. It depends on the patient.
Thank you, Dr. Shivangi. Let's move to the next speaker.
Thank you.
Yes, ma'am.
Now
Thank
I call
you, ma'am.
upon Dr. Benchumi to present her case, a rare case of recurrent pontocerebellar hypoplasia diagnosed by fetal autopsy and histopathological examination. Her code is MIS4. Dr. Benchumi.
Yes, ma'am. I'm sharing my screen.
And start your case, Dr. Benjamin.
Is my screen, ma'am?
Yes, yes, we can see.
We can see. Please do the slideshow.
Good morning, everyone.
Yes, good morning. Go ahead.
Good morning, everyone. I am presenting a case of a rare case of recurrent pontocerebellar hypoplasia diagnosed by fetal autopsy and histopathological examination. My patient was 24-year-old lady, non-consanguineous marriage, gravida 2 para 1 live 0 with 18 plus 6 weeks period of gestation, who was referred to fetal medicine OPD with an ultrasound report showing posterior fossa defect. On eliciting history, patient gave history of previous 7-month IUD baby born of contractures in limbs. She also gave history that the ultrasound in the previous pregnancy also showed polyhydramnios. In the present pregnancy, repeat ultrasound scan was done, which showed polyhydramnios with no fetal movement throughout the scan. On intracranial targeted scan, there was thromboencephalosynapsis with apparently large cisterna magna. Provisional diagnosis of fetal akinesis syndrome was made. In view of present pregnancy with major congenital anomaly, medical termination of pregnancy was done, and after delivery, external examination of the fetus showed contractures of the lower limb muscles. At autopsy, there was absence of vermis and hypoplastic bones. On histopath examination, there was sparse Purkinje cells in cerebellum and bones suggestive of pontocerebellar hypoplasia. The couple was counseled that there was 25% chance that the offspring will be affected and 25% recurrence rate in the next pregnancy. The takeaway message from my case presentation is that it highlights the importance of history taking and review history of a case in reaching diagnosis, as it reinforces the findings of a particular case. It also imparts that review ultrasound scan should always be done to look for other anomalies, as in most cases of intracranial defects, there are associated other congenital anomalies. Fetal autopsy added and confirmed to the findings on the ultrasound, and diagnosis could be reached after the histopathological examination report.
Good. So how many cases of such has been reported?
Ma'am, the incidence is, ma'am, 1 in 10,000 cases. And ma'am, in my hospital, ma'am, this is the first case, ma'am, because the previous, yes, ma'am, the previous pregnancy was delivered in some other hospital, ma'am.
Dr. Benjamin, you rightly said that proper history should be taken. So in this case, did you take the proper history? Was there any family history? Was there any consanguinity and all? Was there any history of taking any medicine? And it's only that autosomal recessive. You said that, okay? And 25% chances it recurrence. So what all history you should take in? Suppose there's a bad obstetric history patient. So what all history you should take in that?
Ma'am, whether the marriage
you didn't know that there was biopsy, this autopsy was done in previous PTCs or not?
Yes, ma'am. Ma'am, I could not write it in the poster, but ma'am, we took the history. Ma'am, the marriage is of non-consanguineous marriage, and in the previous pregnancy, there was no autopsy or histopathological examination which was done. And ma'am, we asked about first trimester drug intake history, and whether she took folic acid prophylaxis or not, and those things, ma'am.
Dr. Anjum, you would like to ask any question? And Dr. Shivani also?
Dr. Benjamin, yes, it's a rare case. Now tell me one thing. Now you already told this patient that 25% recurrence in the next pregnancy. Yes, what methods you want to give her for next pregnancy? How she can go ahead to have a healthy baby?
Ma'am, yes, ma'am. Ma'am, she should be called up. She should be followed, ma'am, for the next pregnancy. We will call her preconceptionally, and we would like to advise, ma'am, folate prophylaxis for 3 months before conception. Ma'am,
you said autosomal recessive disorder. Folic acid will help.
Ma'am, there is, ma'am, less chance, ma'am, that folic acid will help in this case, ma'am.
What option you want to give? That's my question. Do anything genetic help? Anything?
Yes, ma'am. Ma'am, prenatally, ma'am, we can do, ma'am, first, we can do prenatal genetic testing for the fetus in the next pregnancy, ma'am.
Dr. Shivani, you want to ask? Hello?
Yes, ma'am.
Anji. Dr. Shivani, you want to ask any question?
Yeah, my question only she's answering, ma'am, that how prenatally what she can do. My question to her is how she can help this patient to avoid this in next pregnancy.
Ma'am, counseling will be done, ma'am, in the next pregnancy. We will follow her up in the next pregnancy, and ma'am, genetic testing will be advised to her, ma'am, for fetal karyotyping, ma'am.
Thank you. Should we go on to the next?
Yes, Ankita, Hanji, you can call next.
Dr. Shreya Singh Kushwa. She'll be presenting on angiographic embolization of recurrent postpartum vulvovaginal hematoma. Her code is MIS5.
Hello.
Yes, Dr. Shreya, you can start your case.
Yes, ma'am. Good morning to the respected judges and my fellow participants. I'm going to present on angiographic embolization of recurrent postpartum vulvovaginal hematoma. My case is of a 28-year-old female, 6 gravida with previous 5 abortions at 38 plus 5-week period of gestation. She is a known case of sickle cell anemia and beta thalassemia trait and intrahepatic cholestasis of pregnancy. She presented in labor and underwent forceps delivery and had atonic postpartum hemorrhage after delivery, which was managed medically. Around 1 hour after the delivery, she developed a right vulvovaginal hematoma of around 6 into 6 centimeter at episiotomy site. She was paired with tachycardia of 120 beats per minute and BP of 100/60 millimeter of mercury. On comparing the pre-delivery and post-delivery investigations, she had a significant fall of hemoglobin from 8.7 to 5.8, and TLC was raised from 15,000 to 25,000. Other investigations were not significantly different. The patient was taken for surgical exploration of hematoma, but immediately after the procedure, she again developed hematoma and bleeding from the episiotomy site. Immediately, re-exploration was done in the same sitting. In both the sittings, no active bleeder was found, dead space was obliterated, and hemostasis was achieved. But hematoma reformed at the same site while in the OT only. Therefore, the decision for digital subtraction angiography followed by embolization was taken after discussing it with the intervention radiologist. The DAC spots of both the internal pudendal artery are shown in the figure A and D that did not reveal any active contrast extravasation. However, an abnormal blush was noted as we can see in the spot B and E, which was embolized using gel foam. Post-embolization angiograms are shown in C and F, which showed significant reduction of abnormal blush. Bleeding also stopped immediately after the embolization. The patient was transfused with 3 units of packed red blood cells and 8 units of fresh frozen plasma intra and post-operatively. The patient was discharged in stable condition on post-embolization day 8. Coming to the discussion part, there are 3 main approaches for management for the vulvovaginal hematoma. First one is conservative management. Second one is surgical intervention, which is usually done. It consists of incision and drainage of the hematoma, followed by the ligation of the active bleeder if found, and dead space obliteration. It is required in cases of large and growing hematomas, and if the patient is hemodynamically unstable. Other option is selective arterial embolization, which can be done if surgical repair fails, or there is recurrent hematoma formation, or there is or if the bleeding vessel cannot be identified. To conclude, I would like to say in cases of recurrent episiotomy site hematoma after a failed surgical management, possibility of rare causes such as pseudoaneurysm or arteriovenous fistula should be kept in mind and evaluated promptly. And selective arterial embolization is a important therapeutic approach that can be used in such patients. Thank you, ma'am.
Dr. Shreya, your patient was high-risk patient. And I just want to know that you didn't mention to which state the patient belonged, because she had sickle cell anemia also, along with beta thalassemia also, right?
Yes, ma'am.
Am I right?
Yes, ma'am.
So to which state the patient belonged?
Ma'am, she belonged to Uttar Pradesh.
Uttar Pradesh. Sickle cell anemia is common there? Where is sickle cell anemia common?
In the northern belt.
The northern belt. And secondly, that what was the distinct thalassemia report of her husband? He was normal?
Yes, ma'am. Husband was not
normal. And she had intrahepatic cholestasis of pregnancy. Her INR was normal. So normally at what period of gestation a patient of intrahepatic cholestasis of pregnancy be induced or delivered?
Ma'am, we induce or deliver the patient at 37 to 38 weeks period of gestation, but she did not came for follow-up. That's why we couldn't induce.
What can be the reason? Suppose we leave the patient and we don't induce or deliver. What are the chances of?
She can have an IUD if left.
So what's the cause of IUD?
Ma'am.
With intrahepatic cholestasis of pregnancy. Okay, nice. So you've said that suppose failed this thing, surgical intervention and this, and then we should go ahead with the angiographic embolization of the arteries. Good.
Yes, ma'am.
But I think you should always keep in mind, because this patient was high risk. She was anemic, 8.7 grams hemoglobin. She had history of sickle cell anemia. She was beta thalassemia. and tissues must be edematous, and chances of forming hematoma again and again are there. So I think should be handled by a little senior person, so that recurrent formation of the hematoma should not be there. Right. So other judges, they want to ask any question?
What are the complications in particularly related with the embolization of internal pudendal artery? You have embolized that same artery in this now?
Yes, ma'am.
So what are the complications?
Ma'am, there can be immediate complications like the local hematoma at the local site or bleeding, the loss of distal pulses. And ma'am, there can be fever and post-embolization pain. And there can be loss of, generally there is peripheral collateral formation to the organs supplied. But there can be
there is something called post-embolization syndrome.
Yes, ma'am.
That can happen. Then any muscle that can be specifically affected by embolization of gluteal muscle?
Yes, ma'am, gluteal muscles can be.
Then anything related with bladder, bowel, when you're embolizing this artery can happen to them?
Yes, ma'am, there can be embolization of the other vessels they are supplying the nearby organs, ma'am.
And what are the chances of success of embolization of internal pudendal artery? The success rate when you are embolizing these arteries?
70 to 80%.
Okay. Suppose if the artery is not embolized and bleeding is still continued, what is your other options? How you can manage it?
Ma'am, if the patient doesn't
Or
want
suppose if the facilities of embolization are not available at your center, then what will you do?
ma'am, we can do the hysterectomy or the hypogastric artery ligation.
Okay. Long discussion. Good presentation anyways. Congratulations. Okay.
Thank you. Now I call upon the next speaker, Dr. Akanksha Gupta, on spontaneous uterine rupture in a postmenopausal female, a rare entity. Her code is MIS6.
Dr. Akanksha, are you there? Dr. Akanksha?
Dr. Akanksha Gupta, can you share your screen? Okay, we'll go on to the next.
Dr. Akanksha, please do the slideshow.
Dr. Akanksha, are you there? Ankita, just ask her if she's there.
Dr. Akanksha, can you hear us?
We can move to the other presenter next in line.
Till she troubleshoots. I'll call upon Dr. Sunaina Agarwal. She has a case report of the management of a referred case of intraoperative extensive bladder trauma during cesarean. Her code is MIS7. Dr. Sunaina, are you there? Can you share your screen, please?
Yes, ma'am. Ma'am, is the screen visible?
It was visible, now it's gone. Are you able to share your screen now?
Yes, ma'am, I'm showing my PPT. Is it visible?
I think this is Akanksha's
Dr.
slides.
Kancha's is visible. Dr. Kancha, can you stop sharing the screen?
Dr. Sunana, please click on share screen.
Yes, sir, I'm doing that.
Yeah. There is some option. Please click on your slide.
Is it visible now?
Oh, ma'am.
No.
Dr. Sunana,
Yes, sir.
click on share screen
The green button.
and then click on desktop.
Sir, I'm doing that only.
And then click share.
Sir, I've done that. Ma'am, I think my colleague is sharing her screen. That's why it's not showing.
Dr. Priyanka Naik's screen was showing.
Dr. Sunana, please click on share screen. Hello. Can we move to next one?
I'll call upon Dr. Reena Kumari now till Dr. Sunana troubleshoots. She'll be presenting on See and Treat, a new approach to pre-invasive lesions of the cervix. Her code is MIS8. Judges, please note it's Dr. Reena Kumari, MIS8. Dr. Reena, are you able to share?
Yes, ma'am. Hello, ma'am.
Yes, we can hear you. Please share your
Yes,
screen.
ma'am. Yes, ma'am. Ma'am, can you see my screen?
Yes, we can see your screen.
Ma'am, today I am presenting See and Treat, a new approach for the pre-invasive lesion of the cervix. The cervix cervical cancer is the second most common cancer in the age of 15 to 45 years of the age female. Every year, around 67,000 women die from the disease in our country. There is a long interval period between the viral infection and the development of the invasive disease of the cervix. So secondary prevention is an approach that is used to early diagnosis and used to treat the CIN lesion. There are mainly two approaches. In CNT treat approach, the abnormal cervix patient having undergone colposcopy and biopsies were taken, and in the same sitting treatment were given. In the second approach, that is conventional three-step approach for the management of CIN lesions, in which the patient having abnormal cervix were undergone colposcopy, then biopsies were taken and histopathological report were collected, and after the report, treatment were given according to the report. In this approach, more patients were lost to follow-up for the treatment. So the new approach was developed and compared with the conventional three-step approach. The study is randomized control study done in the Department of Obs Gynae AIIMS Rishikesh for the duration of 2 years. Patients were included having abnormal cervix. They were randomized in the two group, in See and Treat group, and another group is conventional three-step approach. The inclusion criteria were women aged 25 to 60 years having abnormal screening result, PAP showing SCUS or worse than SCUS result, positive positive via and villi, clinically abnormal cervix with normal PAP, persistent inflammatory pap smear, postcoital bleeding, and persistent discharge per vagina. The patient were excluded were inability to give the informed consent, obvious growth on the cervix, pregnant woman, severe debilitating disease. In the first group, that is See and Treat group, in the same sitting, on the basis of colposcoping finding, they were treated, CIN 2 and 3 lesions were treated by LEAP, whole knife conjugation and cryotherapy. And in another group, the biopsy were taken and sent for histopathological examination. And after the report, appropriate treatment were given to the patient in the next visit. The results were there in the two group. In the first group, see and treat group, all the people, all the cases were received the treatment. In the second group, after biopsy report, 39 patients required the treatment out of 50, but out of 39, 24 patients were lost to follow for the treatment and they did not receive the treatment. Only 15 patients received the treatment and they were followed for after 6 months for adequacy of treatment, and out of which one were lost to follow-up after 6 months. And in the same group, 11 were low-grade biopsy, so they do not require treatment and they were analyzed after 6 months. So we concluded that significant difference exists in the adequacy of management between the two groups. The study advocate that use of see and treat protocol should be used only in high-grade cytology regions. And therefore, over-treatment rate was more in group A and it was less in group B. Hello, ma'am.
Yes, Dr. Adina, it's a nice one. It's a see and treat that the patient comes in one visit only. You can see and treat her also. But
yes, ma'am.
Like your certain HPV and all. Did you
Yes,
do
ma'am.
that? Did you do that HPV also? Human papilloma virus?
No, ma'am. It was no, ma'am. In this study, it was not done, ma'am. Yes,
Just patient came and you just did the colposcopy and took that biopsy, right?
yes,
And when
ma'am.
was the
Only
repeat
abnormal
biopsy?
patient were examined. Ma'am, no, ma'am. Only yes, ma'am. After 6 months, repeat biopsy was not done. They were only followed after 6 months, and only visual inspection was done.
You didn't do the cytology also in the repeat, only the visual
Ma'am,
examination.
yes, ma'am. No, ma'am. Initially, cytology, visual examination, both were done. Only abnormal Pap smear patient and having abnormal clinical finding on the cervix were taken in the study.
You did the colposcopy also?
Yes, ma'am. We did the colposcopy.
Okay, good. So that means you can save their one visit also, because then they may not come, right? And after 6 months, you were repeating
Yes,
the
ma'am.
cytology and the visual examination. Did you do via in
Yes,
these
ma'am.
cases? Via and villi? In the OPD only when you're seeing that the cervix is looking abnormal, did you do via?
No, ma'am, I have not done. But a patient having positive villi acetoacetic from another screening were referred from another where we have taken the cases.
Okay, good.
Thank you. I request
Thank
the
you,
next
ma'am.
participant, Dr. Ritu Yadav. She'll be presenting a rare case of chronic refractory ITP in pregnancy with unusual complication and successful management. Her code is MIS9. I request all the participants to present in 1 minute as a summary, because their posters have already been prejudged. So the judges can ask questions comfortably given time. Dr. Ritu Yadav, you can summarize your presentation.
Yes, ma'am. Is my screen is visible, ma'am?
Yes, you can see it.
Okay. I am going to present a rare case of chronic refractory ITP in pregnancy with unusual complication and successful management. There was a 23-year-old female, gravida 3, para 2, living 0, known case of ITP presented to us at 14 week of POG with low platelet count. And it was already a known case of ITP. And we admitted the patient and we started investigation, and we started her on oral prednisolone. And the initial platelet count was 5,000 and we started her on 20 milligram once daily. But at the time of admission, she required multiple RDP transfusion and IVIG courses was also given. After 1 week, her platelet count was improved up to 35,000, and she was discharged with sign and symptom of again bleeding and danger sign was explained, and asked her to report if platelet count are below less than 10,000 or any complication. So over her entire ANC period, patient was admitted thrice at 19 week, at 24 week, and at 26 week with either low platelet count or with epistaxis. So at every visit, we give her multiple doses of random donor plasma platelet transfusion, IVIG courses, and dose of prednisolone increased from 20 milligram to 50 milligram. But at around 27 weeks, she complained of bilateral hip pain, which was later diagnosed with avascular necrosis on MRI. Here we can see on MRI also, there is a double line sign, which is pathognomic of bone infarction in femur. So, so we have to taper the steroid and stop at last. But we have to maintain the platelet count also at the safer level. So what is the other mode of treatment we have to given the patient? So we started the patient on injection romiplostin, that is a thrombopoietin receptor agonist. We started her on a dose of 3 microgram per kg per week initially, and later it is increased up to 10 microgram per kg per week. And her platelet count were improved over 2 weeks up to 50,000. And symptom of hip pain improved gradually, but along with this romiplostin, we have to give the patient injection augmentin also, but because on MRI, along with the avascular necrosis, there was superimposed osteomyelitis also. But around at 35 week of pregnancy, she underwent emergency LSCS as she had developed antepartum hemorrhage with fetid bradycardia, under platelet transfusion, and single donor plasma platelet transfusion, and with there was no postpartum hemorrhage. The postpartum period was uneventful. Neonate, however, she delivered a healthy female baby of 2.1 kg with normal Apgar scoring. However, the neonate developed refractory thrombocytopenia, which was managed with steroid, IVIG, and plasmapheresis. In postpartum period, patient maintained her platelet stable count up around more than 1 lakh on injection romiplostin. Here we can see the graph of her entire platelet during antenatal and postpartum period. These are the 3 visits where the patient admitted, and after random donor plasma and IVIG courses, she improved up to the platelet count improved, and this is the where she underwent emergency LSC. At that time, the platelet count was around 50,000, and this is the time where we started injection romiplostin, and after that there is no need of further IVIG courses, and steroid was already stopped, and her platelet count was improved up to more than 1 lakh in her postpartum period. So hereby we can conclude that cases of pregnancy hereby we conclude that cases of pregnancy with ITP on high dose steroid may manifest with atypical presentations such as avascular necrosis, even in the absence of other high risk factor. And avascular necrosis is a progressive and disabling disease. If we can diagnose it earlier, then we can avoid other arthroplastic surgery in this patient. There are the limited literature of use of romiplostin in pregnancy, which was complicated with ITP. But we can consider this drug in a selected cases where there is no response to first line treatment, or when they are contraindicated, like in our case. Thank you so much.
Very good, Ritu. It was very well managed. And did you give this during the postpartum period also?
Yes, ma'am. Patient is still on 250 microgram total doses at a rate of 5 microgram per kg per body weight. She's on still, and she's maintaining her platelet count. But hematologist said that over the time of period they will taper, and finally they will stop it.
Okay. So how long we can give this romiplostin?
Ma'am, according to him, we can give, ma'am, it is safer in pregnancy also. There was this category C drug, but in last trimester, 3rd trimester, we can give. But over the time, there is no significant side effect of this drug. But because this is this drug is costly and weekly injection, so patient can't be afford so much. So over the time, we have to start her again on the steroid. Taking her condition in mind, she developed avian also, but finally we have to stop this drug and take the steroid on use to finally maintain the platelet at a safer level.
Right.
Ritu, how
So
long did you?
what is the cost? Sorry. What's the
Yeah,
cost of this injection?
Ma'am, around 250 microgram of vial is around 2020, 200 rupees one vial.
Okay, right. Somebody was asking question. Yes.
Ritu, how frequently were you doing platelets for her?
Yes, ma'am. Sorry, ma'am.
How frequently were you doing platelet test counts for her when she was on this treatment?
Yes, ma'am. My monthly platelet count. We are following the patient on monthly platelet count because now the platelet is more than 1 lakh. But if the platelet at lower, matlab, count were in lower range, then we have to monitor 2 weekly or 1 weekly also.
And how much rise was expected in this?
Yeah, ma'am,
How
40
much
to 60% rise is expected from injection romiflostin when we started at initially, and we can notice also the platelet count was around 35,000, and after giving over a 2 week period, the count was 50,000, and after 2 weeks, then the count was more than 1 lakh.
Okay, what was the history in the first two? You said she's G3 para 2. What is the first two history for this?
The first two pregnancy was, the first pregnancy was in 2015 and second was in 2017. First, she was the full-term vaginal delivery, ma'am. There was a history of anemia in that pregnancy. She, on her history, she gave that she required multiple blood transfusion, but she never said she received platelet. Maybe she did not know ki whether there was, she was saying ki there was red blood, red color, not yellow in color, but she delivered a full-term vaginal stillborn baby, and there was a postpartum hemorrhage also in that pregnancy. She received 3 units of RBC at that time. And the second pregnancy, that was a full-term LSTS at term in view of MSL with fetal distress, but that baby was also stillborn. The reason was not known. She also developed postpartum hemorrhage in that pregnancy and received 2 units of RBC.
So was she investigated? Does ITP cause IUDs?
Yes, ma'am. She was investigated on behalf of those also. In first pregnancy, she gave history of some decreased fetal movement of 2 to 3 days before. So not investigated after first pregnancy, but after second pregnancy, she was evaluated on the behalf of, as she developed the heavy menstrual bleeding also. So after the second pregnancy, she was went to a doctor. She advised, at that time the HB was also low and platelet was also low. Then he advised her to go for a bone marrow aspiration. For bone marrow aspiration, and on that she was diagnosed with ITP. And for IUD, she was referred to us, but she did not follow up. So in pregnancy also, at 14 weeks they came. So only we did her APLA and autoimmune workup, which was negative for her.
Okay.
Thank you. Now we go on to the next presenter, Dr. Monica Sharma. She'll be presenting on persistent thrombocytopenia in pregnancy associated with Epstein-Barr virus. Her code is MIS10. I request all the speakers to please stick to the time limit. They should summarize in 1 minute so that the judges get enough time to ask questions. Dr. Monica Sharma.
Hello.
Yes.
Is my slide visible, ma'am?
Yes.
Okay. Good morning, everyone. I'm presenting a case of persistent thrombocytopenia in pregnancy associated with Epstein-Barr virus and B12 deficiency. The patient presented, the first introduction is thrombocytopenia is the second most common blood disorder in pregnancy after anemia, complicating almost 7 to 10% of all pregnancies. The most common causes of thrombocytopenia in pregnancy are gestational thrombocytopenia, hypertensive disorder, immune thrombocytopenic purpura, and other causes like viral and drug-induced in the same decreasing order. This patient, 28 years old female, booked patient, presented to us in 40 plus 3 week of period of gestation. She was gravida 2 para 1 and live 1 with the previous cesarean section 5 years back in view of fetal distress. When the patient presented to her on examination, there was pallor present, facial puffiness was there, abdominal edema was present, and on auscultation, bilateral chest crypts were there. Patient also had tachycardia at the time of presentation. On per abdominal examination, uterus was term size, estimated fetal weight was around 3 kg, the baby was cephalic, and fetal heart rate was 140 beats per minute. The patient went into the spontaneous labor. Before this, we transfused 2 units of Paxil because the patient was severely anemic, around 5.6 gram% of HB. And after receiving the second blood, patient went into the spontaneous labor. But meanwhile, it was detected to be a grade 2 MSL. So we took the patient for LSCS, and the patient delivered a healthy baby of 3.1 kg, male baby. The baby was vigorous and there were no GCA detected after birth. After 6 hours of post-op period, abdominal wall hematoma was detected. The patient was taken into the OT again and it was drained under GA. And a suction drain was placed. Around 50 cc of clots and blood was drained from that suture stitch line hematoma. Post-operatively, the patient, her blood investigations were sent and it came out to be, the platelet level came out to be 27,000. She received 2 units of platelet in post-op period. And after that, the patient was on antibiotics and routine antibiotics of Monosef and Metro, and an LGCA was given for the patient. After the second day, again her blood investigations were repeated, but there was again a trend of lower platelet count was seen. That is around 51,000, and her HB was also falling continuously. That was 5.9 gram%. With this picture, she received 1 unit of PCV and 1 platelet and 2 FFP was given to the patient. The patient was further investigated, and no as such evident reason was seen for persistent falling of HB and platelet. Patient was investigated with serum iron layer studies, which came out to be normal, and we also investigated her for B12 levels. Her B12 levels came out to be on lower normal side, which was 189. We also did a patient also came with a ultrasound of 21st February, in which hepatosplenomegaly was seen. With such picture, we took a hematology referral for the patient, in which they advised us for the Epstein-Barr virus to get done. We did her serology for Epstein-Barr virus, and it came out positive for both IgM and IgG levels. Uh, Before getting this Epstein-Barr virus done, we also tested her for dengue serology, as it is a common cause for thrombocytopenia. But she was tested negative for this thing. And after getting positive for IgG and IgM levels, the patient was started on, and also the B12 levels, the patient was started on injection Eldavit on alternate days for 5 doses. With this management, the patients gradually started improving the platelet levels, and her HB also started improving. Overall, the patient received 3 pack cells, 2 platelet, and 2 FFP in her entire hospital stay. We also did peripheral smear for the patient, in which microcytic cells along with megaloblastic cells were seen, and atypical lymphocytes were seen.
Dr. Mamta, we cannot see your screen. Can you please share your screen? Dr. Anjum, can you please take your phone call? Dr. Anjum, can you please take your phone call?
Yeah, I have disconnected it.
My screen is not visible, sir.
No, madam, it is important for you to
We can't
take the
see.
call,
We
please.
can't see.
Can you summarize it?
Yes, ma'am. Ma'am, the patient came to us with a anemic blood picture. Should I share the screen first, ma'am?
Yeah, you can try again, please.
The patient came to us with the anemic blood picture, but after the cesarean section, her platelet count was persistently low. We investigated the patient for the most common causes of decreased platelet count, but we investigated the patient for a decreased platelet count, but after ruling out all the common causes, we tested her for Epstein-Barr virus, which came out to be positive. And thrombocytopenia is also seen with this virus. And also that patient was on the deficient side of B12 level. We also gave her injection Eldavit, which is a combination of niacin, methylcobalamin, and folic acid and vitamin C. So patient improved with this treatment and the conservative management we gave her in the hospital stay.
Okay, we'll let the judges take the call now.
Was the baby also checked for this thing, EB virus?
Yes, ma'am. Not for the EBV virus, ma'am. Her platelet count, the baby's platelet count were checked and they were normal throughout the hospital care that the baby received.
And secondly, is the virus transmitted to the newborn also? To the
Ma'am,
fetus?
the vertical transmission is not seen as such. It is mainly spread by the oral secretions, mainly by the saliva. In young children, it is spread. The spread is there, but it is lesser than the adolescent in developing countries.
So in this case, you didn't check the newborn for the this thing virus?
No, ma'am, because by
Just
the
the
time
platelets.
we discharged the patient, she came out to be negative, and when we spoke to the pediatric doctor who was handling this patient's baby, they said that in our scenario, in lower socioeconomic status from which the patient belonged, it is common that the baby will get infected by 3 or 4 years. But right now, they didn't test the baby for it.
Okay, the baby is doing fine now?
Ma'am, the baby is fine. The patient became negative by the time she was discharged on 20th of March, and both were fine. And the patient significantly improved by the time she was discharged.
So as the previous presenter has said, role of the romiplostin. So is there any role of romiplostin in this case?
Ma'am,
Because it was persistent thrombocytopenia.
Ma'am, this patient gradually improved. There was no role of romiplastin as the previous presenter told me, told us in the presentation, because the virus impacts the platelets, but for a very brief period of time. And with the conservative management is good enough to handle such cases.
Okay, good presentation. Good.
Thank you so much, ma'am.
Dr. Shivani, Dr. Anjum, you'd like to ask any question? Let's go ahead.
Thank you. Now I call upon Dr. Astha Jain. She'll be presenting on interstitial pregnancy, a diagnostic dilemma. Her code is MIS 11. I request Dr. Astha Jain to strictly adhere to 1 minute time for summarizing her findings so that judges get enough time to ask the questions. There'll be additional points to stick to the timings.
Hello, ma'am. Am I audible?
Yes.
Hello.
Yes, please.
Good morning. Good morning, judges and everyone. Interstitial pregnancy is a rare variant of ectopic pregnancy, which is located in the interstitial part of the fallopian tube, accounting for 2 to 4% of all the ectopic pregnancies. It poses a diagnostic and therapeutic challenge in modern obstetrics. Despite the availability of modern diagnostic modalities, there is a difficulty in early diagnosis due to its location. The mortality of interstitial pregnancy is as high as 20% of all the deaths due to ectopics. Two interesting cases, one of ruptured and the other unruptured interstitial pregnancy, came to a hospital which were treated differently. The first case was a Gravida 2 Paraman live one who came to the emergency department with features of shock. Her USG was inconclusive, showing a heterogeneous lesion in the left lateral wall of the uterus, completely encasing the uterus and adnexa, suggesting of organized hemorrhagic tissue along with fluid in the pelvis and abdomen. An emergency laparotomy was done to confirm the diagnosis, which revealed the left ruptured interstitial pregnancy. The left salpingectomy, along with the left interstitial part of the fallopian tube, was resected, and the patient recovered uneventfully. The second case was a live 3 abortion 2 with complaints of irregular cycles since last 1 year and scanty menses in the last periods. Her per-vaginal examination showed an 8 to 10 week size uterus, mobile with no mass or tenderness in bilateral fornix. A USG showed a normal uterus with endometrial thickness of 6 millimeters and irregular anechoic area with surrounding echogenic area, suspicion of gestational sac. MRI confirmed the diagnosis, and since the patient was stable, she was taken up for laparoscopy, where her left interstitium was enlarged. It was dissected, and after histopathic examination, the diagnosis was confirmed. Ma'am, interstitial ectopic pregnancy carries a higher morbidity and mortality. The diagnosis poses a diagnostic dilemma in today's modern obstetrics. The USG finding of eccentric position of gestational sac and thinning of the myometrial mantle helps in differentiating the eccentric intrauterine and interstitial ectopic pregnancy. The most specific sign is interstitial line sign, that is an echogenic line connecting endometrial stripe to gestational sac. MRI helps in confirming the diagnosis. The finding of eccentric to gestational sac eccentric to the junctional zone. The diagnosis of interstitial pregnancy causes a diagnostic dilemma. Many patients with ruptured ectopic are in shock and do not give time for detailed radiological assessment. Advanced imaging, MRI, helps in confirming the diagnosis, or sometimes diagnosis confirmed preoperatively during the surgery. Thank you, ma'am. Hello. Ma'am, I can't hear you. Hello.
Hello, can you hear me?
Yes, ma'am.
I just want to know that any history of amenorrhea in the first patient?
Ma'am, she had complaints of amenorrhea in the last 6 weeks.
6 weeks.
Yes, ma'am.
So suppose she's case of this thing ruptured ectopic, is it going to make any difference in the pre-op diagnosis, that whether it is interstitial or what? In any case, we are going to put in the laparoscope.
Ma'am, at least we'll have an idea if there's a, ma'am, we'll have, there's a interstitial, if there's a ruptured interstitial pregnancy, ma'am, it has a very high mortality rate. So if we get to know about it, if we diagnose it early with the help of transvaginal sonography or MRI, it will help in the, it will decrease the morbidity and mortality of the patient.
But the thing is, suppose it's ruptured, so you're wasting your time in doing the MRI and all.
Yes,
you're
ma'am.
putting in the laparoscope.
If the
right?
patient is stable or not. Yes, ma'am. Since our patient is unstable, we just took her for surgery in less than 30 minutes after she came to a hospital.
Right. But you said that you did the MRI also.
Ma'am, while coming, she already got a USG done from before. She was referred to our center, and as soon as she came, within 30 minutes, we took her up for surgery. And the ma'am surgery was uneventful, and the patient is fit and fine right now.
Okay. Right. Dr. Anjum, Dr. Shivani?
The ultrasound which you mentioned that your patient brought, it didn't show any specific finding for an interstitial pregnancy.
No, ma'am.
And so how was that confirmed? In this 30 minutes, you got an MRI done and you confirmed the diagnosis?
No, ma'am.
Or it was based on the laparoscopic finding?
Ma'am, in the first case, we didn't get an MRI done. The USG was done by the patient. Ma'am, we did a UPT. Ma'am, the UPT was positive, and she gives the history of taking a medical abortifacient on her by herself. So it was confirmed that there is something, and her BP was 90/60. Her pulse was 130, and she had features of shock. Signs of peritonitis were present, so we immediately took her for emergency laparotomy. Over there, preoperatively, we found out that ma'am, the left interstitial part of the pregnant tube was ruptured, and there was hemoperitorium of about 2 liters.
Thank you.
Suppose she was not in shock, is there any role of methotrexate?
Ma'am, if the size of the ectopic is less, if the beta HCG levels are less than 10,000 levels, and if the patient is stable and does not have any kidney renal disease, ma'am, then there is a role of methotrexate, ma'am. But the only disadvantage of giving methotrexate is, ma'am, that patient has increased chances of persistent ectopic due to the presence of deeply embedded trophoblastic tissues.
So it's better to excise that area.
Yes, ma'am.
Okay, thank you.
Thank you so much, ma'am.
Thank you. Now we call upon the next presenter, Dr. Milo. She'll be comparing objective method of symphysiofundal height measurement with conventional method of fundal height measurement for detection of SGA. Her code is MIS12. Dr. Milo, you'll be given 1 minute to summarize and 2 minutes for discussion.
Is there or not?
Good morning, everyone. Ma'am, is my screen visible?
Not yet.
And Dr. Milo, please click on the share screen.
Are you able to share your screen?
Sorry, I'm unable to share my screen.
Okay, we can wait for you to troubleshoot. We can go on to Dr. Deepika if she's there. Dr. Deepika, are you ready? Okay, Dr. Milo can share it now.
Is my screen visible now?
Yes.
Yes. Good morning, everyone. My poster is based on a comparison of the objective method of symphysis fundal height measurement with the conventional method of fundal height measurement for detecting small for gestational age fetus. Assessment of fetal growth is an important aim of antenatal care. So conventionally, the fetal growth is assessed by the palpation of fundal height by clinician in OPD. And the objective method involves the measurement of symphysis fundal height by a measuring tape in centimeters. My study is a prospective observational analytic study. It was conducted on 120 pregnant women sure of their last menstrual period with a singleton pregnancy at or more than 28 weeks of gestation, attending the ANC OPD or admitted in wards. In each woman, the fetal growth was assessed by both the conventional and objective method. And these women were followed up serially and at least 3 readings were obtained. The symphysis fundal height which was measured was charted in the International Symphysis Fundal Height Standard Chart by the Intergrowth 21st project. The final outcome of the study was measured by the birth weight of the newborn, which was plotted on the International Fetal Growth Standard Chart by Intergrowth 21st project. And for the evaluation of the outcome, any newborn with birth weight below 10 centile for gestational age was considered as small for gestational age. By conventional method, a leg in the fundal height of 3 weeks from the period of gestation was considered significant. And by the objective method, any symphysis fundal height measure below the 10th centile for corresponding gestational age was considered as small for gestational age. In my study conducted, out of 120 pregnant ladies, 15 pregnancies resulted in birth weight with having fetal weight below the 10th centile for the gestational age. Of these 10, that is the 67% were correctly detected by the objective method of SFH measurement, and 8, that is around 53% cases were detected by the conventional fundal height measurement. The significance test when applied to my study suggested that the objective method is more reliable than the conventional method for detection. And also it has other added advantages, such as it provides a graphical record of changes in fundal height observed with the advancement of gestation. It also has a lesser inter-observer variation. It is more cost-effective than other methods such as ultrasonography, and it can be used by the primary healthcare workers even at the basic level. And my findings are part of an ongoing study, and the significance of the study can be determined by further readings. Thank you.
It's a very good presentation, very good topic also. And I think without any cost and all, without this thing, and it is just this thing, objective method of symphysis fundal height and conventional method of fundal height to detect the small for gestational age, right? So how many cases you did?
Ma'am, in the poster I have presented 120. And since it is a part of my thesis, ma'am, I am my study is now of 220 pregnant ladies as of now, ma'am.
And what was this thing? P-value was okay? Significant?
Ma'am, it was significant in this study for 120.
In this study?
Yes,
right.
ma'am. This study is going on, ma'am.
Okay, very good.
Dr. Milo, did you add abdominal circumference also along with it? Or it was only symphysis fundal height?
Ma'am, no, I have not added abdominal circumference. I have just measured the symphysis fundal height.
And did you correlate it with ultrasound, these patients?
Ma'am, yes. When we detected any patient in the clinic, in the clinics, then we admitted them in wards, did a workup, and then ultrasound was involved in that, ma'am.
How many patients were positive for IUGR or oligohydramnios? What was your finding?
Ma'am, out of the 120 pregnant women which I have included in my study, 15 were found to be, 15 were detected to be having IUGR. But the detection rate with the symphysis fundal height measurement only was 10, that is 66%.
Did you compare the 6 symphysis fundal height with the newborn baby's weight and the this thing ultrasound weight plus this thing weight of the baby born?
Ma'am,
did you do the comparison?
Yes, ma'am. I have compared it with the final birth weight of the baby, ma'am, in my study.
With your method, was it compared with the ultrasound weight also?
No, ma'am. My study did not compare it with the ultrasound weight. It was only based on the symphysis fundal height measurement and birth weight of the baby.
Okay. Right. Good.
Thank you. Now we go on to Dr. Deepika. She'll be presenting incidentally found placenta accreta in primigravida managed conservatively. Her code is MIS 13. Dr. Deepika, please summarize it in 1 minute so that judges can ask you questions comfortably.
My screen is visible, ma'am.
Yes.
Be short in your presentation, please. And
A
salient points only.
26-year-old primary gravida at 40 plus 2 weeks gestation presented with labor pains for 1 day and leaking PV for last 6 hours. She was unbooked case and her antenatal period and past medical and surgical history was uneventful. Her antenatal bed investigation and ultrasound reports suggested no abnormality. Emergency cesarean delivery was performed in view of failed progression of labor. Per-operatively, placenta failed to separate on its own and despite of appropriate measures. On examining, placenta was seen bulging out at the left corner of middle side as a boggy mass in a serosa of uterus as a bluish distended placental bulge, which was suggestive of placental invasion in serosa, but no, there was no breach on the serosa surface. After discussing with the all risk and consequences, patient opted for the fertility preservation and conservation of the uterus. So prophylactical bilateral uterine artery ligation was done to reduce the risk of hemorrhage. And post-operatively, uterine artery embolization was done as an adjunctive measure for the prevention of the PPH. Post-operative period was uneventful with the 3 months and the 6 months ultrasound with the Doppler for follow-up showing no evidence of the vascularity and no signs for the hemorrhage and infection. And the patient is still on further follow-up till the complete resorption of the placenta. So we can go for uterus conservation in primary gravida patient in cases of the placenta accreta syndrome.
Very good, very well managed. But the thing is, suppose the patient is bleeding, can you leave the placenta in or you have to take action?
Ma'am, if the patient is bleeding, then we have to take the placenta out. But we have to do hysterectomy. But in my case, patient was stable, ma'am. So we go for conservative management only.
Secondly, was methotrexate given to this patient
No,
in the
ma'am.
post-op period?
No, ma'am. Methotrexate was not given, ma'am.
So how did you follow up the patient? This patient, you had left the placenta and just waiting and watching for any bleeding and infection to occur, or anything else you were doing?
Ma'am, post-operative uterine artery embolization was done, ma'am. And we followed that patient at 3 months. 3 months and 6 months with the USG and Doppler. At the 3 months of USG Doppler, there was no vascularity and the size of placenta was 7.5 into 3.5 centimeter and 6 months was 5 into 3 centimeter, ma'am, with no vascularity.
But she didn't expel the placenta later in the post-operative period or postpartum period.
She didn't expel, ma'am.
It got absorbed.
Yes, ma'am. This option is there.
Okay. So what is the risk of, did you do the ligation in this case? She was primary gravida, no ligation, na?
No
So
ligation.
what advice did you give to the patient? What's the chance? Because first pregnancy, was there any history of DNC previously? Because why should placenta accreta occur?
There was no history of any uterine surgery, no history of myomectomy or DNC, ma'am. She was primary gravida. It was incidentally found, ma'am.
Future pregnancy, what do you want to tell her now? When can she plan pregnancy and what are the risks for future pregnancies?
In future pregnancy, there can be incidence of presence of placenta accreta syndrome in the next pregnancy also, ma'am. So she has to follow very closely with from the first trimester of the pregnancy for myometrial thickness and all, ma'am. So that
should you counsel her for next pregnancy or sterilization should have been offered?
At that time, ma'am, she was her baby was fine only, but we need to counsel. We have counseled her for not being pregnant for next 2 to 3 years, ma'am. But after, if baby is healthy after 2 to 3 years, then we can counsel her not to be pregnant again because there is high chance of placenta accreta syndrome again, ma'am.
Okay.
So what are the chances of fertility, impaired fertility after a uterine artery embolization, which you have given to this patient, and what are the other complications apart from placenta accreta spectrum that you will tell this patient that she might have in her future pregnancy?
After uterine embolization, ma'am.
Yes, you have offered this patient uterine
Infertility.
embolization.
There can be infertility, ma'am, in the neck.
And others?
Ma'am,
can there be an
sexual
chance of
dysfunction,
miscarriage?
ma'am. Sexual dysfunction, infertility can be there, ma'am. If the embolus is gone in external iliac artery, there can be gangrene.
So that are the like immediate and late complication of uterine artery embolization. So for this patient particularly, you will counsel her regarding all the complications that has happened, that can happen with the treatment you have offered her, not only the placenta theta spectrum. Okay.
Yes, ma'am. Immediate complications like hemorrhage, sepsis, and excessive bleeding, so that she can be offered. She can need emergency cystectomy, ma'am.
Okay.
Thank you. Now I call upon the next speaker, Dr. Priyanka Naik. She'll be presenting a rare case of perforating IUCD mimicking Nabothian follicle. Her code is MIS14.
Hello, ma'am. Am I audible?
Yes. You can summarize your case in 1 minute.
Here is a rare case of perforating intrauterine copper contraceptive device mimicking like a Nabothian follicle. My case, a 22-year-old female, Paravan living one, LSAs, presented in a family planning OPD with the complaints of prolonged cycles and lower abdominal pain since 2 months. She had a history of intracaesarean copper-T insertion, which was expelled spontaneously 2 months later. Reinsertion was done by a paramedical staff at dispensary. After 8 months of reinsertion, she complained of lower dragging pain, for which ultrasound was done, which reported IUCD displacement downwardly in the lower part of uterus and cervix. In a view of misplaced IUCD with the lower abdominal pain, multiple attempts were made for the removal but failed, for which she was referred to Safdarjung. In Safdarjung Hospital, proper workup was done, and on perspecularum examination, a thread was seen in her external os, and a white protrusion was seen at a 10 o'clock position of the anterior lip of the cervix, which is seen in figure 1. On pervaginal examination, this protrusion was knobby and hard to touch with mild cervical motion tenderness was present. On hysteroscopic examination, a perforating anterior lip of the cervix was seen, which was covered with a thin epithelium left over the knob, and which is seen in the figure 2. And in figure 3, the horizontal limbs were embedded at the internal os. By this, this is a rare, my discussion goes, this is a rare complication where there's a paucity of literature. In this case, ultrasound only reported downward displacement, but it could not identify the perforation. And the difficulty in removing shows that shows that partially perforating IUCD removal may be more challenging than complete perforation. As in a complete perforation, there can be a fistulous tract formed through which this copper-T can be removed. The cause of the pain might be due to the irritation of the cervical afferent fibers by the IUCD limb, which was relieved by copper-T removal. And my conclusion goes here is that there is a paucity of literature, and also there are initiatives by the government of India for training the staffs for proper insertion of the IUCDs, or there might be a decreased or underreporting of the cases. So my recommendation for this case is to prevent such complications as previously cesarean deliveries, copper-T insertion should be done by a gynecologist. Thank you.
After the insertion, was the follow-up done in this patient, or no? Just she came with the pain only first time.
Actually, she had come with a pain of a lower dragging pain only with the pain she had come, ma'am. And then we followed up on the same setting with a sperm examination and pervaginal examination, and she was dated for her hysteroscopic examination, where we could find out that there was a perforation, partial perforation in the cervical lip, and then it was removed in the same setting.
That you have told, Maybe it was the false passage which was made at the time because it was done by a paramedic.
Ma'am, maybe that it might
It was not that trained.
Ma'am,
right? So I think maybe I think patients should be followed up this thing maybe 1 or 2 months after the insertion to see that whether it is in place or not.
Yes, ma'am. In our hospital, we follow them as 1 month, 3 months, and 6 months, and yearly.
Right. Good. Dr. Shivani, Dr. Anjum, would you like to ask any question? I think we are running short of time. We are always already late.
Yes, ma'am. We can move forwards.
Thank you.
Thank you. Now I call upon Dr. Shivani Arora. She'll be presenting a curious case of Van Wyck-Grumbach syndrome. Her code is MIS 15. Dr. Shivani, please summarize your case in 1 minute so judges can ask you questions.
Yes, ma'am. Good morning, everyone. Today I, Shivani Arora, junior resident from AIIMS Rishikesh, will be presenting my e-poster, which is on a curious case of Van Wyck-Grumbach syndrome, a rare cause of precocious puberty. I'll firstly how she presented to us. Van Wyck-Grumbach syndrome is a rare presentation of long-standing pre-pubertal hypothyroidism. So we go back in 1960s where Mr. Van Wyck and Mr. Grumbach described a syndrome which was characterized by breast development, multicystic ovaries, and uterine bleeding in the presence of a long-standing primary hypothyroidism. So overall, this syndrome ensembles bilateral multicystic ovaries with vaginal bleeding and precocious puberty. Now moving on, the case presented to us was of a 4-year-old female from Amritsya village of Haridwar, which was brought to the emergency with complaints of bleeding per vaginum since 4 days, for which a medical legal case was registered by the emergency team. But there was no history of trauma, foreign body insertion, or any sexual assault. Her mother noticed easy fatigability, intolerance to cold, and abdominal swelling for the last few months. But there was no family history of precocious puberty, autoimmune disease, or any consanguineous marriage. Now, upon physical examination, the child was conscious, irritable with pallor, edema, bradycardia, and tachypnea of 24 breaths per minute. Her height, weight, and head circumference were all falling short by -2 to -3 standard deviations for her age. As you can see in the picture, she showed global developmental delay with coarse facies, depressed nasal bridge, protruded tongue, and generalized puffiness, delayed dentition, microcephaly, short stature. Other than that, umbilical hernia and dry, rough skin. Moving on, she had Thilarp of Tanner stage 1 with absence of pubic hair and non-palpable thyroid glands. When we did a per abdomen examination, she had palpable 7 to 9 centimeter firm non-tender mobile mass in both the iliac fossa with absence of fluid thrill. On hormonal profile, which was done, it revealed decreased levels of free T3, T4 and luteinizing hormone levels and increase in the levels of serum TSH to up to 699 with prolactin and FSH. CA125 levels were within normal limits. Now, this was followed by an ultrasound, whole abdomen, which was suggestive of bilateral multiloculated cystic ovaries, which could be due to myxedematous infiltration of the ovarian stoma. Then pituitary hyperplasia with left temporal nodular granular neurocysticercosis was seen in MRI head. A thyroid gland was normal in position with thyroid hypoplasia, which was seen in breast and neck. X-ray was suggestive of X-ray of the left is done, which revealed delayed bone age by 12 months and epiphyseal dysgenesis. Now with high TSH and radiological findings, a diagnosis secondary to severe hypothyroidism, that is Van Wyck-Grumbach syndrome, was made, and she was promptly started on oral levothyroxine, 75 micrograms, tab dexamethasone, and syrup albendazole for neurocysticercosis. On follow-up, which was done after 1 month, she had no vaginal bleeding, rising free T4 levels, and gradual decrease in the size of bilateral ovaries. Thank you.
Dr. Shivani, it was an excellent case, huh? So I think we should keep in mind about this thing and we should see for the high TSH. TSH was very, very high in this patient.
Yes, ma'am.
So now, how is the child doing?
Ma'am, she is well, but ma'am, because according to 4 years of age, we did not see the milestones that were supposed to develop by 4 years of age. Rather, she was lacking behind 2 years. So, in the last follow, which was done in the month of July, ma'am, the TSH levels were approximately 106 with free T3 and rising free T3, T4 levels. Free T3 was approximately 1.3 and even FSH came down to 9.
And what was the TSH level of the mother? Was the mother hypothyroid? Maybe she was hypothyroid during her antenatal period also when she was carrying this.
No, ma'am. No, ma'am.
And did you do this thing, thyroid levels in the mother?
Ma'am, we asked the history, but there was nothing there. But we did not. No, ma'am. But we just took maternal history, and there was nothing in the autoimmune history in the family. And my antenatal visits were all uneventful, ma'am.
So I think this thing in early pre-pubertal age, although it is just child only, 4 years, we should keep in mind about this thing, hypothyroidism also.
Absolutely, ma'am.
Right.
And ma'am, I went into literature and I saw 2 other cases which were reported outside India. And ma'am, those cases presented with cystectomies and oophorectomies. They were admitted for cystectomies. So that is why I went to literature. Then I diagnosed that it is a syndrome which is very rare to find. And we treated it conservatively. So we prevented the child from all, the family from all sorts of anxiety and fear of malignancy.
Very good.
Thank you, ma'am.
Well presented. Dr. Shivani, Dr. Anju?
Outside, you said the phase 10. What is the outcome for these babies in the literature?
Ma'am, we have only 2. I saw only 2 case reports in the literature, ma'am. Both were treated with conservative management, ma'am. So we do not know whether it deteriorates or is there anything.
I think you should follow this case. It's quite interesting case. Nicely presented. Thank you.
Thank you. Now we go on to the next presenter, Dr. Sunita. She'll be presenting an uncommon hemoglobin variant. Her code is MIS16. Dr. Sunita, please summarize your case in 1 minute so the judges can ask you questions.
Am I audible?
Yes.
Good afternoon, judges. I am presenting a case of 32-year-old antenatal woman, G2P1L1, 38 weeks, presented with labor pains and PROM. Antenatal period was uneventful, but she was diagnosed to have an uncommon hemoglobin variant, HBT Punjab, of heterozygous variety. She had non-consanguineous marriage, no chronic illness in the past. Previously, she had normal delivery, but it was undetected. She's a resident of Delhi, but no ancestors from Punjab. Examination revealed that she was in early labor. So we can see the inheritance patterns of hemoglobin B Punjab. It can be heterozygous, homozygous, and associations of thalassemia and sickle cell anemia. Though heterozygous and homozygous they do not cause much clinical manifestations. Association with thalassemia and sickle cell anemia, they can cause moderate to severe hemolytic anemia picture. You can see the HPLC, D window of HPLC. Investigations of B positive blood group, HB 11.6, and rest of the red cell indices were normal. He spontaneously delivered a 3.1 kg baby with no complications in GTB hospital. We carried out HPLC of the husband and it was normal, and the first child HPLC showed similar heterozygous status. The use of hydroxyurea is proven beneficial. There were 2 cases reported of malignancies also, but we don't know whether it is coincidental or further cases are required to prove it. So my conclusions are, since HBD Punjab potentiates sickling, we have to be careful to prevent severe occlusive events and ischemic stroke-like events. Since India is a thalassemia belt, to diagnose hemoglobinopathies, we have to screen the patients with Nesterov test, and to diagnose electrophoresis and HPLC are to be used, and molecular techniques when we need genetic screening. So I would like to enlighten that screening of the spouse is very important here to diagnose at a pre-symptomatic stage to give better management. Thank you. Hello?
Dr. Anjum, you can ask the question, please.
Hello, I cannot see the screen, please.
Yes, ma'am. Is it fine, ma'am? No?
Yeah. So this was a book case of your hospital?
No, ma'am. She was showing in a private hospital, and during her routine antenatal checkup, she was diagnosed with this variety.
Okay.
So
if supposedly she came to you in early antenatal visit and you diagnosed her with the case of hemoglobin D, what all further investigations and what all thing you will keep in mind for her antenatal, visits?
Ma'am, I would like to ask the ancestral history, and especially usually we do all these investigations when we find anemia picture. Mainly the red cell indices I would like to carry, I would like to do. And if she's a known case, if she belongs to anemia picture, then Nestrov test I would like to do. If it is positive or doubtful, then electrophoresis or HPLC, mainly the cation exchange HPLC I would like to carry out, because both are complementary to each other in diagnosing. And if in antenatal period this can be done, in future pregnancies, if she had any complications in the previous pregnancies, then I would like to go for molecular techniques, especially if the spouse is a if there is association with thalassemia or sickling.
So you have to test the spouse first.
Yes, ma'am.
And then whether there was any adverse outcome in the previous pregnancy.
No, ma'am, it was actually undetected in previous pregnancy. Only this pregnancy she had, since she was in antenatal checkup with private practitioner, this was diagnosed accidentally.
Okay.
Thank you.
Thank you, ma'am. Thank you so much.
Now we go on to the next presenter, Dr. Sumera Neha. She'll be presenting an unusual presentation of invasive mole. Her code is MIS 17. Dr. Sunita, you can stop sharing your screen. Then Dr. Sumera can share it now.
Yes.
Good afternoon, anyone. Hello?
Hello, you're audible.
Okay. Let me share my screen.
Yes, please share your screen.
Okay. Is it visible?
No. Are you able to share your screen, Dr. Sumera?
Yes.
Yeah, we can see it now.
Okay. So is it visible now?
Yes. You can summarize your case in 1 minute.
Okay. A 34-year-old Gravida 3 para 2 living 2 women with 7 weeks pregnancy took MTP kit outside following a positive UPT. And there was no bleeding following the intake of the medicine. So ultrasound was done and repeat kit was taken by the patient. And this was followed by the bleeding for a few days. Due to persistent positive UPT, she had an ultrasound which showed 10 weeks miscarriage. Dilatation and curettage was done for the failed medical abortion. A repeat ultrasound was done next day, which showed empty cavity. After 15 days, again ultrasound was done, which was suggestive of the query scar pregnancy with a volume of 40 cc, and beta HCG was done, which showed 3,788 levels. Following the CBC, KFT, LFT of the patient, injection methotrexate 50 mg IM was given. Again, after 7 days, beta HCG was done, and which shows 366 levels, and ultrasound showed 30 cc volume. And MRI was done, which is suggestive of the invasive mole. Then the patient was referred to the oncology department for the further management, where she is being treated with injection methotrexate 80 mg IM and tab Ricovorin 15 mg alternatively for 8 doses. Hello? Hello?
Yes, you're audible.
Yes,
So yeah, this thing, I think every time when you're doing the MTP, one thing is that ultrasound must be done. Secondly, that products should be sent for histopathology. Otherwise, you can miss the molar pregnancy. And
yes, ma'am.
good.
So in this case of invasive mole, you didn't go for a hysterectomy?
No, ma'am. We didn't go. We
Because
referred the patient to the onco. No, ma'am. We referred the patient to the onco department to take the conservative management. Like.
But do you think offering her hysterectomy would have been a better option?
Yes, ma'am. Since the patient is multigravida and
Depends upon her choice. So
yes, exactly.
The judges like to ask any more questions?
Go ahead with the next speaker.
Now I call upon Dr. Surbhi. She'll be presenting a uterine AV malformation, a raging wildfire. Her code is MIS 18. Dr. Surbhi?
4 रहते हैं अभी इसके बाद.
Hello.
Yes, Dr. Surbhi. You can share your screen. We can see it. You can summarize your case.
51B. 51B continuously means TCT8 sugar control.
Dr. Surbhi, you can summarize your case.
Dr. Harsha, please unmute yourself.
Dr. Surbhi, you're not audible.
Hello?
Yes.
Surbhi, no, I'm her speaking. So this is uterine artery. Dr. Surbhi, I think you can start presenting.
Yes. Am I audible?
Yes, you are.
Yes, ma'am.
Yes,
My patient is a 28-year-old P2L0 female who presented with continuous bleeding at post-op day 35 of cesarean section. On examination, she was hemodynamically unstable with the pulse rate of 104 per minute. Her blood pressure was 90 by 58 mm of Hg. She was pale. Clinically, she was 5 to 6 grams.
Sorry to interrupt, but I
CT
think just
findings
give
were
the
normal.
sorry to interrupt. Just tell us the salient points.
Yes, ma'am. Yes, ma'am. Ma'am, the patient presented to me with the bleeding per vagina. The patient was hemodynamically unstable, so we transfused her 3 PRBC and we put her on tranexamic acid and IV antibiotics. After being hemodynamically stabilized, when the patient was hemodynamically stabilized, we took her for the ultrasound. On ultrasound, we did the transvaginal ultrasound with color Doppler, which showed endometrial thickness of 21 mm with increased vascularity with multidirectional flow of the uterus. There was mosaic pattern of blood flow within the cystic spaces of uterine body. Along with this, there were retained product of conceptions, which further complicated the diagnosis. This was followed by dilatation and evacuation since we found the RPOCs on ultrasound. But even after the dilatation and evacuation, the vaginal spotting continued. So we did her MRI. The subsequent MRI imaging showed it confirmed a uterine arteriovenous malformation, which was masquerading as retained product of conception. Which multiple tortuous vessels. The patient, after this, we put the patient on oral progesterones, and after 6 days, her bleeding was controlled. So, the patient was further discharged on oral northisterone in a dose of 10 mg and she's currently under follow-up. Currently, the bleeding is controlled and the patient is at follow-up, ma'am.
Very good. You could save the uterus. That means.
Yes, ma'am. Ma'am, since she had no live issues, so we wanted to go for conservative management.
I think conservative management is always better. So
you didn't suspect this in ultrasound, or you had to do a MRI?
Ma'am, actually on ultrasound, there were both pictures. We could find the ROCs and we could find multidirectional flow inside the uterus. So we decided to go for the
so during
Dr. Surbhi, you are not audible.
Yeah, not at all.
Dr. Surbhi, your connection is lost.
Hello.
Yeah.
And Dr. Surbhi, at the time of
am I audible?
Hello. Can you hear me?
Ji, ma'am.
I'm just asking you that on the 35th day of the cesarean section, she had the bleeding and all. So during cesarean, what precautions you should take to prevent this AV malformation and all?
Ma'am, we should not, when we evacuate the placenta and when we take out the placenta and membrane, we should avoid the instrumentation of the uterus while doing any procedure.
For removing
that we do
placenta,
not-
do you use any instrument?
No, ma'am. मतलब उसका DNAs भी हुए थे तो while
That was later on. That is, it should be spontaneous expulsion of the placenta. Wait and watch, so that all the placenta is. Once you start removing with your hand, you can always leave little bit of part of the zinc placental tissue inside the cavity. Okay, we can go ahead with the next, I think.
Thank you. Dr. Sabina has already delivered her presentation. Judges, please note, MIS 19 has already delivered. So now it is Dr. Shalini Singh. Gas gangrene of the uterus following surgical abortion, a rare case report. MIS 20 now.
Hello, am I audible?
Yes, Dr. Shalini, you're audible.
Good afternoon, everyone. My case report is a rare case report of gas gangrene of uterus following a surgical abortion. My case report is about an 18-year-old young female married for 3 months who presented to us as a referral from other maternity hospital with the provisional diagnosis of peritonitis and with complaints of pain, fever, abdominal pain, fever, and vomiting for past 24 hours. After thorough evaluation of her history from her relatives, as the patient was semi-conscious when she came to us, we found out that the patient had 3 months amenorrhea and underwent surgical evacuation for incomplete abortion 36 hours back. On presentation, the patient was semi-conscious. She had a pulse rate of 140 per minute and the BP was not recordable, and her SpO2 was 93% with a respiratory rate of 22 per minute. The patient was febrile to touch and her temperature was 103 degree Fahrenheit. On per-abdominal examination, she had extreme guarding tenderness and rigidity, and PS showed brownish discharge, and the PV was revealed or closed. The bilateral fornices were full and the exact size of the uterus could not be made out. Her blood picture was normal in nature. Her LFTs
I'm sorry to interrupt you, but I think you can just tell us what led you to think of that it is gas gangrene of the uterus.
Yes, ma'am. Ma'am, since the patient, when she came to us, she has a non-recordable BP. We stabilized her on nodded, and then
Tell me 1 to 3 points. I'm just asking you, tell me the points which led you to think of that it is gas gangrene.
Ma'am, when we took her up for the after stabilization, when we took her up for ultrasound and for X-ray, we found out air under the diaphragm, and we found out presence of gas within the USG in the uterine cavity, which led us to and her thorough deterioration led us to a suspicion of gas gangrene. When we opened the patient up, we took her up for emergency laparotomy, which showed presence of the bowel was explored. There was no sign of any bowel perforation, and the past history of DNC was one of the reasons we suspected gas gangrene. When we opened her up, we found 1.5 liter of turbid fluid with pus flakes, and the serosa had air blebs, which is found in cases of gas gangrene. And as it could be seen in the picture as well, the right side of the uterus showed presence of 5 into 4 centimeter of necrotic area, and the serosa has blebs over it. So we provisionally diagnosed her as a case of gas gangrene. Was
the culture done?
Ma'am, we lack the facility for anaerobic culture, but we did send the patient's uterus for histopath, and the histopath was very much correlating with what we find in clostridial associated infections. The endometrium was very thin, the myometrium was thin, it was just 1.5 centimeters, and the vessels were filled with necrotic debris.
Post-op period was okay?
Ma'am, post-operatively, the patient deteriorated even more. We, after the surgical management and thorough wide spectrum antibiotics, her KFTs and LFTs deranged. She underwent, she had to be started on 3 inotropes. Despite all the efforts, she went into MODS followed by consumptive coagulopathy, and she died on post-op day 6. We were unable to. Yes, ma'am. Ma'am, the
It's a
basic.
deadly infection.
Yeah, it is a deadly infection. Ma'am, my most important point regarding my poster is if she would have presented a bit early to us when she was conscious, when she just started developing fever, when she started having pain abdomen just after the evacuation, might be if we took the similar steps at that point of time, we would have saved the patient.
Right. Okay. Dr. Shivani, Dr. Anjum.
Yes, ma'am. How long back did she have DNC?
Ma'am, she presented to us after 36 hours of DNC. She underwent a DNC at a maternity hospital. After that, when she was discharged on the same day. When she was discharged, since evening, she started developing pain, fever, and she was having pain, fever, and she was having continuous episodes of vomiting.
So
and
see
ma'am,
how
one more. Yes, ma'am.
See how important it is to have this thing, asepsis.
Yes, ma'am. Ma'am,
Under
it
order.
is. I want to highlight one thing. This is a case which could have gone to a surgical department as well, apart from gynae. So whenever there is a history of any surgical intervention which has been done in past, we should thoroughly evaluate the patient, be it a gynecologist, be it a general surgeon, and emergency laparotomy should be done. So that a surgical debridement could be done easily and the source of infection could be removed as soon as possible.
What was the counts? Just asking, what was the counts?
Ma'am, when she came to us, her counts were normal. However, the blood picture showed neutrophilia. Counts were 10,700. However, the neutrophils counts were raised. Ma'am, 92 were the neutrophils counts.
So when this patient presented to you, didn't you think of like bowel perforation secondary to this DNC?
Ma'am, when she came to us, she came with a diagnosis, provisional diagnosis of perforation peritonitis. We did think of it, but when we stabilized the patient and we saw that she had undergone, we evaluated the history as well. When we saw that she had undergone surgical evacuation and her USG showed presence of air within the uterine cavity, we suspected that something, uterine perforation might have occurred, which would have led to a bowel perforation. So we opened her up, we called the surgeons in as well, and we performed the surgery. The bowel exploration didn't reveal any kind of perforation within the bowel. However, the uterus was found to be necrosed on right side.
Good. So Ankita, let's go to the next case now.
Thank you.
Thank you.
Now I call upon Dr. Rishi Agarwal. Early stage carcinoma endometrium with fertility preserving management, code MIS 21. Dr. Rishi Agarwal, you can start sharing your screen.
Hello. Am I
Dr. Rishi
audible, ma'am?
Agarwal? Yes.
You're audible, but screen is not showing any slides.
Are you able to share your screen, Dr. Rishi Agarwal?
I've shared my screen, ma'am.
Dr. Rishi, please click on share screen. Hello, Dr. Rishi.
Sir. So I'm not able to share my screen.
Please click on share screen.
Dr. Rishi, is it the same case which was presented in AOGD monthly meeting by R&R Hospital? Looks like it's the same case you're going to present.
Sir, yes, ma'am.
So I think there should not be two presentations at the same thing. Last month only your hospital presented it, and now you're presenting it as a poster.
Okay, ma'am. Ma'am, shall I just read my presentation, ma'am?
Just tell us the salient points, that's all. Just salient points, just take 1 minute to present your case because we know about your case.
Okay,
It was
ma'am.
beautifully presented, but it's
Yes,
just a
ma'am.
repetition now.
Okay, ma'am. Ma'am, the salient points are 36-year-old Nali Gravida, ma'am, for evaluated for infertility. She came to R&R hospital with abnormal uterine bleeding. She has been married for 7 years, but no kids for last, but trying for conception from last 4 years. Before coming to
We
hospital,
can't see, sorry, we can't see the slide share is not there. We can see your photograph only.
Dr. Rishi,
yes, ma'am.
are you able to share your screen?
No, ma'am.
Ma'am, in the meantime, should we ask Dr. Akansha Gupta or Dr. Sunaina to present?
Sure, Ankita, I think we can call because we are already late.
Yes, ma'am. Dr. Akansha Gupta. Please summarize your case in 1 minute. She's MIS 6. Judges, please note. MIS 6.
Akanksha. Just tell us the salient points only, please. She is not there.
Dr. Akansha, can you unmute yourself?
Ankita, I think call number 7 because we are wasting time.
Dr. Sunaina?
Yes, ma'am.
Is this Dr. Sunaina?
Yes, ma'am.
Can you please share your screen?
Yes, ma'am.
Dr. Sunaina is presenting now. She's MIS 7.
Good morning, everyone. My case is a case report on the management of a referred case of intraoperative extensive bladder trauma during LSTS. I will move directly on to case presentation. A 29-year-old para 2 live 2 was referred from a private hospital on post-op day 6 of emergency LSTS performed in view of previous LSTS not willing for TOLAC in labor. Her vitals were stable, but she was grossly pale. Her hemoglobin corresponded to 16%. She was referred with chief complaints of abdominal distension and anuria. An emergency ultrasound was performed, which showed intraperitoneal hypoechoic collection of nearly 1500 ml. Paracentesis confirmed a bloody tap, so she was taken for emergency laparotomy. On opening on exploration of the peritoneal cavity, uterus was well contracted and bilateral adnexa was normal. Bladder anatomy was grossly distorted as is shown in figure 1. Dome of the bladder and anterior wall of the bladder was completely deficient, showing inflated Foley's catheter bulb as shown in figure 2. Posterior wall had a vent of shape 7 with vertical stem lying between the two ureteric orifices. 11 into 15 centimeter clot along with stocklet fluid was suctioned from between the rent lying behind the posterior wall of bladder. Urologist joined the case, and after careful inspection of the bladder anatomy, bilateral degestenting was done to confirm the patency of the ureters. Bladder was sutured in 2 layers with absorbable sutures. On successful repair, the repair was successful, but the capacity of the bladder was significantly reduced to nearly 50%. So here there was delay in the referral from the referring hospital, since the most important prognostic factors in bladder repair is intraoperative recognition and surgical correction. So the referring hospital actually delayed the referral of the patient. So On conclusion, women undergoing emergency LSTS with high risk should be managed with multidisciplinary team. Although urinary tract injuries is a dreaded complication for any obstetrician, injuries identified promptly and managed appropriately are associated with favorable outcomes. Thank you.
In this case, was it a surgical injury to the bladder, or it was a rupture of uterus which led to this thing?
No, ma'am. Uterus was completely normal. Only a Kerr's incision was present in the lower segment, but the bladder was probably injured during the surgery process.
Surgery. And it was the lower segment cesarean section which was performed?
Yes,
or
ma'am.
upper segment? It was not classical.
Yes.
Okay. So what difficulty can be there by stitching the bladder in such an injury? Because it's the posterior wall. It's the anterior wall which is gone and posterior wall which is adherent to the uterus. So what problem you can have in stitching the bladder?
Ma'am, first of all, we can injure the ureters and the ureteric orifice, the trigone.
Yes, that is the main, the trigone area,
Which will lead
because you can always stitch that area, that both the ureteric orifices. Yes. Good.
Yes,
and how did the
trigone area was
patient do
also
later
involved,
on? Later on, she was all right. Was the suprapubic
patient
hysterectomy also done?
Yes, ma'am. So, suprapubic hysterectomy was also done, and the catheter was removed on day 21, on day 14, after the clear urine was passed in Foley's catheter.
Right. Patient is doing fine?
Ma'am, she is doing fine, but her bladder capacity is significantly reduced
course.
to 200 ml.
Because that part has been removed. Good.
Yes, ma'am. Yes.
Right. Dr. Shivani, Dr. Anjum, you want to ask any question?
What was Dr. Sunaina, what is the most common site of bladder injury in a cesarean?
Ma'am, bladder injury, it's usually at dome of the bladder. Ma'am, 95% of the bladder injuries occurred at the dome.
Okay, and how early can you diagnose them? And what features suspect that there is a bladder injury?
Ma'am, during operation, extravasation of urine can be present. Appearance of Foley's bulb, if there is gross rent, then Foley's bulb will be visible. There will be gross hematuria in the urobag, and visible detrusor muscle laceration can be seen. If any.
Post-operatively, how early can you recognize them?
Ma'am, post-operatively, we can check for the urine in the urobag, which will show hematuric urine, or patient will have oliguria or anuria. There will be lower abdominal pain or flank pain. There can be signs and symptoms of peritonitis, sepsis. On investigation, there can be increased blood urea nitrogen.
Did you send this fluid for paracentesis for any blood urea or any creatinine?
No, ma'am. Paracentesis fluid was not sent.
It was not sent. And how was the KFT, this patient?
Sorry, ma'am?
KFT, how was the kidney function test?
Ma'am, kidney function tests were normal.
What do you expect in KFT, kidney function to happen?
Ma'am, normally we would expect that the urea and creatinine will rise in these kind of patients, because she actually presented with anuria.
And how long did you keep stent? Normally, how long do you keep your stents?
How long, ma'am? What?
Stents. Ma'am,
DJ stenting was done just to check the patency of the ureteric orifice.
Okay. You did not keep it for long. You just kept it for temporarily.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
To involve urologist, yes.
Yes, ma'am. That's right.
Okay. Thank you, doctor.
Thank you. Is Dr. Akansha there now? Dr. Akansha, are you ready? Dr. Rishi?
Zaima, please, Papa se keh dena, Puppu ka call aa raha hai.
Dr. Rishi Agarwal, are you ready now with your presentation?
Dr. Ankita?
Yes.
Rishi has been cancelled, his presentation. Yeah.
Cancelled.
Yeah.
Okay. And Dr. Akansha, are you ready now? I think she's not able to connect.
Ankita, which has been cancelled? Which number?
Dr. Rishi Agarwal, ma'am. MIS 21.
Okay.
If Dr. Akansha is not there.
So should we consider them in the marking now?
Dr. Akansha. Hello.
Dr. Akansha, do you want to connect later in the next session? She's not able to connect, so we can move her to the next session. I can pass the baton now to Dr. Tarun Das for the third session.
Dr. Ankita, thank you very much for giving us this opportunity, and it was nice.
Thank you, judges. Thank you.
And it was very
Thank you so
lively
much.
session.
Thank you.
Thank you so much.
Yeah, thank you so much for making us a part of this online e-poster presentation. It's on altogether a new experience for us also.
Thank you
And
so
all
much, dear
the
judges,
presenters
for your
are very
precious
kind.
time.
And thank you, AOGD. Team AOGD, Team Gangaram.
Thank you, respected judges, for your precious time, and the delegates for presenting.
Thank you.
Thank you, Ankita. Good afternoon, everybody. I'm going to start the session 3. We are running short of time. I would like to invite and welcome our judges. I would like to call upon Dr. Chitra Setia. Ma'am is the senior consultant and head of the department of Obs and Gynae, Apollo Hospitals, Noida. Welcome, ma'am. Hamdard Institute.
Dr. Tarun, can we start? Hello.
I think he's unable to connect, so we'll introduce the judges. This session has Dr. Chitra Setia, Dr. Nidhi Gupta, and Dr. Geeta Mendirata, who will be judging this session. Also, I think the e-poster sheets, the marking sheets would have reached them, and they would have gone through the primary posters once and would have marked them on 3 heads. The idea here is to ask the candidate to summarize their findings and, of course, ask questions. So may we now invite the first speaker for this session, Dr. Pragati Agarwal, whose poster that will be displayed now is on transplacental COVID antibodies and cytokine storm in newborn bodies. Antibodies do not confer protection. Dr. Pragati, please.
Good afternoon, everyone. This is Dr. Pragati Agarwal presenting a case report as poster in today's session on topic transplacental COVID antibodies and cytokine storm in newborn. As you know, in this COVID pandemic, pregnant women and neonates are at increased risk of negative outcome of COVID infection, but limited data is available on neonates. In my case, a multigravida 37+4 POG, labor was induced in view of chronic hypertension and asymmetrical fetal growth restriction. Her COVID antibodies were positive. Cesarean was done in view of fetal distress. Boy baby was delivered with birth weight of 1.6 kgs with APGAR 5 and 8. Baby had external congenital anomalies. Baby was shifted to NICU for observation. After 24 hours, baby deteriorated. His investigation showed thrombocytopenia, deranged coagulation profile, deranged KFT and LFT. Sepsis screen was negative and inflammatory markers were raised. Her COVID antibodies came out to be positive. So possibility of cytokine storm was kept, leading to multi-organ dysfunction. So as we saw that cytokine storm occurred without active infection of mother or neonate, but the COVID antigen antibodies was positive in the baby. So during intrauterine period, there is a critical balance maintained by pro-inflammatory marker and anti-inflammatory marker, which is IL-10, which is produced by placenta. But after delivery, we hypothesize withdrawal of IL-10 from the circulation led to imbalance, leading to cytokine storm in already compromised baby, as in this case. Although there is negligible evidence of vertical transmission of COVID infection, yet exaggerated response could have occurred in this patient due to increased ACE2 receptor expression on placenta, as our patient was hypertensive. Therefore, possibility of placental infection followed by fetal infection cannot be ruled out. Hence, we propose pregnant female having either past COVID infection or active infection should be monitored. Their baby should be monitored by neonatal IgG antibodies and interleukin levels for cytokine storm, especially in compromised babies. Intrauterine transmission of COVID-19 infection cannot be ruled out, require further studies, and presence of external anomalies could be a mere coincidence. Thank you.
Hello. Hello. Dr. Pragati, can you hear me?
Yes, ma'am.
That was a very well presented case. Can you just explain to me regarding the IUGR? You think there was some connection between the IUGR, the anomalies, and the predisposition to transplacental spread and cytokine storm predisposed? These babies are more predisposed. You can propose that?
Yes, ma'am. There is studies available which showed that 10% of patients with COVID positive is associated with fetal growth restriction, but with external anomalies, there is no such studies available, and we require further studies for that.
No. What I'm trying to ask is that a baby who has a congenital anomaly and IUGR, they go hand in hand. Every time you have seen in your practice, whenever there is a COVID infection or any other IUGR, there is always some anomaly associated. Rather, anomalous babies are always usually growth restricted. So there is in literature enough evidence to say that even with COVID, there is IUGR, and they have a proposed, extra prone to this neonatal cytokine storm is well known to occur in these predisposed babies.
Ma'am, this is proposed for adults, that their compromised adults are at more risk of complications.
Exactly. So that is how the baby, a growth retarded baby, is exactly the same pathophysiology happening.
Yes, ma'am.
Fine. Thank you very much. Next, please.
Pragati, can you hear me?
Yes, ma'am.
Really a very nice presentation. Just tell me, her level 2 scan was normal.
Ma'am, her level 2 scan could not be done because the timings of 18 to 20 weeks came at around first week of April when lockdown.
Okay, fine. Nice presentation. Good case.
Thank you, Dr. Nidhi, for that comment. I'd like to invite the next speaker, Monica Kandapu. I see her on the list.
Good morning, ma'am. Good morning, ma'am. Sorry for the interruption.
Yeah, Tarun.
Yeah, we can call the next speaker.
Yeah, Monica Kandapu is the next speaker. You could take over from here, Tarun.
Yeah, sure. Dr. Monica, are you there?
She's starting to share her screen, so you could announce her title. Dr. Monica's title is High-Risk Pregnancy with DA-DC Twins with Pancytopenia with Severe Preeclampsia with HELLP syndrome with asymptomatic COVID. Several things in this case.
Hello, ma'am.
Yes, we can hear you. Please go ahead.
Good afternoon, everyone. My case report is about pancytopenia with HELLP syndrome in diamniotic dichorionic twin pregnancy with asymptomatic COVID-19. She was a case of 29-year-old who was diagnosed with severe anemia with pancytopenia with severe preeclampsia with HELLP syndrome, and she was referred to our hospital in view of COVID-19. Total of 4 units of packed RBC and 8 units of platelets were transfused in her entire antepartum period in view of severe anemia with pancytopenia. Injection dexamethasone was given for fetal lung maturity, and in spite of oral and intravenous antihypertensive drugs, her BP was uncontrolled and decision for induction of labor was done. And she delivered twin babies vaginally after 8 hours of induction with birth weights of 822 grams and 1096 grams with Apgar of 677 and 788 respectively. During her intrapartum period, she developed hypertensive crisis with BP of 200 by 110 millimeters of mercury, and nitroglycerin drip was started and it was continued during postpartum period also for 24 hours. And for the prophylaxis of eclampsia, injection magnesium sulfate was given as per the Dakar regimen. And 1 unit of PCV and also 4 units of platelets were also transfused in the intrapartum period. Even though there was no PPH, prophylactic balloon tamponade was inserted after delivery and that was removed 24 hours post-delivery. And oral antihypertensive drugs like clonidine and Lasix, labetalol and amlodipine, they were started 24 hours post-delivery. Coming to the discussion of my part, even though pancytopenia is a very rare entity in pregnancy, it may also associated with so many maternal and fetal complications like maternal sepsis, PPH, preeclampsia, preterm labor, and IUGR and IUD. And in pregnancy, blood transfusion is considered to be the first treatment of choice for pancytopenia. Coming to HELLP syndrome is also a serious complication in pregnancy due to severe preeclampsia, which may result in further complications like eclampsia, abruptio placenta, and disseminated intravascular coagulation, and also acute renal failure and subcapsular hematoma of liver. Results of the case were, in the postpartum period, the BP was well controlled with all these oral antihypertensive drugs, and all her blood counts were also improved. And she was tested negative again for COVID-19 by RT-PCR, and she was discharged with both her babies after 3 weeks of hospital stay. So conclusion of this case report is early diagnosis and timely intervention of rare entities in pregnancies like pancytopenia and HELLP syndrome. They will arrest further complications and also bring favorable maternal and fetal outcome. Thank you.
Now the topic is open for discussion. Geeta ma'am.
Thank you, Dr. Tarun. Thank you, Dr. Monica. That was a very well managed case. One query I have, can you answer that please? Now this addition of the COVID-19 status, how do you think COVID-19 status in addition to an already complicated case will further complicate your case? Hello, Dr. Monica.
Yes, ma'am.
Hello, Dr. Monica.
Can you hear the question?
Can you hear us?
So you have a twin with HELLP with pancytopenia. In addition, the patient is afflicted with COVID, right? Now, as far as the COVID, was it a mild infection or was it just a moderate infection, or it was just a by chance COVID pickup? So how does the COVID help?
Ma'am, she was asymptomatic only for COVID. During her entire hospital stay, she never developed any symptoms for COVID-19. And after 10 days of her positive result, she was again tested and she was reported to be negative.
So my question is, having this conundrum of this HELLP and pancytopenia with the COVID setup, background of COVID, does COVID pathophysiology alter your HELLP and pancytopenia?
Ma'am, in case of COVID-19, when there is a coagulation profile, when there is a deranged coagulation profile.
So that's what
coagulopathies.
Because I don't find the levels of D-dimers, I don't find the levels of ferritin in your case presentation, I don't find the levels of interleukin 6 and CRP.
Yes, ma'am, ferritin was done and it was 446, ma'am. And also D-dimer was normal, ma'am. It was 804.
Because it is important to mention, once you utter the word COVID, you have to do the laboratory characteristics should be evaluated. Thank you so much for that response.
Monica, was your patient vitally unstable?
Ma'am? No, ma'am.
So you have given 4 units of transfusion in antenatal period only at a hemoglobin of 6.2.
Yes, ma'am. Yes, ma'am. Ma'am, but that was given over a period of 5 to 6 days, ma'am.
So you have induced patient after at 30 weeks, 1 day patient presented to you. You have done the investigation and you have induced the patient.
Yes, ma'am. On 31 plus 2 weeks, we induced the patient.
Sorry, at
31 weeks plus 2 days.
41 weeks plus 2 days, you have induced the patient.
31.
31. Okay, okay. At 31, you have induced the patient.
Yes,
So
ma'am.
was that necessary at 6.2, 4 units of transfusion to be given? After transfusion, what about the hemoglobin of patient? 4 unit of
Ma'am,
transfusion.
after transfusion, it was 8.8, ma'am. Ma'am, actually, first in the other hospital, she was transfused because she was with a HB of 5.1 actually.
Okay.
After 2 units of transfusion, she presented to our hospital with HB of 6.2, ma'am.
So you have given 2 units further, not 4 units further.
No, ma'am. Entirely, she received 4 units of RBC in other hospital and also in our hospital. But in our hospital, we gave only 2 units of PCV in our antenatal period.
Okay, fine. And 1 in post-operative period.
Yes, ma'am. Yes, ma'am.
Okay.
Shall we move to the next presenter, ma'am?
Yes, I think Tarun, we are already 1 hour late.
We are running short of
So,
time.
so we have to have a very
yeah.
crisp thing. It is a standard application. I will not repeat it for all PGs. It is exactly 1.5 minute they speak and 1.5 minute we ask. Simple.
Fine. Ma'am, we are moving to the next presenter, Dr. Vijayata. Her code is CV3. Dr. Vijayata?
Yes, am
Please
I
upload
audible?
Please upload. Your time starts now.
Am I audible now?
Yeah, you're perfectly audible. Your time starts now.
Yeah. Good afternoon, everyone. Today I am presenting case report of COVID positive triplet pregnancy complicated by intrauterine death of 2 fetuses. My patient, 30-year-old female with gravida 4, para 2, abortion 2 with 2 life issues, was diagnosed at 12 weeks of gestation to have a triplet pregnancy with dichorionic triamniotic placentation. At 33 weeks of gestation, she was diagnosed with intrauterine death of 2 fetuses, and the patient was counseled properly and reassured about the condition. And fetus and patient was kept under very close monitoring. At 33 weeks of gestation, unfortunately, she acquired COVID infection. So it was a very challenging situation for the obstetrician because intrauterine death can cause derangement of coagulation profile, and COVID infection is also a pro-inflammatory condition. So coexistence of both these conditions will further complicate the situation. So the patient was monitored very strictly, and the fetal well-being was monitored by non-stress test biophysical profile and Doppler vascular flow. And dexamethasone cover was given for the acceleration of lung maturity. Patient routine investigation came out normal, but her D-dimer was raised, for which low molecular heparin was started. At 35 weeks of gestation, patient underwent emergency LSCS in view of non-reassuring, non-stress test, and baby with Apgar 899 was born. Luckily, her post-operative period was uneventful and patient did not end up into any complication. But because of the intrauterine death and COVID infection, there are high chances of sepsis, DIC, and postpartum hemorrhage. So, in these cases should be managed at tertiary care center where all the facilities of blood transfusion and management of complication is available. Thank you.
Thank you so much, Dr. Vijayata. The topic is open for discussion.
Thank you, Dr. Vijayata. That was well managed. Now you can tell me one question, because this COVID-19 is also causing a lot of inflammation, cytokine storm. So what are all the frequency of the laboratory measurements you did once you came to know your patient was COVID positive with a co-twin device? And I presume the twins who died were the monoamniotic, monochorionic, because it is a DCTA, right?
Yes,
Am I
yes.
right?
Yes,
you
ma'am.
lost the babies who were monos, right?
Yes, ma'am.
Right. So now you have a patient with COVID with co-twin device. Please tell me, she is asymptomatic, but her inflammatory markers were elevated. Can you tell me how frequently and what tests you will do in such a patient? Which laboratory checks?
Yes, ma'am. Ma'am, according to the guidelines, we have to do complete blood count, absolute lymphocyte count, LFT, KFT daily, and we have to monitor CRP, D-dimer, and ferritin level every 48 to 72 hourly.
Okay, what else?
And ma'am, we have done her X-ray, like in a baseline X-ray, PT-INR values were also done. Her in the period of her stay, her interleukin 6 level was raised. So
Okay, so she was in the mild category, or did she have any cough, fever, or it was just a asymptomatic COVID?
Ma'am, she is asymptomatic COVID, ma'am. No symptoms. There was no breathlessness. No respiratory rate was normal. SpO2 monitoring was always normal, like more than 96 all the time during her hospital stay.
Right. Very well managed. Thank you.
Shall we move to the next presenter, ma'am?
Yes, you can move.
Dr. Nidhi has questions, Tarun? Dr.
No,
Nidhi?
no, it's nice presentation, Vijita. Yeah,
Okay,
move to
Nidhi,
next
I think,
presenter.
Nidhi, I think we are short, so I think we can just be brief and move.
Thank you so much, ma'am.
Yes, yes, ma'am.
We are moving to the next presenter, Dr. Shalini Shakarwal. Her code is CV4. Dr. Shalini. Dr. Shalini. Dr. Shalini, are you there?
Tarun, move on.
Okay, we are moving to the next presenter, Dr. Kia Kalra. Dr. Kia, her code is CV5. Dr. Kia.
Yes, Tarun, I'm just uploading the post.
Okay, fine, ma'am.
Tarun, you can just tell us when 1.5 minutes is over for their presentation.
Sure, sure.
Can you see my screen, Tarun?
Yeah, yeah, ma'am. You can start, ma'am. Your time starts now.
Yeah, good afternoon, everyone. I would like to present a case. We had a 31-year-old overweight primary gravida who came to us at 5 weeks gestation with UPT positive. The only significant history in her case was that she had COVID infection 6 weeks ago. Initially, she was asymptomatic, but after a week of presentation, she complained of pain in the right side of the back, especially when she had did deep breathing or had hiccups, and it progressed that she had limitations on lying down in supine and right lateral position, and also slight breathlessness on exertion. So when we examined her, we found out that there was decreased air entry on the right side. And then we also consulted a pulmonologist, and an ultrasound of the chest was done, which revealed a right-sided pleural effusion. So we got her investigated, and all the tests otherwise were normal. So we went ahead with a pleural tapping because we were in we had a diagnostic dilemma, what exactly it was. So 200 cc of hemorrhagic fluid, which was negative, eosinophilic, had raised LDH, and was negative for tuberculosis and malignancy, was removed. Since she had persistent symptoms and the investigations did not reveal tuberculosis, which was of primary suspicion. So we were now thinking on the terms of pulmonary embolism. Because her D dimers were raised, she had—
Yeah, ma'am, you have 20 seconds left.
We had history of COVID. She was slightly overweight. Pregnancy, which is also hypercoagulable state. We further investigated for thrombophilias, which revealed protein S deficiency. The bilateral Doppler lower limb were normal, and the D dimer was persistently raised, though it was coming down or was in a downward trend, and CRP also was significantly raised for her. So we came to the diagnosis of pulmonary embolism. We went through the literature. Few cases of pulmonary embolism have been reported, especially in this COVID era. There's a study from France which revealed 32 cases of pulmonary embolism, all in the moderate and severe category, where similar picture was found, but they were not pregnant. They were male and female patients both. So we wanted to present this case that since our patient is young, not critically ill, but she had multiple factors which caused a hypercoagulation. So every patient, whoever even has a mild COVID infection or even in the recovery phase, should be evaluated if presents with breathlessness or pain in the chest. Thank you.
I think we should move for the question answer session, ma'am. Thank you so much. The topic is open for discussion.
Thank you, Dr. Kia. That was a very good take-home message you have given us. Any patient should be investigated for all the procoagulable problems because pregnancy is a procoagulation stage. And in addition, your patient was obese and protein S deficiency, so she was very, very prone to coagulation. Now, my question is, what else could you have done if you knew about this, how would you have managed it differently the moment she came to you with a decreased air entry?
Ma'am, if we had thought about pulmonary embolism from the beginning, maybe started around this prophylactic anticoagulation, because
yes, and an echo would have been done at the entry.
Ma'am, we did the echo. Echo was normal. Bilateral Dopplers of the lower limbs were also normal. We had offered the patient CTPA, but since it was early pregnancy, she refused. So with limitations of the investigations also, since it was a diagnostic dilemma, so we, along with the patient's counseling and the pulmonologist, we started therapeutic dose on clinical diagnosis. And the patient is doing very well.
Ongoing pregnancy.
Yes, ma'am, ongoing pregnancy.
How long will you give her anticoagulation in such a case?
We will give her total pregnancy plus 6 weeks postpartum. She's thrombophilic also. So she becomes a high risk for recurrence of embolism. So she will be covered throughout till postpartum period.
Is it only 6 weeks? What do the guidelines say?
Ma'am, she basically it is 6 weeks. Then we will reconsider. We will repeat the thrombophilia. It can give a different pictures. We need to, because in pregnancy also levels can be low as such. So we will investigate her, and if she requires, then maybe lifelong oral anticoagulation.
Exactly. Any role of inferior vena cava filters in this patient, maybe at a later date? In this patient.
In this patient per se, no, right now.
Right. Very good. Thank you very much.
Thank you, ma'am.
Thank you so much, ma'am. We are moving to the next presenter, Dr.
Yes,
Nisha. Dr. Nisha Yadav, are you there? CV6. Dr. Nisha?
She's not joined, sir.
She's not joined. Huh? Okay, then we are moving to the next, Dr. Anshika Agarwal. Her code is HRP23. Dr. Anshika?
Good afternoon, everybody.
You can share your screen. Good afternoon.
Yes, I'll be sharing my screen right now.
You'll get 1.5 minutes time to present your e-poster, and then the crossing will be around 1.5 minutes.
Sure.
You can start now, Anshika. Your
Yes,
time
sir.
start now.
Good afternoon, everybody. I'll be presenting my poster, which is on the low-dose warfarin embryopathy. Warfarin is a vitamin K antagonist drug, which is used for the prophylaxis and treatment of the thromboembolic events in pregnancy, especially associated with valvular heart disease and mechanical heart valves. Because of its low molecular weight, warfarin has been known to cross the placenta and leading to the fetal embryopathy, with the total risk being 12%. And literature has shown that this risk is directly proportional to the dose of the warfarin used. In my particular case, I had a patient who was a 37-year-old lady, known case of rheumatic heart disease with severe MR and severe MS for the last 15 years. Patient had undergone surgery with mitral valve replacement in 2005, and she was currently taking warfarin sodium at a dose of 5 milligrams on a daily basis. Patient came to our antenatal OPD with a level 2 ultrasound scan showing multiple GCs in the baby. Her anomaly scan revealed large extradural hematoma with depressed nasal bridge and narrow palate, with evidence of choanal atresia, left axis deviation, and hemivertebra in the lower thoracic and the upper lumbar vertebra. The pediatric surgery referral was done, and the patient was explained the prognosis of the baby. The patient chose to undergo medical termination of pregnancy. Patient was hence admitted for the same, and she was switched on from warfarin to low molecular weight heparin, and after that the pregnancy was induced with tab mifepristone 200 mg per orally, followed by after 24 hours tab misoprostol. It has been shown that when the fetus in utero has been exposed to warfarin in the first trimester of pregnancy, it can have teratogenic effects. However, the exposure in the second and the third
20 seconds more.
Yeah, however,
20 seconds more.
However, the exposure in the second and third trimester leads to the coagulopathy in the baby, leading to the microhemorrhages and hence sequelae of CNS defects. However, it has been seen that for the maternal outcome, warfarin has been proven to be the best, but for the fetus, it is a low molecular weight heparin, and the low dose of warfarin, that is dosing less than 5 milligrams per day, has proven to have the same effect on the fetus. Hence, most of the guidelines, especially the European Heart Society, the American Heart Association, and for that matter, the RCOG in their 2011 guidelines also recommend continuation of warfarin if it is less than 5 milligrams throughout the pregnancy, switching over to low molecular weight heparin just before delivery.
Thank you so much, Anshika. We are running short of time. Now the topic is open for discussion. Geeta ma'am?
Thank you, Dr. Anshika. Dr. Nidhi, आप कुछ पूछना चाहेंगे?
I just want to ask, what is the lowest dose of warfarin which is given in pregnancy?
Ma'am, the lowest dose can be anything less than 5 milligram, which can be continued. Patient can be using 2.5 milligram of warfarin.
Okay, 2 to 2.5.
Ma'am,
So your patient
5
was
milligram of warfarin dose, it is advisable to be continued for the better maternal outcome. However, we cannot rule out the risk of teratogenicity with this dose, like in our case, but the guidelines say that this can be continued, thinking the maternal outcome.
So,
okay, fine.
Dr. Anshika, looking at your case and many cases we have also handled in Gangaram, this 5 milligram, sometimes 7.5 milligram, would you say that you would like to switch in the first trimester to LMWH? Your opinion?
Ma'am, in my opinion, we should analyze the patient's situation. Like in the guidelines also, RCOG says that despite the dosing of the warfarin, if the patient is at a very high risk of thromboembolic events, for example, patients with mechanical heart valves, they should be continued on the warfarin only. Because the low molecular weight heparins, ma'am, they are associated with very high risk of thromboembolic phenomena.
Okay, thank you so much.
Any more question, ma'am?
Okay, thank you.
Thank you, Anshika. Dr. Anshika, we are now moving to the next session, next presenter, Dr. Diksha Prasad. Her code is HRP24. Dr. Diksha, are you there? Dr. Diksha Prasad.
Hello.
Hello.
Hello. Can you hear me, sir?
Yeah, we can hear you. Please upload your presentation.
Yes, sir.
You get 1.5 minutes time for the presentation. Your time starts now.
Good afternoon, everyone. I'm presenting a case report pulmonary aspergilloma during pregnancy. My patient was a 25-year-old female primary gravida who came to us with massive hemoptysis in May 2019. She had a history of ATT intake in 2014 and 2012 for the same. During she was admitted for massive hemoptysis, and during evaluation, she was found to be in a second trimester of the pregnancy. Then she underwent CECT. We found out extensive fibrobronchiectative changes in bilateral upper lobes of the lung with dilated pulmonary artery. She was intubated and she underwent bronchial artery embolization. Patient had stage 1 FGR in her antenatal course. She was then booked in our hospital. She underwent uncomplicated vaginal delivery with epidural analgesia, delivering a newborn of 2133 kg. 2133 grams in August 2019. Postpartum period, she had ICU stay in view of respiratory distress requiring oxygen mask. Currently, the patient is echo was done in view of peripartum cardiomyopathy, and she was started on furosemide and kept on non-invasive ventilation for 10 days. She was discharged in a stable state, and currently the patient is under follow-up of pulmonary medicine department for her pulmonary TB. So conclusion is pulmonary aspergilloma is a rare but grave complication of TB. In pregnancy, it can lead to disaster complication for mother and baby both. Like in this case, the patient had massive hemoptysis, which could have lead to aspiration in death of the patient. So prompt recognition of the condition and appropriate management is advised. Pregnancy is also considered as a state of immunosuppression. The Th1 and Th2 cytokine ratio and the absolute number of CD4 cells of the pregnant
Dr. Diksha, we just have 10 minutes time.
Yes, sir.
10 seconds. Sorry.
So pulmonary aspergillosis is a rare post-TB sequelae common in immunocompromised patients, like in my patient. Thank you.
Thank you so much. Now the topic is open for discussion, ma'am.
Dr. Diksha, how did you diagnose aspergilloma in this case?
Yes, I also want to ask this. How did you diagnose this?
Ma'am, she had serology for IgE positive for aspergillosis.
Because it is not mentioned in your presentation, you have done a CECT. By the way, just a by the way question, how much radiation is patient is exposed to during a CECT of the chest? This is just by the way, I'm asking.
I'm sorry, ma'am, I don't remember.
Okay. Next question. This bronchial artery embolization, is it a prophylactic one you did, or because of the dilated pulmonary arteries, or did she have a bleed?
And she
Because
did
of a
have-
massive hemoptysis, that is why you did, na?
It was therapeutic.
It was a therapeutic one. Thank you so much, Dr. Diksha.
Thank you, ma'am.
There was no problem in intubation when the patient was having massive bleeding.
Ma'am, the massive bleeding was managed by bronchial artery embolization, and she underwent then intubation for the further management.
Okay.
Thank you. Next, Tarun.
Thank you so much, Dr. Diksha. Now we are moving to next presenter, Dr. Deepali Garg. Her code is HRP25. Dr. Deepali, are you there? Dr. Deepali Garg, her code is?
Can you see? Nice to, good afternoon, everyone. Good afternoon, everyone.
Yes, doctor. Please go on.
Actually, I cannot read in the side. So actually,
Just tell us the salient features of your paper.
okay. So my paper is about double valve replacement in pregnancy, a challenge for optimal pregnancy outcome. The cardiac disease complicates almost 2% of the pregnancies in India, and 50 to 90% cases are due to the rheumatic heart disease. The mitral stenosis is the most common 60% cause in these lesions, and multiple valvular lesion occur in the 30% cases. During pregnancy, the increased cardiac output, the increased heart rate, decreased systemic valvular resistance lead to the increased gradient across these valves and ultimately to the heart failure. Severe mitral stenosis comes under class 4 of modified WHO classification of maternal cardiovascular risk. So the pregnancy is contraindicated in this class. The severe mitral stenosis is associated with risk of pulmonary edema about 50%, arrhythmia in 15% cases, and associated with maternal death in 2 to 3% cases of pregnancy. The medical therapy is the first line of the treatment, but the surgical interventions are required if the medical therapy is not working. And the percutaneous balloon mitral valvotomy or percutaneous transseptal mitral commissurotomy are preferred surgical options because these are less invasive and associated with less fetal-maternal complications. But the open heart surgery is required when the valvular morphology is unfavorable. In my case, there was a 24-year-old primary gravida with severe rheumatic heart disease, which was referred at our center at 17 weeks period of gestation. She presented with biventricular heart failure with the predominance of the left heart failure features. She was intubated and kept in ICU on medical management for 1 week, but she was remained in NYHA class 3 to 4. So she was decided for the surgical intervention. The decision for the surgical intervention was taken in view of the poor response to the adequate medical therapy, and due to the severe calcific mitral valve, she was found unfit for the less invasive surgical intervention like PTMC, and the decision for the open surgical double valve replacement was taken, and she was given option for the termination of pregnancy along with that surgical intervention. But that termination of pregnancy patient refused. On echo, there was severe calcific mitral valve stenosis. The gradient across the valve was 16 millimeter of mercury. There was no mitral regurgitation. The moderate, there was associated.
Interrupt you, ma'am. We have 20 seconds left only.
Okay, there was moderate aortic regurgitation was present. So the patient underwent open double valve replacement at 18 weeks period of gestation. The intraoperative findings were cardiomegaly, enlarged left atrium. There was no clot, thick calcific mitral valve, and severe subvalvular disease. The intraoperative, all the measures was kept to lower down the fetal risk. The patient was started on oral warfarin and discharged on post-op day 10 of the cardiac surgery, and she was routinely followed up in the antenatal and the CTVS OPD. She was diagnosed with stage 1 FGR at 32-week period of gestation, and she was again admitted at 35 weeks period of gestation, and she was labor was induced at 37 weeks period of gestation, and she delivered a healthy 2.54 kg baby delivered vaginally, and she was discharged on post-op day 15, postpartum day 15, and during postpartum period she was had increased bleeding per vagina for which was conservatively managed. Till now, only 3 cases of double valve replacement during pregnancy has been reported, and our case is 4th one. And in all the cases there was LSCS was done, but we did the vaginal delivery, and the fetal outcome was very good in our case. So the conclusion is the early recognition of the valvular disease and the valvular replacement during second trimester of pregnancy gives favorable outcome, although preconception optimization of the valvular disease is preferable. Thank you.
Thank you, Dr. Dipali. Now the case is open for discussion.
Thank you, Dr. Dipali. That is very well managed case. Again, I would like to ask you that you had developed increased bleeding per vaginum. Now you started warfarin on day 2 of delivery. What are the guidelines given by the Cardiological Society as well as the RCOG regarding the switch?
They say whenever you are confirmed that the hemostasis has been achieved, you can start the oral anticoagulant. We thought second day is because after delivery you can start the heparin. We started the heparin after 6 hours because we thought the hemostasis is quite okay, and we usually start after 48 hours. We started
Exactly. So that is what I'm trying to say. The guidelines are unfractionated heparin is 6 hours, LMWH is 12 hours, and oral is 48 hours. So I think there was a little, early start, may I say, and probably that accounted for it. Thank you so much. Dr. Nidhi,
No, thank you. It's a nice presentation. Well managed case.
Thank you so much.
Well managed.
We are now moving to the next presenter, Dr. Anjali Raj. Her code is HRP 26. Dr. Anjali.
Yes, good morning.
Good morning. Can you share the screen?
Can you see my screen, sir?
Yeah. You can go ahead.
Good afternoon, judges and all the viewers. I'm presenting a case report on a placental cause of fetal growth restriction and abnormal Dopplers which came to our hospital. In this case, the cause of fetal growth restriction was identified to be chorioangioma of the placenta. Chorioangioma of placenta is a benign vascular tumor of the placenta with a prevalence of 1 in 100. But giant chorioangiomas, which are more than 5 centimeters, have an incidence of 1 in 9,000. And they are associated with adverse fetal outcomes such as fetal anemia, congestive heart failure in the fetus, non-immune hydrops, and polyhydramnios, fetal growth restriction, preterm labor, abruptio placenta, and the perinatal mortality rate is around 30 to 40%. We can diagnose this prenatally by imaging techniques such as ultrasound, Doppler, and MRI. Ultrasound will usually show a hyperechoic lesion, and Dopplers help to differentiate it from other lesions such as teratomas or hematomas, hemorrhages, and myomas. MRI is done when ultrasound is inconclusive. We report a case of a 30-year-old primey who presented at 36 plus 5 weeks with a fetal growth restriction. The abdominal circumference was less than 3rd centile. On Dopplers, MCA-PSV was raised and more than 1.5 mmM, and MCA-PI was between 25th to 58th centile, and CPR was less than 1. On ultrasound, we also detected a well-circumscribed hypoechoic lesion in the placenta, which was 6 into 6 centimeters with feeder vessel, and it raised the suspicion of a placental chorioangioma. Emergency LSCS was done, and female baby of 2.3 kg, less than 3rd centile was the birth weight, with an Apgar score of 8 by 9 was delivered. Placenta on gross examination showed a whitish nodular circumscribed lesion of 6 by 4 by 3 centimeters, and histopathology postnatally confirmed the diagnosis of chorioangioma. Fetal anemia was ruled out postnatally because the hematocrit of the baby was 55% 2 hours of life. So chorioangiomas are arteriovenous shunts in the fetoplacental circulation, and it is responsible for the fetal complications. And MCA Doppler is important in such cases because it can detect both late onset growth restriction and also any fetal anemia. And interventions like coil embolization and endoscopic laser coagulation can be used to devascularize the tumor in the early gestations. And the intervention will depend upon the period of gestation, the fetal hemodynamic state.
Sorry to interrupt, 10 seconds left.
Okay, and the resources available in the hospital. Thank you.
Thank you so much, Dr. Anjali. Now the topic is open for discussion.
Thank you, Dr. Anjali. Very well done. I have one question to ask.
Yes.
Now, you have said that color Doppler is priceless in differentiating. Can you tell me the color Doppler findings, had it been a teratoma?
Ma'am, feeder vessels will be seen in case of chorioangioma. With in case of teratomas, feeder vessels might not be seen, and also, ma'am.
What is the characteristic color Doppler feature in a teratoma? Characteristic.
Ma'am, peripheral vascularized. I'm not sure, ma'am.
Okay, not an issue, not an issue. Another question. Now, this patient had an MCA peak systolic velocity of more than 1.5 mom. Can you tell me at 36 weeks, is there any relevance of a peak systolic velocity at 36 weeks?
At a later gestation, MCA PSV is not so relevant, but but we have to rule out any other causes of fetal anemia since it is raised. So in such a inspection, we found that the placenta has a 6/6.
Yeah, no, I'm talking antenatally. So what are the other features? What I wanted you to answer is, what are the features of hydrops ultrasonically in a patient?
We can find any ascites can be there.
Yes.
Features of pleural effusion, cardiomegaly, polyhydramnios. These can
What
also.
is the sequence in which the hydropic changes appear? Mild, moderate, severe. Can you tell me the sequence of hydropic changes? First, what will appear? Second, what will appear? And gross hydrops will be a Buddha sign, ascites. But what is the first, very first clue?
Ascites.
Anything else?
I'm not sure.
Okay, no problem. Thank you, Dr. Anjali.
Okay, thank you, ma'am.
Dr. Anjali, have you gone to the literature to search how many cases are there of giant chorioangioma?
Yes, ma'am. It is rare. The incidence is 1 in 9,000, ma'am, reported incidence.
You have not mentioned any study in your discussion. That's why I'm asking. Study or any previous case reports in literature.
Ma'am, I have put references of 4 cases, ma'am. Hello?
Yes, we could see that reference.
Yes.
Thank you, Dr. Anjali.
Okay. Thank you.
Thank you, Dr. Anjali. Geeta ma'am, I have a small poster presentation. I'm sharing my screen.
May I invite Dr. Tarun Das to present his poster titled Osteosarcoma in Pregnancy, a Rare Case, HRP 27.
Thank you,
Please
ma'am. Can you see the screen, ma'am?
Yes.
Hello. Can you? Okay, ma'am. I have a patient of a 30 years lady, primary gravida. She came at 22 weeks of pregnancy with a dull aching pain in the right knee for 7 days in routine antenatal care. On examination, her right knee was swollen, inflamed, and the 2 into 2 centimeter hard mass noted on the lateral side of the lower end of the femur. Deep tenderness present, and on orthopedic consultation.
Project your
We
poster,
cannot see your
please.
screen, sir. We cannot see your screen.
Project your poster, Tarun.
Yeah, you can see.
No, it's not visible.
You can see, ma'am?
Yeah, started screen sharing. Yes.
You can see now? Okay. Now the thing is, she is a 30 years lady with primary gravida, 2-week pregnancy. She the history of pain, and on examination, she had deep tenderness, and we found a 2 into 2 centimeter hard mass on the left, right lateral aspect of the knee. And on proper counseling and orthopedic consultation was taken, and after an X-ray finding on the AP view of the right knee, it was a bony heart tumor. Osteomyelitis was ruled out. We did MRI. The features are corroborative of the bone tumor confined locally. We did a bone biopsy. It revealed osteosarcoma. The patient and relative were counseled regarding the prognosis, need for the limb-saving surgery, preterm delivery, and need for the chemotherapy. Wide resection of the right distal femur and endoprosthetic reconstruction was done under general anesthesia at 23 weeks of pregnancy. Oncologist consulted. Role of antenatal adjuvant chemotherapy was discussed with the patient, but they refused. Steroid cover was given at 29 weeks gestation, and after proper counseling with a neonatologist, we planned for the elective LSCS at 30 weeks. Male baby 1.2 kilo we delivered, and we shifted that baby to NICU on CPAP. Post-operative period was uneventful. After 48 hours, the baby was put on room air. She was discharged on the 5th post-operative day. And again, she got readmitted 21 days after the postnatal, 21 days postnatally for the adjuvant chemotherapy. PET scan was done and no significant metastasis was noted. Adriamycin along with the cisplatin chemotherapy regime was planned for her 6 cycles. The osteosarcoma is pregnancy is very rare. Risk and benefit of early delivery versus delaying maternal therapy have to be weighed on an aggressive malignancy like this. Long-term maternal and neonatal outcomes have to be considered. Early diagnosis and multidisciplinary courageous timely management can save both the mother and baby, but a long-term follow-up is needed. Thank you so much, ma'am.
Well on time. Dr. Nidhi, you can ask questions, please.
Very nice presentation by Tarun, and it presented very well and well in time also.
Thank
so
you.
Nothing to add. Nice presentation.
Can I ask a question, Dr. Tarun? Hello,
Yeah,
Dr.
sure,
Tarun. Now, adjuvant chemotherapy
can hear
was
you.
discussed. Hello, Dr. Tarun. Adjuvant chemotherapy
I can
was
hear you.
discussed by the chemotherapy team. Now, what chemotherapy is safe in pregnancy in such a case?
Basically, we can, whatever chemotherapy was advised in the postnatal period, it was safe from the 2nd trimester onwards. Even the adriamycin as well as cisplatin is also to some extent safe. But the methotrexate we cannot give to the pregnant patient. That is an alternative chemotherapy for that osteosarcoma patient. And if we skip the 1st trimester, the 2nd trimester to 3rd trimester onwards, these chemotherapies are safe. To some extent, but not 100%
What are
safe.
the dangers? What are the dangers with Adria and cisplat? How will you monitor if given to a pregnant lady?
Adriamycin, ma'am, basically it causes the cardiac dysfunction, that is the dilated cardiomyopathy in the baby, and the cardiac, the diastolic functions will be less in the baby. So we have to monitor with the fetal echo routinely with the adriamycin. And with the cisplatin, we have seen, so there are some cases been reported for the myelosuppression. After delivery, we have to keep on that part. We have to, antenatally, we can't monitor much with the cisplatin, but after delivery, we have to see about the myelosuppression features in the baby.
Thank you, Dr. Tarun.
Thank you so much, ma'am. Now we are moving to the next session. Dr. Anjuna Tumpati. Dr. Anjuna, her code is HRP 28.
Yes, sir.
Please share your screen, Dr. Anjuna. Dr. Anjuna, please share your screen.
Do you want us to share the screen?
Yeah, sure. Go ahead.
Good evening, everyone. I'm going to present a case of 22-year-old primary para on day 2 of emergency LSCS presented to her gynae casualty with complaints of pain abdomen and abdominal distension and fever since her cesarean. LSCS was done in view of meconium stained liquor with cephalopelvic disproportion with a history of prolonged leaking for 21 hours. And she came to our emergency in septic shock with initial diagnosis of hematoma or query pyoperitoneum. Clinical diagnosis of septic shock was made with in view of fever and with thin purulent discharge from the stitch line with her Q-SOFA score of more than 2. After initiating the first hour sepsis bundle with fluid resuscitation, higher antibiotics like piperacillin and tazobactam, clindamycin, and starting her on antibiotics, she was shifted to OT for exploratory laparotomy. Peroperatively, she 1 liter of seropurulent peritoneal fluid was drained and uterine stitch line was necrotic with pus flakes. Decision for hysterectomy was taken in a primary para in view of septic shock intraoperatively with requirement of 2 inotropic supports. Postoperatively, patient developed coagulopathy, which requires transfusion of 18 RDPs and 1 SDP, 14 FFPs, and 6 patch cells from timely management. Vancomycin and imipenem was started on day 4 in view of MRSA on her blood culture. On day 7, her blood culture grew Candida species for which amphotericin was added. She had high-grade intermittent spikes of fever in second late stage, in second week, postoperatively, which was responded to artesunate. On postoperatively, she had seizure-like activity, seizure, which was managed with sodium valproate. Her CT was normal, and she developed side effects to sodium valproate, in which her blood ammonia levels were raised. So we discontinued her sodium valproate. Later, she developed burst suture line sepsis, and which was conservatively managed with daily dressing, and wound swab grew Klebsiella species, which was sensitive to colistin. Later, she was discharged after resuturing. Conclusion: maternal sepsis is a condition which was associated with high mortality, and its main initial management and early diagnosis is the main thing to decrease its mortality and morbidity.
Thank you so much, Dr. Anjuna. Now the topic is open for discussion.
Dr. Anjuna, it was a nice presentation. What are the features of R1 sepsis bundle?
R1 sepsis,
which you have mentioned now, 1 hour sepsis bundle.
Yes, ma'am.
What are the features of that?
First, early diagnosis and timely management with resuscitation of IV fluids. IV fluid resuscitation with systolic blood pressure. We have to measure the systolic blood pressure and check the necessity of inotropes, and firstly remove for blood samples for culture, and timely management of.
Only for cultures, you will remove blood samples for
normal, all routine.
Lactate also.
And lactate. Lactate level must be, ABG has to be taken, and which lactate is measured. If it was more than 2, she might be required. It was due to hypoperfusion. And more than 4, it has more mortality of 95%.
Okay. Have you gone through literature?
Yes, ma'am.
But you have mentioned only the guidelines. Hello?
Yes, ma'am.
Any such case series or case discussion or case have been reported in literature?
Ma'am, I just gone through the guidelines.
You have just gone through the guidelines?
Guidelines, yes, ma'am.
When you are presenting a case, you have to go to literature also, no? Okay, fine.
Thank you, Dr. Anjuna.
Now we are moving to the next presenter, ma'am. I would like to call Dr. Sonam. Her code is OTH23. Dr. Sonam.
Yes, sir.
Please share your screen. Your time starts now, Dr. Sonam.
Yes, sir.
You can start, Dr. Sonam.
Is my screen is visible?
So do you want me to share again?
Yeah. You people can help her. Dr. Sonam, please start.
Good afternoon, respected teachers. Today I am presenting a huge collision tumor of ovary in pregnancy. My case is 30-year-old female, 5th gravida with 4 living issues, presented with 10-week amenorrhea and hugely distended abdomen. She complained right-sided pain abdomen for last 2 weeks with loss of appetite and difficulty in micturition and constipation. Her pregnancy was confirmed by UPT and ultrasound at 10 weeks of the POG. Ultrasound shows a large right adnexal complex mass of 25 into 23 centimeter, having a small hyperechoic mural nodule with a large multiloculated cyst wall. Wall was thin and no papillary projection and no increase in vascularity was appreciated. Left ovary was also bulky, measuring 5 into 4 centimeter, and intrauterine fetal pole corresponding to 10-week pregnancy with normal fetal cardiac activity. Her serum ovarian cancer marker was slightly raised, and sonography pointed to benign ovarian tumor. Hence, she was planned for the surgery at 14 to 16 weeks of gestation. She was prescribed with progesterone and folic acid till 16 weeks. She underwent exfoliated laparotomy in second trimester at 16 weeks under spinal anesthesia. A midline longitudinal incision at laparotomy revealed smooth, shiny, pale, right-sided ovarian cyst, which was drained through a small incision on its capsule to limit abdominal incision, abdominal incision length. Finding included a massive right ovarian cyst replacing the entire right ovary with no normal residual ovarian stroma. The cyst was twisted twice on its pedicel. Her upper portion of the cyst was 20 into 15 into 8 centimeter, and approx 5.4 liter of the dark colored serous fluid was aspirated from it.
Dr. Sonam, 10 seconds more.
Lower cyst was approximately 10 into 10 centimeter, which contained a seromucinous fluid and was multilocated. One of the daughter cysts is 4 into 4 centimeter with pultaceous material with tuft of hair and nodules, clearly dermoid cyst. Her right salpingo-oophorectomy was done with left cystectomy. On histopathology, there is mucinous cyst adenoma and a single mature teratoma was there. The right fallopian tube was unremarkable, and there was no capsular breach or invasion or no lymphovascular or perineural invasion. Peritoneal lavage was negative for malignant cell and positive for reactive mesothelial cell. The patient thereafter had underwent post-operative recovery, and further antenatal period was unremarkable. She delivered a live-born healthy male baby at term.
Thank you so much, Dr. Sonam. Now the topic is open for discussion, ma'am.
Dr. Sonam, thank you so much. The collision tumors of the ovary, can you tell us the incidence? How many have you seen?
Ma'am, it's very rare tumor, and its incidence is approx 0.05 to 2.4%. And ma'am, maximum tumors are benign, and
that is the incidence of adnexal mass in pregnancy. What is the incidence of collision tumor?
Okay, doesn't matter. If this ultrasound finding, which actually it's very difficult to read your poster. Somehow the visual appeal, it's Dr. Nidhi.
That's correct. It's
थोड़ा सा मुश्किल है. बाकी torsion जो आपने बताया है, it was a torsion, I believe, ना? Torsion. Did you find a torsion in this?
Yes, ma'am. Yes, ma'am.
Right. Okay. Thank you so much.
You have written a lot on your paper, actually.
Yeah.
Thank you so much, Dr. Sonam. Now we are moving to the next presenter, Dr. Sunayana. Her code is OTH24. Dr. Sunayana, are you there?
Good afternoon, everyone.
Please share your screen, Dr. Sunayana.
Yeah. Share.
Backup team, can you please help her?
Wait a second, I will share.
Your time starts now. Dr. Sunayana, your time starts now.
Yeah, thank you. Good afternoon, everyone. I'm presenting case of high-grade ovarian tumor that masqueraded as ectopic pregnancy. A 35-year-old female presented in the emergency with 6 weeks amenorrhea and pain abdomen for 1 day. The patient was hemodynamically stable, and on per vaginal examination, there was 6 into 8 centimeter mass felt in the right fornix and fullness in the left fornix. There was no CMT. On ultrasound, there was 3.8 into 2.4 centimeter heterogeneously hypoechoic lesion in the left adnexa and a unilocular cyst lesion seen on the left side without any solid component. Her beta HCG level was 773. So a provisional diagnosis of ectopic pregnancy was made, and she was managed initially with medically with injection methotrexate. But her day 4 and day 7 beta HCG level raised, and she had acute pain abdomen. So a decision for emergency laparotomy was taken operatively. On right side, 6 into 6 centimeter ovarian cyst was present, for which ovarian cystectomy was done. And on left side, there was ovarian mass of 9 into 6 centimeter with solid cystic areas with no surface excretions present, for which left ovariotomy was done. As per operate, it was suspected to be a malignant mass. So a mental biopsy as well as peritoneal washings was sent for histopathological examination. On the final diagnosis was made on the basis of histopathological examination as high-grade serous ovarian carcinoma of the left side, while the right ovarian cyst was came out to be as ovarian corpus luteal cyst. The mental biopsy and peritoneal washings was negative for any
Dr.
metastasis.
Sunaina, 10 seconds left.
Yeah, she was kept on follow-up. CA 125 levels were within normal limits, and her CT whole abdomen and pelvis was normal. She is still on regular follow-up. So there are numerous causes of raised beta HCG, for which the most common is pregnancy, but a high index of suspicion should be kept in mind while treating such patient, as she was a very young patient, and we see most commonly high-grade serous carcinomas in old age peoples. Thank you so much.
Thank you, Dr. Sunaina. Now the topic is open for discussion.
Dr.
follow
हाँ, yes, please, Dr. Nidhi.
yes मैम आप बताइए.
नहीं, आप बोलिए, Dr. Nidhi.
अच्छा, on follow-up, I want to ask, have you underwent, मतलब your patient underwent beta HCG, and when it get normalizes?
Beta HCG normalized after 1 month, and her CA 125 levels was done on the post-op day 0 of her post-op day 0, which was 18.1.
Yeah, CA 125 was 18.1 on day 0. Beta HCG you done as it was higher in the pre-operative period. It get normalizes after 1 month.
Yeah, yes, ma'am.
How frequently you repeat the beta HCG
Ma'am,
in your case?
initially we kept the patient admitted. We did it weekly. We did endometrial biopsy, endometrial curettage, and beta HCG weekly. It normalized after one month.
Dr. Sunaina, did you remove the left ovary, the left ovariotomy? That is, the left whole ovary has been removed. Am I right?
Yes, ma'am. Yes, ma'am.
Why didn't you not remove the left fallopian tube? It's a HGSS, and most of them arise in the femoral end. So why you have not removed the left fallopian tube?
Ma'am, the diagnosis of high-grade serous ovarian carcinoma came out after the histopathological examination. Operatively, there was we didn't suspect that it will be high-grade serous carcinoma. We knew it will be a tumor, but not as high-grade serous carcinoma.
But if you're removing the entire left ovary, it stands to reason that you remove the tube also. What for the tube has been preserved? Anyway, thank you very much.
Okay, thank you.
Thank you.
Thank you, Dr. Sunaina. We are moving to the next presenter, Dr. Priyanka Yadav. Her code is OTH25. Dr. Priyanka.
Hello.
We can hear you, Dr. Priyanka. You can share your screen. You have 1.5 minutes time to present your poster.
Good afternoon. I am presenting a hydrosalpinx, a rare effect of endometriosis. A patient 33 years old, married for 1.5 years, nulliparous, presented in the OPD with complaints of swelling in lower abdomen since 4 months, decreased appetite, and menstruation was regular with severe dysmenorrhea. She had cholecystectomy 8 years back, and on abdominal examination, suprapubic mass was felt around 14 week size. On vaginal examination, cervix was deviated to left side. Uterus was around 6 to 8 weeks with 2 irregular
Dr.
masses.
Priyanka,
Hello.
we are unable to see your screen.
Can you enlarge it, please? It's a microscopic print. Please enlarge it.
I think you can auto-rotate your screen.
Okay.
You can auto-rotate.
I'm trying this. Give me a second. Actually, I'm sharing it from my phone. That is right.
That's why I'm saying that you can auto rotate the thing and we can get a good picture of.
I think Tarun, the backup team can help her, please. We are running out of time.
Okay, ma'am.
Remove the rotation lock. Then you can auto rotate.
Okay.
We can.
Tarun, just see the timing is correct.
Yeah. We are running
Should I-
short of time.
Yeah. Should I start with again?
Yeah, you just have 30 seconds time to present.
Okay. On abdominal examination, a suprapubic mass was felt around 14 in week size. On vaginal examination, cervix was deviated to left size, and it was around 6 to 8 weeks with 2 irregular masses felt in the fornix. Endometriosis along with the TO mass was suspected, and ultrasound revealed focal adenomyosis with bilateral ovarian endometrioma, the largest being 56 into 30 mm in right ovary. MRI was also suggestive of TO mass, and there was no evidence of tuberculosis and endometrial aspiration. So exploratory laparotomy followed by bilateral salpingectomy with left endometriotic cystoid removal with myomectomy was done. On per-op, mentum was adhered to the uterus. Right side hydrosalpinx tube was around 10 to 5 centimeter, adherent to ovary. With the left hydrosalpinx was around 2 into 2 centimeter. And endometrioma with the yellowish discharge were also there. And on histopathological examination, bilateral xanthogranulomatous salpingitis was seen.
I think we should stop over here. Now the topic is open for discussion.
Dr. Priyanka, is laparoscopy available at your center?
Not right now, ma'am. It was not used that much.
Can you project the poster, Sumit? Keep the poster on while the questions are going on.
Backup team. Hello.
Okay,
Hello,
Dr. Priyanka. Dr. Priyanka.
Yeah, ma'am.
Yeah. Now, can you tell us a little bit more about what is xanthogranulomatous salpingitis and what is its impact on a woman's fertility potential?
Xanthogranulomatous salpingitis is a very rare form of chronic inflammation. It is characterized by accumulation of foamy macrophages in the fallopian tube.
Dr.
And
Priyanka, we are unable to see your screen.
You please go ahead with the question association.
Yeah.
So in this inflammation, there are infiltration of histiocytes in the tube. So it distort the
Backup team, please mute yourself. Backup team, please mute yourself.
Hello.
Hello.
Am I audible?
Yes,
Yeah,
Priyanka, please carry on.
Yeah. So, ma'am, it is a chronic, rare form of chronic inflammation of the tube. So, it blocks the tube by accumulation of the macrophages and which caused hydrosalpinx in this case.
Thank you, Dr. Priyanka.
Thank you, Dr. Priyanka. Because of the shortage of time, we are moving to the next presenter, Dr. Ayushi Gupta. Her code is OTH26. Dr. Ayushi.
Am I audible?
Yeah, you are audible. Please share your screen.
Yes, sir. Is it visible?
Backup team, please help her.
So we are not able to see your screen, Dr. Gupta.
Hello?
We are not able to see your screen, Dr. Ayushi.
Is it visible?
Backup team, please help her.
Just a second, sir.
Yeah, your time starts now. We can share your. We can see your screen.
Just a second. Shared my screen.
Yeah, we can see.
Okay, sir. Good afternoon, everyone. I'm presenting a case of. Okay, sir. Good afternoon, everyone. I'm presenting a case of puberty menorrhagia, a rare presentation of acute myeloid leukemia. A 14-year-old girl presented in February 2020 to gynae.
We cannot see your screen. Backup team, please help.
Dr. Gupta, we will share the screen. You please don't share now.
Of heavy bleed vaginally for 1 month, requiring 3 to 4 pads per day, associated with weight loss, approximately 4 to 5 kilograms, anorexia. Okay. A 14-year-old girl presented in February 2020 with the complaints of heavy bleeding per vaginally for a month, requiring 3 to 4 pads per day, associated with weight loss, anorexia, and easy fatigability.
I guess she's facing some internet issues.
Okay, fine. Then we are moving to the next one. Ma'am, with the permission of the chair, we can move to the next one, ma'am.
Yes, please, Dr. Tarun. I'm trying to make up for the lost time.
Yeah. Dr. Kavita Koiwal. Dr. Kavita Koiwal, OTH 27. Dr. Kavita?
Yes, sir.
Please share your screen.
Sir, it would be great if you are, you please request your backup team to share.
Backup team, please share her screen.
Thank you so much.
Please start. Your time starts now.
Greetings from AIIMS Rishikesh. Our patient is a 24-year-old unmarried girl. She presented to us with abdominal distension for last 6 years with pain abdomen. She had difficulty in breathing, walking and standing for last 1 year. On examination, general physical examination was done. It was suggestive of a thin-built, malnourished, anemic and hyperproteinuric, though her weight was 78 kg. On abdominal examination, as we can see in figure 1, it was a large, huge abdominopelvic mass from epigastrium area to hypogastrium, and bilateral flanks were full. We worked up the patient on CCT scan. It was suggestive of a 15 to 40 centimeter large multiloculated cystic lesion with internal septations, and bilateral ovaries were not seen separately. Her tumor markers were raised. CA125 was 160, CA99 was 9,314. So we decided to operate her intraoperatively. It was a large 50 into 60 centimeter of ovarian mass arising from the left ovary. Almost 36 liters of thick straw-colored mucinous fluid was drained, and the left ovarian mass was excised. It was weighed 5.1 kg, making the total weight of tumor 41.1 kg.
Intraop, seconds more.
Yeah, intraop imprint cytology was suggestive of malignant mucinous tumor. So complete cytoreductive surgery was performed. Final histopath was suggestive of bilateral mucinous carcinoma, and it was stage 3A because parietal peritoneum and pouch of Dulux peritoneum was also positive for malignancy. She is now planned for adjuvant chemotherapy. The idea behind presenting this case here is the case is a unique case because most of these cases are presented in postmenopausal women, one thing, and another thing, these cases are usually benign. These use cases are usually benign. So ours was a malignancy. Another similar case we could found in literature was presented from Japan in 2007, but unfortunately their patient was died 12 hours after surgery due to DIC. We were fortunate enough to save the patient with the help of our critical care team. So to conclude, I would say these kinds of tumors are extremely rare, and to the best of our knowledge, this is the largest case of malignant ovarian tumor in a young female with fair prognosis ever reported. Thank you so much.
Thank you so much, Dr. Kavita. Now the topic is open for discussion.
Thank you, Dr. Kavita. My question is that in case some place doesn't have a frozen facility, would you have still proceeded the same way, or would you have done in 2 sittings?
Ma'am, in that case, we might have done in 2 sittings because she is a young patient, 24-year-old only. So we have to think that way. So we might have done in 2 sittings.
Once you have this ginormous tumor, what should be your next step in your mind?
In pre-op stage, ma'am?
No, you had the frozen of malignancy. Would you have thought of anything else vis-a-vis fertility preservation? Can you offer her something?
Ma'am, first thing we thought of fertility preservation only, but when we discussed with relative, and for this condition also, they took 6 years to take her to the hospital. So they were very uncompliant from low socioeconomic status. So if we would have did fertility preservation, to the patient might not have come afterwards. So they completely denied that they will again come hospital. They did do complete surgery for the patient. So we had to do it.
Other ovary, what was the report of the other ovary?
Ma'am, unfortunately, the other ovary was also involved. It was also it is bilateral mucinous carcinoma of ovary. Both ovaries were involved.
Thank you, Dr. Kavita.
And what was the status of appendix?
Appendix was normal, ma'am, and on histopath also it was normal. Okay. So we did appendectomy also.
Okay.
Thank you,
doctor.
Thank you so much, ma'am.
We would like to call Dr. Aparajita Gupta. Her code is OTH28. Dr. Aparajita.
Yes, I'm just
please share
sharing my
your
screen.
screen.
Yes.
You have 1.5 minutes time to present.
Okay. Good afternoon, everyone. I'm presenting the case of a 35-year-old female, P4L4A2, presented post medical abortion at 7 weeks of pregnancy, and followed by history of 2 suction and evacuation in a private hospital for continued bleeding. At the time of presentation to our hospital, the patient's vitals were stable and per vaginal exam showed bulky uterus and minimal bleeding. Her pre-treatment beta HCG was 4.5 lakhs, and patient and her ultrasound and CCT head, abdomen, and chest showed mass in uterus with lung and liver mets. The slides of the retained product of conception from the second evacuation was reviewed in the pathology department of our hospital, and with a diagnosis of choriocarcinoma was made. She was stage 4, FIGO stage 4, and WHO score of 16, choriocarcinoma. Following an oncology referral, low dose of Imaco was started due to high tumor burden. And after 2 cycles of low dose Imaco, the bleeding increased to 2 pads per day, which was at which time the decision was for hysterectomy was taken, which was opportunate because
10 seconds more.
Because it was opportunate because the per-op showed perforation of the serosa, and following total abdominal hysterectomy, patient was given 6 cycles of Imaco, and patient's beta HCG levels decreased to 2.70 with normal chest X-ray and ultrasound whole abdomen. I am presenting this case because in such cases, FIGO defines ultra high risk case of having a score of greater than 13 with stage 3 or 4. And such cases are very rare, and usually in these cases, the chemotherapy is the first line treatment, and adjuvant surgical procedures are usually not done unless to excise resistant metastatic foci. And we also gave her...
Thank you so much, Doctor. We have to open this topic for the discussion.
Yes.
Ma'am.
Dr. Aparajita, that was very well managed. My question is that if once a patient comes to a gynecologist with history of MTP pills taken without any ultrasound done, what is your opinion? Should MTP pills be given over the counter?
Ma'am, no, MTP pills should not be given over the counter because and lots of patients come without knowing the gestational age. They usually, the patients who take MTP pills, they are multigravida, G4, G5, and they, without getting an ultrasound, then they take MTP pills. So we are not even sure कि they get it at what weeks of pregnancy they have taken. They are not sure कि MTP pills, and we have seen lots of complication following MTP pills, and they usually require a dilatation and curettage, the patients who have taken MTP pills, because due to incomplete abortion or retained products of conception.
What will be your long-term approach to this patient?
Ma'am, we are following her for monthly beta HCG. We followed her for 6 months post the last dose of chemotherapy. Now we have calling her 3 monthly beta HCG. For patient is stable, and we are getting her for taking a history, and ultrasound will be done on yearly basis.
How would you manage her pulmonary and hepatic metastasis? Anything you would like to do from that angle apart from beta HCG? What are the other follow-up protocols?
For hepatic metastasis, we have done CCT chest and ultrasound for CCT abdomen.
Which is the best modality to chase a hepatic meta?
Best modality for hepatic metastasis is MRI abdomen.
Okay, thank you very much.
Thank you.
Thank you so much, Dr. Aparajita. We are moving to the next presenter, Dr. Shalu Solanki. Her code is OTH29. Dr. Shalu, Dr.
Yes,
Shalu,
sir. Hello.
you can share your screen.
Okay, sir. I'm sharing. Sir, are you able to see?
No, not yet.
Okay. Now, is it visible?
It is visible, but you have to do the auto rotate. Backup team,
Okay.
please. Yeah, your time starts now. We can see.
Okay. I'm going to present a case of McIndoe's vaginoplasty and 8-4 MRKH. 19-year-old female with a complaint of primary amenorrhea was diagnosed with MRKH syndrome. Patient had no history of developmental delay. Patient had a history of appearance of breast nodule at around 12 years of age, followed by development of pubic and axillary hair. Patient had history of cyclical abdominal pain for 2 years. Patient did not have any phenotypic or endocrine abnormality. Ultrasound shows there is absence of uterus while ovaries were normal. MRI was done with following report. Uterus and proximal vagina was not visualized and bilateral ovaries were normal. Patient was planned for McIndoe's vaginoplasty under general anesthesia. And proper counseling of the patient and her family was done before the surgery. Patient was laid in the lithotomy position and parts were clean. Foley's catheterization was done. There transverse incision given on the vaginal dimple and blunt dissection was done between the bladder and the rectum, and the space was created and mold was put in this space, and patient was monitored for 10 days post-operatively till patient herself changed the mold and followed up in OPD after discharge monthly for the next 6 months. Vaginal mold was changed under all aseptic precaution after 7 days of surgery. Now it shows MRKH is a rare anomaly that leads to serious impacts on the sexual life of an otherwise normal patient. So it is essential for the
Shalu, 10
patients
seconds more.
and their families to attend counseling before and throughout the treatment. Now, conclusion, we observed that McIndoe's vaginoplasty was successful and had less complication rate. This procedure is simple with least complication rates.
Thank you so much, Dr.
Thank you.
Now the topic is open for discussion.
Thank you, Dr. Shalu. Was a karyotype done in this patient?
No, ma'am. Karyotyping was not done.
Second question. Name the other vaginoplasty surgeries you know of.
Ma'am, there is a Williams vaginoplasty, or before this, Frank's dilatation and Ingram dilatation was done in the past. Now, McIndoe's vaginoplasty and Williams vaginoplasty. Nowadays, these procedures are done.
Do you know of a laparoscopic neovagina creation?
Ma'am, there's a Vicchetti technique in which there is a spare connected to two metal wires and guided through the peritoneal space using laparoscope.
What is the risk of ovarian malignancy in a patient with MRKH versus a congenital adrenal insensitivity syndrome? Okay, thank you, Dr. Shalu. Dr. Nidhi, आप पूछ लीजिए.
What can be the complications?
There can be interosseal formation, ma'am. There can be bleeding in the post-op period, and there can be bladder injury or rectum injury, or there can be vaginal atresia if mold was not changed properly. And
okay, thank you.
Thank you so much, Dr. Shalu. We are moving to the next presenter, Dr. Akanksha Deswali. Her code is HRB 29. Dr. Akanksha.
Good afternoon, everyone. Am I audible?
Yeah, you can share your screen.
Yes.
You will get 1.5 minutes time to present.
Yes, I'm sharing my screen. Is it visible?
No, yeah, it is visible. You can start.
Okay. Good afternoon, everyone. I am presenting a case of spontaneous uterine rupture at an early gestation due to placenta percreta. My case was a 32-year-old female. She was gravida 3 para 2 live 2 with previous to normal full-term vaginal delivery. At 16 weeks period of gestation, she presented with abdominal pain and vomiting for 2 days. On examination, her vitals were stable. Per-abdominal examination showed a non-tender abdomen with fundal height corresponding to 16 weeks period of gestation. On investigation, she was found to have anemia, HB of 4.3, And on imaging, it showed intrauterine pregnancy corresponding to 15 weeks, 6 days period of gestation with moderate free fluid in the abdominal cavity and normal bilateral adnexa. During her hospital course, she received PRBC transfusion for anemia and she was undergoing evaluation for ascites. Suddenly on the next next hospital day, she collapsed. She had acute abdominal pain with tachycardia and hypotension. On examination, the abdomen was tender and there was loss of uterine contour. She was subjected to a repeat ultrasound which showed empty uterine cavity and clots lying adjacent to the uterus in the abdomen. With the clinical diagnosis of uterine rupture, she was taken up for emergency laparotomy.
Dr. Akansha, 10 seconds more.
Intraoperatively, there was a rent in the left cornua and the fetus and placenta were found lying in the abdomen, and she was managed with emergency total hysterectomy. On histopathology, it showed features suggestive of placenta percreta, showing chorionic villi invading through entire thickness of the myometrium. She was discharged uneventfully on postoperative day 7. Spontaneous uterine.
Thank you so much. We are running short of time. Now the topic is open for discussion.
Thank you, sir.
Thank you, Dr. Akanksha. My question is, when she came to you with pain abdomen, there was moderate free fluid.
Yes, ma'am.
Could you have preempted this and put in a laparoscope at that time? And because the next day she ruptured, so that moderate free fluid was a good clue you had. Any comments?
Actually, for this moderate free fluid, there was a clinical suspicion of liver disease as well. She had icterus as well. So it got masqueraded because of the liver disease probably.
So you were not expecting that to be hemoperitoneum?
Yes, ma'am. Initially, we were thinking only as...
That's why ma'am was saying that if you can put a scope, or there is another thing in which anesthesia is not required, whether you can see whether it is a hemoperitoneum or not.
Aldosynthesis.
Okay, thank you.
Thank you.
Thank you, Dr. Akansha. We are now moving to the next presenter, Dr. Vidushi Kulshrestha. Ma'am's code is a CV7. Dr. Vidushi.
Yeah, good afternoon and wishing you all a happy Dashera.
Happy Dashera to you, ma'am. You can share your screen, ma'am.
Yeah, sure. Is it visible?
It's not a backup team. Kindly help her.
Yeah, you can show from the backup team can.
Backup team?
Yes.
Wait for a moment.
Yeah, thank you so much. So, first of all, wishing you all a happy Dashera. And basically in this COVID pandemic, we are coming across a lot of women who are apprehensive while they are coming to the healthcare facility for their antenatal checkups. And they are worried about risk of exposure while coming to the hospital, about the fetus. And many of our women are already high-risk women, and they are worried about their pregnancy outcome. And this pandemic is basically adding to their stress. So we are conducting this study to screen pregnant women for depression. And so far we have analyzed data of 50 women. So this was actually a cross-sectional study, and here the tool used was Edinburgh Postnatal Depression Scale, and basically it's indicated how the mother had felt during the previous week. And for antepartum depression, the cutoff was taken as 14 or 15, and women were advised to seek a psychiatric consultation if they seemed positive for antepartum depression, or also if they had a positive score for question number 2, which actually indicates suicidal thought. So in literature, the reported incidence of antepartum depression is 9 to 11%. And in our study, we found that 30%, that is almost a third of the women coming to us, they screened positive for antepartum depression and they were referred to the psychiatrist. And also about 12% women had a positive score for question number 10, that is they had suicidal tendency. Also, we found that there was a decreasing trend in EPDS score with respect to the advancing age, it was noted. And so a recent study that is published in 2020 during COVID pandemic only, It also found a depression in 37% women, and though they used the cutoff of 13 or more. However, in our study, we have taken cutoff of 15 or more, as has been validated for antepartum depression. Since antepartum depression has many long-term implications, such as impact on pregnancy, bonding, impact on children, so we suggest that EPDS is a very simple 10-item sensitive tool which can be used to screen such women, especially in this COVID pandemic, because evaluating these women in time may prevent many long-term complications. Thank you.
Thank you,
so much,
Dr.
ma'am.
Vidushi. Thank you, Dr. Vidushi. Can you tell us what intervention was done in the patient who had a EDPS score more than 10?
Yeah, basically EPDS score is for screening. It is not diagnostic. So we refer these women to the psychiatrist, because we have on board this psychiatrist also for this study, and they evaluated the patient, and most common treatment that they give was escitalopram, which is as SSRI. And we've also found that counseling the patient, basically the patient think that there is thought that there is a taboo, but if we counsel patients nicely that it will help you in coping up in this pandemic, they are open to like the psychiatrist consultation as well as taking the treatment.
Second question, in this Edinburgh postnatal depression scale, can you highlight the most important question which you asked, which you paid attention to, or rather which was the most significant question pointing to depression of the 10 questions which you have enumerated?
Okay. So basically it
because from your
had many
poster it is
questions,
not
but
evident, the scale is not given, so we are not aware exactly. I mean, the students may not be aware of what are the content of the EDPS.
Yeah, so it actually has 10 questions and score is given from 1 to 3, and like patients may not do it as a pattern. So question number 3 questions have score 0, 1, 2, 3 in that order, and others have reverse order, like the third option has 0 and the first option has 3 scales, so that patients they
can you tell us the questions you ask?
Yeah, the questions are like are the patients being able to laugh and see the funny side of the thing? So like as they used to do it previously, not often, or definitely no. Or are they able to sleep? Are they feeling unhappy? Are they blaming themselves? Are they anxious or worried for no good reason? Or are they thinking of harming themselves? Are they feeling scared or panicky for no good reasons? They are some of the questions. They are general questions. So we found
No, they are very relevant questions, and I'm glad you pointed out, because I think there's a very good study you have done. It's a very highly impressive study. I wanted everybody to know that the contents, I know it, but I wanted everybody else to be also aware.
So basically, we are conducting this study as a larger study like this EPDS is only for depression, but
yes,
for this
yes,
study,
yes,
we are
yes.
also including DAS for somatic symptoms, anxiety, stress, etc.
Absolutely. Well done. Very
but
good.
We have taken only one aspect to present.
Very good.
And
are you having any data on APD of these women before COVID?
No, we didn't have. In fact, this is something I was thinking that we should. It's such a simple thing, and we should always do it for like all of our patients, because all are stressed, and even like ACAG has recommended universal screening. We have not been doing, but I think after this study, I'm going to do it for everyone.
No, Vidushi, this is a very good and very highly impressive. Very good. Well done. Thank you. Thank you, Dr. Tarun.
Thank you so much, Dr. Vidushi. Ma'am, with the permission of chair, there is one presenter left, Dr. Shalini Shakarwal.
And Dr. Ayushi Gupta. Ayushi Gupta.
Dr. Shalini Shakarwal. She is from this session.
And Dr. Ayushi Gupta also could not connect.
Yes, ma'am.
Yeah.
Okay, we are on. Please carry on.
So I'm going to ask Dr. Shalini Shakarwal. Her code is CV4. Dr. Shalini, are you there? Dr. Shalini? Backup team.
Hello. Good afternoon, everyone. I'm here, Dr. Shalini. Yeah, I'm sharing. Is it visible? My screen is visible or not? Hello?
Yes, Dr. Shalini, please carry
Ma'am,
on.
is my screen is visible?
Yes, it is visible.
Okay, ma'am. Good afternoon, everyone. I'm presenting a case, a very interesting case of, she is 24 years old, para 2 life 2 patient. She was referred from a peripheral hospital, government hospital to our hospital on post-operative day 3 of elective LSCS, and it was done. She was not willing for VBAC, that's why it was done, and she came with mild symptoms to our institution. On examination, she was asymptomatic, maintaining her saturation, vitals were stable, and gynecological examination was unremarkable. So we kept her on antibiotics and for observation. But on day 7 of our LACS, post-op day 7 of the LACS, she developed multiple episodes of tonic-clonic seizures. Before that, she had one episode of vomiting. Then and at that time, her BP was 142 by 114. That was raised. So we gave IV labetalol 20 milligram. After that, her BP was stable throughout. So we started her on the moderate protocol, that is dexamethasone, injectable no molecular weight heparin, and IV phenytoin loading, followed by the TDS dose. So we kept her under observation. We took the neurology referral. We sent our investigations, which came out to be normal, and her CT contrast. Enhanced CT as well as non-credence, both are done, both were normal. So we observed her for rest of the period. She was asymptomatic, she was stable, she didn't throw any further seizure episodes, and her BP was normal. So I presented this case because there's no I think this is because she doesn't fall in the category of preeclampsia, eclampsia, and she doesn't have any history of seizures prior to this. So she doesn't have any history, any medical, any surgical illness. So that's why I think this case is very interesting. So I took this case.
Thank you so much. Now the topic is open for discussion.
Thank you, Dr. Shalini.
Yes.
That was a very well managed case, and seizures in pregnancy. You ruled out all other causes of seizure like dyselectrolytemia,
Ma'am,
hypomagnesemia.
yes, ma'am. All other investigations were normal, except her D dimer was mildly increased. That was 1136, and that also came to normal after 2 days. Like
why your patient is not is of postpartum eclampsia?
Ma'am, because according to the literature, it is we take postpartum eclampsia only till 48 hours after the delivery. That's why it doesn't fall in that category.
But it can occur up to 7 days.
Ma'am, because I have seen the literature, and in our book, Resnick, that is a maternal fetal medicine book, that is well and clearly they have mentioned that we take patients only till 48 hours after delivery. That falls in preeclampsia, eclampsia.
What is the incidence of antepartum eclampsia? What is the incidence of intrapartum eclampsia? And what is the incidence of postpartum eclampsia? Just off the cut, I'm asking you a question. Since you have got a case of fits, seizures, I'm asking. If you were to see 100 eclampsias, how many of them would have thrown a fit antenatally, intranatally, postnatally?
Most of the patients, they throw fit in the third trimester antenatally.
Firstly, I'm asking the incidence. It's very clearly written. Okay, thank you very much.
Okay, thank you
so much. We are moving to the next presenter, Dr. Ayushi Gupta. Her code is OTH26. Dr. Ayushi, are you there?
Yes, sir.
Please share your screen.
Okay, sir. Is it visible?
Yeah.
Okay, I'm present.
You can
I'm
start.
presenting a case of puberty menorrhagia, a rare presentation of acute myeloid leukemia. A 14-year-old girl presented in February 2020 with the complaints of heavy bleeding per vaginally for 1 month, requiring 3 to 4 pads per day, associated with weight loss approximately 4 to 5 kilograms, anorexia, and easy fatigability. She attained menarche at 13 years of age, and her cycles were regular ever since. Investigations revealed severe anemia of hemoglobin 4.5 gram per deciliter and thrombocytopenia of platelet count 11,000 per millimeter cube. Her coagulation profile, serum TSH, chest X-ray, and ultrasound pelvis were reported as normal. Her peripheral smear showed bicytopenia with 11% of blast cells, and more than 50% of these blast cells were positive for myeloperoxidase, implying the diagnosis of acute leukemia. This diagnosis was confirmed on bone marrow biopsy, which showed acute leukemic infiltration of bone marrow, and flow cytometry was reported as acute myeloid leukemia with monocytoid differentiation. This patient was managed by transfusing 2 units of packed cells. Vaginal bleeding got controlled with tranexamic acid 500 mg TDS and norethistron 10 mg TDS. 1 cycle of induction phase chemotherapy with daunorubicin and cytarabine was given in consultation with hematologist. Repeat bone marrow biopsy showed after 1 cycle of chemotherapy showed favorable changes with myeloid maturation up to neutrophils. Subsequently, this patient ceased to follow up with us as our center was turned into an exclusive COVID-19 treatment facility, and due to lockdown, this patient stayed at home for 6 months, due to which she developed leukemic retinopathy. Presently, she is in a private healthcare facility and continues to be in a precarious state. On concluding this presentation, I would like to say every patient of puberty menorrhagia should be screened for blood dyscrasias and coagulation disorders. Peripheral smear and coagulation profile are important investigations in workup of these patients. And the present case highlights how COVID-19 pandemic has led to delayed treatment of life-threatening diseases, adding to morbidity of this patient. Thank you.
Thank you, Dr. Ayushi. That was a very well managed case, again showing us the brunt of the COVID, which has been borne by many patients. You know, it is a sad state that COVID has prevented their treatment. So, in my question to you is, can you name some other causes of puberty menorrhagia?
Yes, ma'am.
In sequence, commonest versus less common.
Yes, ma'am. The most common cause lies in anovulation amongst patients. Then the next most common cause is polycystic ovary syndrome, hypothyroidism, and then comes the coagulation disorders, and finally the blood dyscrasias, for example,
which is the
leukemias.
commonest coagulation problem, and what is its incidence?
Ma'am, the commonest coagulation problem is von Willebrand disease. It is an autosomal disease, and sorry to say, ma'am, I don't know the incidence right now.
Okay, thank you very much. Dr. Nidhi?
Thank you, ma'am.
Thank you, Dr.
Thank you. It was a nice presentation.
Thank you. Thank you, Dr. Tarun.
Thank you, ma'am. I would like to invite Dr. Nisha also. Dr. Nisha, are you there?
We don't have a name in our list, Dr. Tarun.
Dr. Nisha, CV6.
No, we have not.
No. There is Nisha Yadav, severe preeclampsia with pulmonary edema mimicking COVID-19 in
pregnancy.
No, Nisha Yadav. We have done it or no?
Yeah, Nisha Yadav.
Dr. Nisha, her code is CV6.
But Dr. Nisha is not there. Not joined.
Not joined. Okay, fine. Thank you, Dr. Tarun. I think Dr. Nidhi and myself, we have tried to keep our questions very crisp and short so as to make up for the time lost. I know Dr. Ruma is staring at us, but sorry, Ruma, we tried to do it as fast as possible. Thank you so much.
Thank you, AOGD.
And Dr. Nidhi for being able to manage this so beautifully. Thank you, Dr. Nidhi. And I think they deserve a proper introduction to the gathering. Tarun, please would you do that? Because in my hurry, I forgot to introduce them in the way that they deserve. So please start by introducing Dr. Nidhi and Dr. Geeta.
Dr. Nidhi, Assistant Professor at the Hamdard Institute. Ma'am, we are just at the end of the session, we are introducing like that. We are
How
very
it
sorry
would
for
happen.
the technical glitch.
Yeah.
Yeah. And
No problem.
Geeta Direta, ma'am needs no introduction, I think. She is the pillar of AOGD. Ma'am is the senior consultant and Institute of Obstetrics and Gynae, Sir Gangaram Hospital. Ma'am, we welcome you at the last of this session. Please pardon us.
Thank you. I think Sharmishta is getting
Tarun.
very anxious. Let's proceed.
Thank you, Tarun. Thank you, AGD.
We are moving to the next
Thank
session.
you. Thank you.
Dr. Sharmishta. I would like to introduce Dr. Sharmishta.
No, Tarun, I'll introduce myself. Thanks a lot.
Okay. Thank you so much.
Yeah, thanks a lot, Tarun. Thanks a lot, Tarun. So now we begin with the session 4. I would like to call my esteemed judges. Dr. Neeta Sagar ma'am, she is the HOD and senior consultant in Jagpravesh Chandra Hospital, New Delhi, and Dr. Kusum Arora, she's CMO, senior administrative grade officer, and she's also in charge of COVID testing in Government of New Delhi and NCT area. Dr. Kusum Arora ma'am and Dr. Neeta Sagar ma'am and Dr. Nidhi Kira ma'am, she is unable to join us. So Dr. Ruma Satvik ma'am will be joining us as the third judge. Ruma Satvik ma'am is our consultant in Institute of IVF, Sir Gangaram Hospital. I welcome you all and special thanks to Kusum Arora ma'am. Okay ma'am, so with all your permission, I would like to begin the session and I would like to call my first presenter, Dr. Raksha Soni. Dr. Raksha Soni, are you there with us?
Good afternoon, ma'am.
Hi, Raksha. So her paper code is OTH1, right, Raksha?
Yes, ma'am.
Yeah, so Raksha, there is one request in front of the judges. I'm telling you, dear, because you're given only 3 minutes time. So try to just summarize your case so that judges get enough time to ask questions to you because you will be marked on that. Okay?
Okay.
So try
Ma'am,
to
my
keep it short,
screen.
try to summarize your case.
Okay, my screen is visible, ma'am.
Yeah, we can all see you.
Yeah. It's visible. Good afternoon, everyone. I will present the new concept of embryological vaginal development in relation to vaginal anomalies that has been a dilemma all these years. This insight came with a 13-year-old teenager who presented with typical symptoms of cryptomenorrhea. On clinical examination, a suprapubic mass of 14-week gravid uterus size was palpable abdominally. Local examination was unremarkable. On per-rectal examination, a bulge was palpable 5 cm above the anal verge. Patient was investigated. Blood investigations were normal. Her chest X-ray, cervical, dorsolumbar spine X-ray were normal. USG upper abdomen KUP were normal. On ultrasound pelvis, we were able to see the distended uterus and the endocervical canal. However, there was dilemma about the vagina. MRI pelvis was done, which revealed hematometrocorpus with dilated upper part of the vagina. However, the middle and distal part of the vagina were not visualized. With the differential diagnosis of transverse vaginal septum and vaginal agenesis in mind, we prepared the patient for the OT. Now, the intra findings were, patient were dissected. Dissection was done in the rectovaginal space for about 8 cm. Vagina was atretic in most part except for the cornices. Cervix was present, hematometra drained, and skin graft covered foam mold placed in vagina. Post-operative result was final vaginal length was about 12 into 3 cm. Vagina was healthy. There was no pus discharge and patient had normal menses. Now taking you to the current concept of vaginal development, till so far whatever knowledge we were having was either based on the histological staining of the human fetus or the studies based on the immunohistochemical markings in the mice. However, as per the recent studies carried by Stanley Jobson, on the human embryo using the immunohistochemical markers separately for the urogenital epithelium and the Mullerian epithelium, it was concluded that most of the vagina develops from the urogenital epithelium and only the upper part of the vagina restricted up to the fornices develops from Mullerian epithelium. This patient is an absolute clinical proof of the current concept and is a case of pure urogenital epithelium anomaly, that is the partial vaginal agenesis, which is an extremely rare case with an incidence of 1:70,000. It's important to understand the embryological basis of vaginal development, as partial vaginal agenesis is completely different from complete vaginal agenesis, which is popularly known as MRK syndrome. In partial vaginal agenesis, till yet, we are not able to find any genetic cause as per the latest studies, and the associated syndromes, it is not associated with any syndrome. The associated anomalies are completely different from the MRK syndrome. And these are vesicovaginal, rectovaginal fistula, cloacal anomaly. Laparoscopy is usually not required in these cases. It requires vaginoplasty with or without corrective surgeries of the anorectal canals. After surgical correction,
Raksha, Dr.
Yes,
Raksha,
ma'am.
you are running out of time. You've already consumed your 3 minutes. Okay, I just told you to summarize your case because the judges will not get time to ask questions then. Okay, we are done with 3 minutes. Please give judges some time to ask questions.
Yes, ma'am.
Judges, please proceed with the questions.
Yeah, Dr. Raksha, I want to know that do you think this case is rare? And if it is rare, in what sense it is rare? This presentation is rare.
Ma'am, the incidence of partial vaginal agenesis is 1 is to 70,000. In this case, we have no other associated Mullerian anomaly, and only the lower portion of the vagina, that is the lower 2/3 portion of the vagina, was atretic, and there was no associated anomaly. So, in that aspect, it is rare.
Okay. What is the conclusion you have drawn from this case? That you tell me. What conclusion you have drawn from this case?
Ma'am, when we were ma'am, during the diagnosis of this case, there was a dilemma that whether it is a transverse vaginal septum or it is MRKH, it is vaginal agenesis. So after going through the literature, I came to the point that the transverse vaginal septum, this term itself, it is a misnomer. It is a misleading term because transverse vaginal septum can occur at any level. It can occur at any level and it can occur of any thickness. So now, as per the recent literature, partial vaginal agenesis, which were earlier classified with complete vaginal agenesis, is now classified with transverse vaginal septum as a part, or as it present as a spectrum. The partial vaginal agenesis is a part of spectrum only. So my point
no, what is the recent insight of the embryological development?
Ma'am, recent insight is initially the partial vaginal agenesis was classified with complete vaginal agenesis because it was believed that most of the vagina is derived from the Mullerian duct. But now, as per the recent studies, which is carried out in 2017 yes, ma'am, which is carried out in 2017 and 18, it is now known that most of the vagina, almost the complete vagina, is derived from urogenital sinus epithelium, and only the fornices, the uppermost part of the vagina, is derived from the Mullerian duct. So the partial vaginal agenesis are now classified along with the transverse vaginal septum, and as per the authors, as per the recent studies, transverse vaginal septum is a misnomer. It should not be used. Rather, there should be a separate classification for the cloacal anomalies. Even in the Eshrey classification, I have put a question mark.
It's okay. Okay.
Ma'am, time is over.
Let's move to the next one.
Dr. Raksha?
Yes, ma'am.
Dr. Raksha, tell me, what are the other syndromes associated with it?
Ma'am, there can be Fraser syndrome.
Syndromes
with MRKH, the syndromes which can be associated are the Bradel-Beadle syndrome, Kaufman-Mokosic syndrome, then the Fraser syndrome can be associated. But no specific syndrome is associated with partial vaginal agenesis.
Okay, doctor.
Okay,
next case.
Yeah.
Thank you.
Thank you. Thank you, Raksha.
Thank you.
Now I would like to call Dr. Neha Bhardwaj.
Good afternoon, ma'am. Can you please hear me?
Yeah, we can hear you, Neha.
Yeah.
Can you please start sharing your screen?
Presentation. Can I please ask the background team to share my poster? Can that be done? Because I'm not able to share my presentation slide.
Okay, backend team, can you please help her? Hello?
Yes.
Yeah.
Yeah, wait a second. I'll share.
The topic for Neha's presentation is rare presentation of ruptured endometrioma in a young girl.
Thank you for
ask the presenter to switch on her video, please. All presenters to do that.
Yeah, please, all presenters, please note, switch on your video camera whenever you're speaking so that judges can see you.
Okay.
Yeah.
Doing it.
Turn on your camera.
Okay.
And try to summarize your case in 1.5 minutes so that we have got 1.5 minutes to ask questions.
Okay.
Yeah, now we can see you, Neha. Please start your presentation.
The title of my topic is Rare Presentation of Ruptured Endometrioma in a Young Girl. Endometriosis affects 5 to 15% of women in reproductive age group, out of which only less than 3% are unfortunate to have ruptured endometrioma. My case is about a 22-year-old unmarried female who came to us with a pain lower abdomen from past 15 days. Her last menstrual period was 4 days back, and she had been experiencing regular menstrual cycles. General condition was fair and vitals were stable. Per-abdominal examination revealed a 14-week size abdominopelvic lump, which was mildly tense, tender, and non-mobile. Urgent USG MRI's correlation was suggestive of large endometrioma cyst measuring 13.5 into 13.2 centimeters, which can be clearly seen in the first slide. We planned her for laparoscopic cystectomy, and a night before surgery, unfortunately, she presented with severe acute pain abdomen, which was associated with vomiting. Her general condition, she was tachypneic, and her BP was 108 by 64 millimeters of mercury. Per abdomen examination revealed no abdominal pelvic lump, and localized tenderness and guarding was there in the lower abdomen. USG MRI correlation was suggestive of no adnexal cyst with free fluid suggestive of ruptured endometrioma, and that we can see in the second figure. We planned her for emergency laparotomy with a query being kept as ruptured endometrioma cyst. Per our findings revealed chocolate color fluid, which can be seen in the third figure, which was of 250 cc volume in the peritoneal cavity. Ruptured right cyst had formed adhesions with small and large bowel posteriorly and could not be separated from bowel. Right fallopian tube, left side ovary, and adnexa were normal. Post-op was uneventful. Follow-up with ultrasound after 1 month revealed normal bilateral ovaries with no evidence of any cyst and fluid, and that can be clearly seen in my last figure. This brings us to the discussion of the topic, and that says that prolonged history of progressive dysmenorrhea in young girls should raise suspicion of endometriosis. The differential diagnosis can be kept as ectopic gestation or spontaneous hemoperitoneum. It has varying features in pregnancy, which can be peritonitis, colonic perforation, hemoperitoneum, and fetal death as well. This brings to the conclusion of the topic, which is that endometrioma rupture is a rare entity. It should be suspected in young female with large ovarian endometrioma presenting with sudden onset of features of peritonitis. Its enigmatic etiopathogenesis makes it difficult to diagnose and treat. But fortunately, we have early ultrasound and MRI can aid in timely diagnosis and treatment. The management can be conservative or operative. Early surgical intervention can reduce adhesions and preserve future fertility. Thank you.
That's great, Dr. Neha.
Thank you.
Just one quick question. Was there a histopathology report available in this case?
Ma'am, we had to take the patient for laparotomy since the patient came in the middle of the night. So we actually didn't end up sending the histopathological report. We did not.
And have you heard of hemorrhage into a cyst? Like, could it have been a corpus luteal cyst?
Definitely, ma'am. It can be corpus luteal cyst, in fact, the neoplastic cyst, but we can easily differentiate it because we have done the MRI, which differentiates the hemorrhagic cyst from the...
What about her history of prolonged dysmenorrhea? You don't mention that.
Yes, ma'am. There was a history of prolonged dysmenorrhea. And I have, ma'am, mentioned it, progressive dysmenorrhea from past 4 to 5 months she had been having it.
Not in her history, you mentioned in discussion.
Yes, ma'am.
Okay, fine. Thank you.
Neha, I want to ask, are there chances of recurrence in this case?
Yes, ma'am. The chances after surgery is 20 to 50% after 5 years of surgery. So that is a recurrence rate now.
Okay. Okay. Any other questions, ma'am?
And do you think your surgery was complete? So there was a rupture, and do you think it was complete?
Ma'am, there was a rupture, and when we opened the abdomen, there was only chocolate color fluid, and then we did the gastric lavage, and we had to put the drain because there were a lot of adhesions, and we were not able to see the anatomy of the ovaries and the annexa properly. So that was a drawback that we had when we did laparoscopy in the middle of the night.
Okay.
Sure. Thank you, Dr.
Next case.
Yeah. I would like to call the next presenter, Dr. Advika T.S.
Good afternoon, all. Am I audible?
Yeah, Advika. Please
I'll just be sharing my screen.
Yeah.
Is my screen visible to all?
No, not yet.
How about now?
No, we still don't see you. No,
yeah.
Now we can.
It's visible now.
Please enlarge it.
Good afternoon, all. Good afternoon. Good afternoon, esteemed judges. Is the slides, is the slide okay?
Yeah, it's okay.
Okay. Thank you. I'll be presenting a case of malignant mixed Mullerian tumor of uterus. The case was a 60-year-old postmenopausal woman who presented with features suggestive of a malignant uterine mass that was retrospectively diagnosed as malignant mixed Mullerian tumor of uterus after histopathology. Now, this comprises about 5% of all uterine tumors. Our patient presented with pain, abdomen, and bleeding per vagina for 1 month, which that's 2 out of 3 of the triad of presentation of MMTs. The triad also includes necrotic discharge per vagina. Given her presentation, some of the differentials we've had in mind were a fibroid polyp, which had undergone, because she presented with a polypoidal mass on per speculum, we thought of a fibroid polyp that could have undergone secondary malignant change or an endometrial CA. Imaging that she underwent was an ultrasound and a CECT. CECT showed a 7 into 9 into 9 centimeter mass in the pelvis. The uterus was not delineated. And however, the important thing is that on CECT, no invasion of the bladder or rectum was noted and no lymph node involvement was noted. She underwent a surgery on laparotomy on opening the abdomen. A bulky uterus with inversion of the uterus was the only finding that was noted. No mass was externally visible. However, on opening the vault, as we had expected from our pre-op evaluation, a large friable mass was noted. And she underwent TAH BSO, post which it was noted there was no involvement of the pelvic or para-aortic lymph nodes, bladder or rectum, or any of the other abdominal organs or the peritoneum even. Histopathology showed both endometrial as well as rhabdomyosarcoma components involving more than 50% of the myometrium, and immunohistochemistry was positive for Desmond CK, which is a mesenchymal marker, and CD10, which is noted in gynecological tumors of remnants of mesonephric duct. Her post-op period was uneventful. She received 1 cycle of chemotherapy post-op with adriamycin and ifosfamide. However, unfortunately, because this case was operated around February and from March to April onwards, we started having problems related to the COVID-19 pandemic, so she could not be followed up. Thank you.
Judges, please proceed with the questions.
Let me know how you think this mixed Mullerian tumor is different from other tumor of uterus. How it is different?
Ma'am, when it first of all, this is something that presents in the postmenopausal period, which is quite similar to endometrial carcinoma. That also presents quite later on in age. However, it's a very aggressive tumor in comparison with an endometrial CA. Invasion is much more common, and the survival post treatment is also quite poor in the case of a mixed malignant Mullerian tumor. And the origin and histopathology is starkly different.
Okay, and what are the consensus about its management? Are they clear, these consensus about management? Like
there aren't any clear consensus regarding management. However, if it is an early stage, the staging that's a working classification that is used is stage 1, which involves only the uterus, stage 2 involving uterus and cervix, stage 3 involving pelvic organs, and stage 4 having extra pelvic involvement. For stage 1 and 2, an initial TAH BSO, a staging laparotomy. So that's also, it could also include a biopsy of the lymph nodes, a biopsy of the omentum, etc. And thereafter, patients undergo multimodal as well as single agent chemotherapy because there is no consensus regarding the same. They can also undergo chemoradiation. And even in a stage 3 or stage 4 cancer, if a cytoreductive surgery is possible to be performed, then initially a cytoreductive surgery followed by multimodal chemoradiation.
Okay.
Hello.
Yes, ma'am.
What do you mean by Mullerian? Can you explain?
Ma'am, Mullerian ducts are they are formed of intermediate mesoderm, which lies lateral to the mesonephric duct, from which the female genital tract and the upper part of the vagina is formed.
Okay. Types of tumors. Types of tumors. Hello.
Yes, ma'am.
What are the Mullerian tumors? What are the types of Mullerian tumors you know of?
I'm not very sure of this answer, ma'am.
Okay. Okay.
Okay, thank you, Dr. Advika. Now I think we should move on to the next presenter, Dr. Rajeshwari Punia. Dr. Rajeshwari, are you there? Dr. Rajeshwari?
Hello, ma'am. Can you hear me, ma'am?
Yeah, Rajeshwari, we can hear you. Please start sharing your screen. And just try to summarize your case, but don't go into details because the judges are not getting enough time to ask questions. Okay, because they've all read your posters before also.
Can you see my screen, ma'am?
Yeah, we can see it.
Yeah, we can see.
Good afternoon, judges. I'm Dr. Rajeshwari under guidance of Dr. Renu Arora and Dr. Vijay Sutri. I'm going to present my poster on aggressive angiomyxoma of vulva, a 14-year-long follow-up. So aggressive angiomyxoma is a rare mesenchymal neoplasm arising primarily in the soft tissue of the vulva, perineum, and the pelvis of the adults, comes under the tumors of uncertain differentiation. So this poster is presented because it is a rare scenario. Only 250 cases have been reported since 1983. Our patient has been following with us since 19 years of age. Now she is 33 years of age. At first, she was misdiagnosed as Bartholin cyst, and the histopathology came out to be angiomyxoma elsewhere, and she came to us with a recurrence in 2009. So we took an MRI in which there was infiltration in the pelvic floor. So we have done a wide excision and we have sent it to histopathology. In the immunohistochemistry also came out to be estrogen and progesterone receptor positive and also vimentin positive, pointing towards a mesenchymal tumor. So she had multiple recurrences since then. In 2012, she had a recurrence, and then she had a robotic surgery elsewhere in a private setup. We followed her with MRI, and 2013 she had a minor recurrence, and 2015 she had a major recurrence involving the ischiorectal fossa and the perineum as well as the pelvic floor. When she got pregnant, we also followed the tumor size. We found that there was increase in size of the tumor up about 13 centimeter during pregnancy, and there was immediate post LSCA she had a decrease in size of the tumor. And we had again a local excision in 2016. So based on the ERPR positive status as well as the course in pregnancy, this was a hormone sensitive tumor. So we had started her on intermittent GnRH agonist, and she had a temporary resolution with the GnRH agonist. We started her on injection leuprolide, depot preparation, 3 monthly injections. She got once or twice in the last 1 year. At present, she's 33 years and she had again recurrence in 2020 when she was not on GnRH agonist. And the histopathology, as she has shown in the figure, it's a homogeneous hypocellular vascular myxoid stroma, and little to no mitosis was present. It is an angiomyxoma. So we presented this case because it is a very rare differential of a recurrent vulval swelling, locally aggressive, hormonally sensitive tumor. The metastasis is rare yet reported to lungs. Surgical wide local excision is the mainstay of the management with adjuvant GnRH agonist with MRI follow-up for recurrences. So radiotherapy is not much useful because the mitosis is less, and the embolization had been tried pre-operatively also with varying success rates. Several case reports, they show that GnRH agonist is used for complete resolution also. Thank you.
Very good case, huh? Long follow-up. Good.
Thank you.
Can you tell me what is the mainstay of the treatment of in this to prevent the recurrence?
Ma'am, wide local excision is the mainstay of the treatment, ma'am, but it is almost impossible because there is no definite capsule for this tumor and it is highly vascular. So for the number of repeated surgeries the patient need is more, ma'am. In all the case reports that you have presented, the patient always needed multiple wide local excisions, ma'am.
Why is an embolization not possible?
Ma'am, there was no single feeding vessel for the tumor, ma'am, because it's highly vascular. So
Recurrence is always in the same site? Recurrence is always in the same site?
Yes, ma'am, same site, and it was progressive, ma'am. Like it started in vulva and it was encroaching into the perineum, ischiorectal fossa, and perianally. Final excision was done with difficulty, ma'am.
And when you say this is estrogen progesterone sensitive, the response you got with agonists, or you were even considering Mirena at some point, was it appropriate? Did you get good response with hormonal suppression?
Yes, ma'am. So Mirena IUS, ma'am, we have inserted for the first time in before 3 months, ma'am. We are following up the patient and we have yet to confirm the response, ma'am.
What about GnRH and agonist?
Agonist means the patient is asymptomatic when she is on GnRH agonist, but once she is off GnRH agonist, she again start to have recurrences, ma'am, slowly.
Good, very good case.
Good. Very good case.
Thank you, ma'am.
Doctor, what are the differential diagnoses in your case, aggressive angiomyxoma?
Ma'am, differential diagnosis being all the valvular swelling differentials, ma'am. If it is cystic, it can also present like a Gardner duct cyst, Bartholin cyst, or abscess, or it can even present as sarcoma, ma'am. That is a separate entity. Other myxoid tumors also it can present.
Most common?
Ma'am, most common is if it is, it can present a cystic lesion, ma'am. So Bartholin is the most common differential that we have to see.
Okay. Okay. Thank you, Dr. Rajeshwari.
Thank you.
So I think I just got a message that the next candidate, Dr. Raj Rathod, has not joined yet. So judges, please note, we are moving on to the next participant, who is Dr. Swati Dhar. Dr. Swati Dhar, and her code is OTH6. Dr. Swati, are you ready with your presentation? Yeah, here we can see your screen. Dr. Swati, please turn on your camera.
Hello. Hello, am I audible?
Yeah, you're audible.
Good afternoon, everyone. I'll be presenting two cases in which we'll be discussing the hysteroscopic management of retained intrauterine fetal bones post-abortally. Through these cases, I'd like to show that there's a wide clinical spectrum of presentation of these cases, and as these are very rare complications, these are rarely suspected and considered very late in the workup of the patient. The first case is of Miss X. She's a 34-year-old patient with the secondary infertility who had a history of DNC 16 years back at 4 months of gestation at a private setup and was unable to conceive since then. There were no menstrual complaints related with the patient. On PV examination, the uterus was found to be slightly bulky. The rest of the infertility workup was within normal limit as pertaining to the hormone profile and the HSA. However, on TVS, two definite hyperechoic myometrial lesions were seen, which had calcifications. And for this, with the suspicion of some retained foreign body, a hysteroscopy was done. And on the hysteroscopy, there were multiple calcified areas seen embedded in the walls, which were removed under vision. And grossly, the specimen resembled fetal bones and was also sent for histopathology, on which it was confirmed to be the same. Currently, the patient is undergoing ovulation induction for infertility treatment. The second case is of patient Y. She's a 27-year-old, para 1, live 1, abortion 1. She's having a complaint of discharge PV since 1 year and had also started developing dysmenorrhea since some time, and these problems had increased since 3 months. There were no associated symptoms seen. The patient had sought treatment from other facilities as well, and in some outside ultrasound, she had some hyperechoic lesions seen, for which she had even undergone a repeat DNC, but to no avail. When patient came to us, we examined the patient and saw that some white foul-smelling discharge was present on per speculum examination. However, the uterus was not very much enlarged in size, was almost normal. The patient was the patient also underwent TVS, on which we saw multiple hyperechoic foci seen in the endocervical canal as well as in the cavity itself, for which she underwent hysteroscopy again, on which multiple white heart structures.
Dr. Swati, excuse me.
Yes,
Dr. Swati, you're running out of your time. You have to give time to your judges to ask questions, please.
Yes, ma'am. Ma'am, multiple white heart structures were seen and which were removed under vision, and they were also found to be long fetal.
All right, we understand your case. We have, I have one question, and then Dr. Neeta and Dr. Kusum now take over. One question is, what has been the pregnancy follow-up in case 2? The first one you say is undergoing ovulation induction. What about case 2?
Ma'am, the case 2 did not present with infertility. That is the point, that she only had local symptoms.
All right.
Yes.
So, what is the need for ovulation induction in case 1?
Ma'am, in case 1, ma'am, because she's already 34 years of age, we did not want to just leave it for spontaneous, and therefore considering it as a sort of a mixed type, So like in the treatment of unexplained infertility, we go for OI with IUI. So we've started around
It's not
OI
a case of
tentatively.
a case of unexplained. You already mentioned why she's infertile in your discussion.
Ma'am, but even in literature, I've seen that even after the removal of intrauterine retained fetal bones, there have been cases where the patient has not been able to conceive spontaneously.
That is because of an endometrial cause, not because she was unable to ovulate, right?
Yes, ma'am. Yes,
so
ma'am.
the right treatment is ideally to wait for 5 to 6 months before thinking of
For the age, actually, age factor was considered.
Thank you.
Thank you, ma'am.
Do you think always this hysteroscopic removal be beneficial in all the cases?
Ma'am, as a screening, first of all, TVS can be done, but yes, hysteroscopy is considered a gold standard for removal of retained intrauterine fetal bones as seen in most cases.
Are there any cases in which you won't be able to, on ultrasound, there is a bright echogenicity is there, and on hysteroscopy, you won't be able to see anything. Is it possible?
Ma'am, if the calcific foci are deep in the endometrium, it might be possible. We might not.
Okay. If the hysteroscope is not there, any other way? In many hospitals, it is not available. How can it be removed then?
Ma'am, in literature, I've read that in some places they've even tried blind DNC again, and they've been able to curate out the bones which were superficially present.
Okay. Okay.
Sir, tell me the causes of this retained intrauterine fetus.
Ma'am,
Important.
Yes, ma'am.
Important causes of this retained intrauterine fetus.
Ma'am, fetus papyraceous is ma'am. Usually, the patient in 80 to 90% of the cases of these patients, they've given history of abortions and followed by mid-trimester DNCs. And especially if it is done beyond 12 weeks, it is more likely that they'll have intrauterine fetal bones, as endochondral ossification of the long bones and flat bones would have occurred by then.
History of abortions, you want to say?
Yes, ma'am.
Other causes?
Ma'am, other causes, ma'am, it can be, ma'am, osseous metaplasia can be there, or if the patient is having any cause of metastatic calcification, like hyperparathyroidism. Or ma'am, even in cases of chronic infection like endometrial TB also, we might have some cases in which there might be some calcific foci present.
Thank you, Dr. Swati. Ma'am, Dr. Raj Rathod has joined, who was the previous candidate. He has just joined. So I'm calling Dr. Raj Rathod. Are you there? Dr. Swati, please stop sharing your screen.
Yes, ma'am, I'm present, ma'am.
Okay, Dr. Raj, please start sharing your screen now.
Yes, ma'am. Just a minute, ma'am.
Yeah, again, to brief you, Dr. Raj, please wind up your presentation within a minute so that judges get 2 minutes to ask questions.
Okay, ma'am. Can you see my screen, ma'am?
Yeah, we can see, but the font is very small. We can hardly.
You just enlarge it.
Are you able to see now?
Very small.
Ma'am, I am.
PowerPoint setting where you see the one at the bottom.
Right, ma'am. Zoom it, yes, ma'am.
Yeah.
Just summarize your case. Okay.
Yes, ma'am. Ma'am, I'm Dr. Raj Rathod from Maulana Azad Medical College. I'm here to present a case of asymptomatic uterine arteriovenous malformation, a rare case. It is a rare condition with less than 100 cases reported in the literature. My case being 33-year-old, gravida 14, paravan live-in, abortion 12, female. She was referred to our institute with an incidental ultrasound finding of a uterine arteriovenous malformation. Patient was asymptomatic and had no episodes of pervaginal bleeding or pain in abdomen. She had a significant past history of 4 surgical evacuations and a full-term LSCS. On examination, she had no pallor, and the per-abdominal examination was also normal. On per-vaginal examination, the os was closed, uterus was enlarged to 6-week size with bilateral adnexa not palpable. Her blood investigations were normal. Beta-HCG was spent, which was 21, and after that, which was followed, and it was in the following trend. On radiological investigation, transvaginal ultrasound with color Doppler was done, which confirmed the diagnosis of uterine arteriovenous malformation. Even on MRI and CT angiography, it was confirmed. And with it, the patient had imperceptible myometrium along the anterior aspect of the lower uterine segment which was the area of previous cesarean section scar, suggestive of the cesarean scar defect. As the patient was hemodynamically stable and had no complaints of bleeding, we, along with the consent of the patient, managed her expectantly and was successful in doing so. Her follow-up ultrasounds were done after 2 months and 4 months, and it showed resolution of the uterine lesion. The patient had complaints of on and off spotting with no evidence of any excessive bleeding. She has resumed her normal menstruation since last 2 months, ma'am. These are the CT images which are visible. Here, we would like to bring to your notice that uterine arteriovenous malformation is a pathology of concern because of the ability to cause catastrophic bleeding. So it is always supposed to be having a high suspicion in patients with unexplained vaginal bleeding, especially in reproductive age group women with histories of previous LSCS, abortion or delivery. And the management options should mainly be determined on the basis of the hemoglobin and the size and site of the lesion. There are various management options, and it is not that only one particular management is the best, should be curated according to the patient's needs. The differentials also should be kept in mind because any surgical intervention. Hello, am I audible, ma'am?
Yeah, you're
Dr.
audible.
Raj. Yeah, Dr. Raj, you're running out of your time.
Okay, ma'am. So, ma'am, in my case, the patient had the previous surgical interventions and LSCS history. And with that, because of the imperceptible myometrium, it can be a likely cesarean scar pregnancy leading to AVM malformation. Thank you, ma'am. Ma'am.
Dr. Rathod, can you tell me what are the various modes of management?
Ma'am, the patient
in
can
AVM.
Yes, ma'am. The patient can be managed expectantly, in which we follow the patient without giving any symptomatic. Other than that, we can give. Hello.
Yeah, I'm listening.
Yeah. Other than that, we can give medical management. In that, we can give GnRH agonist, ma'am, or the ocipil, or we can have embolization, ma'am, or else hysterectomy. These are the 4 options available, ma'am, for management.
So in this case, you just left her for conservative management, giving some hormone therapy, or just on conservative
No, ma'am, it was
management?
just conservative management. She regressed spontaneously. We were just giving her symptomatic management if she had any episode of bleeding, ma'am.
And she remained admitted with you?
Yes, ma'am. Actually, when she was referred with the ultrasound findings, is when she was admitted with us for 10 days. After that, every regular interval, she used to come on OPD. She used to have her contact numbers and was explained thoroughly of if can be the catastrophic bleeding she can face. And she consented of no need for the embolization. And as the patient was hemodynamically stable and no complaints,
and what is the gold standard of diagnosis of AVM? Gold standard.
CT angiography is the gold standard for the diagnosis of AVM. We got her CT like contrast enhanced CT angiography, ma'am, and through which we confirmed the diagnosis that it is uterine arteriovenous malformation.
Are there any chances of recurrence again?
Ma'am, actually the data is not sufficient enough to comment on this, but I have got 1 or 2 studies and I've quoted one of them here. It shows that the patients who have been treated with uterine artery embolization have shown 17% of recurrence as per the study. But I don't have sufficient data to quote a particular number, ma'am.
So do you think follow-up is very important in such cases?
For sure, ma'am. We are following.
You're following
Yes,
this case?
Yes, ma'am. I am in touch with the patient, and the patient is further under us only, ma'am. Actually, the hospital is COVID right now, but still has her contact number. She remains in touch.
Okay.
How will you differentiate whether the malformation is arterial or venous?
Ma'am, arteriovenous malformation is capillary, like they don't have an intervening capillary network. It's directly an artery meeting the vein. So usually the findings which we see in CT angiography is that there is enhancement in the arterial phasings with early venous filling, ma'am. So that is very peculiar of arteriovenous malformation.
By intraluminal pressure?
Intraluminal pressure for sure, because now the venous supply will have high flow velocities, and the arterial flow would have low velocity and low resistance, ma'am. So that is.
So judges, can we move on to the next?
Next, yeah, next case.
Thank you so much,
Thank you, Dr. Raj. Yeah, now I'm calling Dr. Suma Sheth. Dr. Suma, are you there?
Good afternoon, everyone.
Yeah, good afternoon, Suma. So please start sharing your slide.
What is Shuma's number?
Shuma's number is OTH7.
Okay.
Is it visible, ma'am?
No, not yet.
Dr. Suma, please turn on your camera also.
Yes, ma'am. I have turned on it. Turned it on.
Visible.
We don't see either of them.
The technical team, please share Dr. Shuma's poster.
Yeah, now we can see. Shuma, please start.
Good afternoon, everyone. Today I'm presenting a case on Hurlin-Werner syndrome, also called OBERA. It's a rare congenital anomaly of lower abdominal and pelvic organs. Its incidence is 0.3 to 5%. OBERA stands for obstructed hemivagina and ipsilateral renal agenesis. In our case, a 15-year-old short-statured girl with kyphoscoliosis presented with acute pain and lump in right iliac fossa. She already had a CECT which was suggestive of right adnexal mass. A repeat USG and MRI was advised, which was suggestive of uterine diadelphys with right-sided hematometrocolpus and obstructed right vagina with right hematosalpinx with agenesis of kidney. She also had vertebral defects. We proceeded with hemivaginal septal resection followed by drainage of hematometrocolpus and anastomosis established between the obstructed hemivagina and normal vagina. In the same sitting, salpingostomy to drain hematosalpinx was done by hystrolaparoscopy. A Malicot catheter was placed in the neovagina for 3 days and she was followed up after her menses and USG was done, which was suggestive of minimal collection in the vagina with flimsy adhesion. Examination under anesthesia followed by adhesiolysis and hysteroscopy was followed. A condom catheter, a condom covered dental mold was inserted for 7 days and patient was discharged after 7 days with well epithelialized vagina. Most commonly, OBERA patients are diagnosed months after menarche. They usually present with pelvic pain and mass. Sometimes urinary complaints also will be there and they can also present with foul smelling discharge. Timely diagnosis is a must to preserve the fertility and further complications. Thank you.
Okay. Suma, can you tell me why in this case hysteroscopy is better in spite of normal traditional surgery? How come it is better? What is the advantage of doing hysteroscopy? You have told, na, hysteroscopically, hystrolaparoscopic, yeah, hysteroscopically you have removed.
To see the, to whether sometimes in rare cases, OBERA can be associated with septum, other septum of the uterus. In this case, it was uterus diadelphys. So to see all the anatomical variations involved with OBERA, hysteroscopy is better, ma'am.
Any other main advantage? Okay, fine. And how you have done this laparoscopy, you have told, no? This how you have proceeded with this process? How will you do it?
Ma'am, in the same setting, hysteroscopy and laparoscopy both done. In this case, we also had hematosalpinx. We have to drain that also. So we proceeded with.
Okay, laparoscopy is fine because there was. How will you proceed with your hysteroscope? How will you proceed with it? Like, what is the management and what is the way of treating it with hysteroscope? How will you do? What will you do?
In this patient, right-sided bulge was
What's
seen.
the procedure? I want to know about that.
Yes, ma'am. Right-sided bulge of the hemivagina was seen, and hysteroscopic guided aspiration of the bulge was done to make sure it is a blood hematocolpus. We drained and hematocolpus was we made sure it's a hematocolpus, and cruciate incision was done and extended, and septal resection was done further on.
Okay. And how do you think why these cases they report very late? Can you tell me why these cases report very late? You said na it is uterus diadelphus, na?
Yes, ma'am.
Can you tell me why these cases they report late?
Ma'am, usually they will be having menstrual pains similar to usual menstrual pains, but only when they develop a mass, they will be worried. Otherwise, in initial cycles, they will be having usual regular cycle, because the other horn of the uterus is it's communicating.
Okay. Fine. Okay, ma'am.
What is the prognosis of surgical treatment?
Ma'am, prognosis is very good if it's detected initially and corrected. Depends on the ma'am at what time she visits the hospital. If it's late, in this case, she visited a hospital within 1 year of her menarche. So prognosis is good. If she presents in later period, there is a chances of endometriosis, and she may lose
Other
her
factors on which prognosis is different?
Ma'am,
other prognostic factors?
Other prognostic, ma'am, adhesions, if it's present around the adnexa, and ma'am, size of the hematocolpus and hematometra.
Okay, next.
Okay, thank you, Dr. Suma. Our next presenter is Dr. Sukanya Sanapala, and her code is OTH8. Dr. Sukanya, are you there? Dr. Sukanya?
Able to share my screen. Could you please share that?
The backend team, please help Dr. Sukanya. She's not able to share her screen. Yeah, Sukanya, now we can see it. Please start your presentation.
Sukanya, just one thing. Don't go into discussion. Tell us what your case was with a brief history, quick examination, and how you managed. Yeah. Don't go into discussion. That can be a part of questioning. Yeah, go ahead.
My case is paraneoplastic encephalitis associated with a teratoma of the ovary. According to we report a case of 23-year-old married nulliparous female presented to the gynecology OPD with mass per abdomen since 4 months, with acute psychosis, memory loss, and cognitive impairment since 5 months. The psychotic symptoms were not relieved with antipsychotics. On per abdomen examination, a mass of 28 week size was palpable, which was firm, non-tender, smooth, with regular, well-defined margins, and side-to-side mobility was present. Ultrasound abdomen and pelvis showed a large, solid, cystic, well-defined, heterogeneously echogenic lesion of size 12 into 7.2 centimeter, with multiple cystic areas along with internal vascularity was present. MRI showed a huge mass of query ovarian teratoma. Possibility of malignant transformation was present. Psychiatric and neurology opinion was taken regarding psychotic symptoms, and MRI brain was done showing non-specific ischemic changes. Patient was taken up for staging laparotomy with unilateral oophorectomy. Patient was post-operatively improved. The psychotic symptoms was improved. Intraoperatively left ovary normal in size with deposits noted over the surface. Mass arising from right ovary 20 into 17 centimeter lobulated form adherent to omentum, which with breach in the capsule. Multiple peritoneal implants were present. Tumor along with all biopsy samples were sent for histopathological examination. The gross examination of the specimen showed 20 into 17 centimeter lobulated soft form capsule intact with breach in the capsule. Cut section showed solid with areas of bone and cartilage formation with intermittent cystic areas filled with serous and mucinous fluid. Histological report showing immature teratoma with gliomatous peritoneum. Post-operatively, patient was discussed in tumor board and was planned for follow-up with tumor markers. Patient was recovering after tumor resection. My conclusion is ovarian teratoma with the paraneoplastic symptoms misdiagnosed as psychiatric diseases, and early diagnosis with the tumor resection will improve the treatment patient outcome.
Great. That's a
Thank
lovely case, Sukanya. I have two quick questions for you. In what percentage of cases with malignant teratoma would you see psychiatric symptoms? And second is, why do you think this is happening? How do you explain the psychiatric symptoms?
The immature teratoma of the ovary contains a neuronal tissue which will cross-react with the brain neuronal tissue, and there will be antibodies forming anti-NMDR receptor encephalitis antibodies. Actually, we haven't done that because patient was not affordable. We clinically presented the patient case.
And answer to the first question, what percentage would you see such symptoms? What percentage of malignant teratoma would you see these symptoms?
3%, ma'am.
What's that?
3%.
3%. Okay.
Management in these cases?
Okay, you ask, Kusum, you ask.
What is the management in these cases?
Ma'am, tumor resection, ma'am, mainly. Tumor resection. Surgical. So mainstay is surgery only.
What else? Mainstay is surgery, fine. Anything else you can, after the removal of tumor, what else you can give to her?
Follow with the tumor markers and residual tumor left. And
is it immune
tumor markers
mediated?
are increasing. What,
Do you think is it immune mediated also?
Yes, ma'am. Immune therapy will be better useful.
And why do you think these cases report so late? Matlab, you are not able to come to know about this ovarian masses. You diagnose them quite late. Why? What is the reason behind it? What is the mainstay?
The pathology takes a quite long time for
come
the
to your
receptor
OPD quite
antibodies.
late. You will come to your OPD quite late, or you will be seeing this case quite late. Why?
Patient will be misdiagnosed as psychiatric disease, and they will follow up in psychiatric OPD and neurology OPD, but they won't come to
any other investigation. Fine. Any other investigation which is very important in this case would have been done.
NMDR receptor antibodies, they must be done, ma'am. Anti-NMDR receptor antibodies.
Okay. Next, anyone
and
else?
EEG also.
I think next case, huh, Dr. Sumishta?
Okay, ma'am. Thank you, Dr. Sukanya. Our next presenter is Dr. Anamika Baghel, and her code is OTH9. Dr. Anamika?
Hello, ma'am.
Yeah, hi, Anamika. Please start sharing your screen, dear.
Yes, ma'am.
Yeah, we can see you.
Good afternoon, everyone. I'm presenting ORR syndrome, which is also known as Werner-Vanderlis syndrome, which is a very rare Müllerian duct anomaly, which consists of a triad of uterine diadelphys, obstructed hemivagina, and ipsilateral renal anomaly. A 12-year-old presented with a pain in abdomen for 1 month, and she had her menarche 6 months back, which was associated with progressive dysmenorrhea. Her general and systemic examination was unremarkable. Her external genitalia were normal, and her breast and pubic hair belonged to Tanner stage 4. PP was not done in this girl, and on PR, a bulge was felt on right side, 5 cm above the anal verge, and the upper margin was not reachable. On ultrasound and MRI, it's suggested right-sided hematometra, hematosalpinx, and hematocolpos, and she was planned for vaginoscopic septal resection. And with the help of hysteroscope, a transverse nick was given over the bulge, and a collected blood and mucus were seen draining from the bulge, as we can see in figure 3. And a silicone catheter was put inside the opening, and the catheter was put for 2 months. And after that, the catheter was removed, and the girl was mensurating normally from the newly created opening, and there was no post-op pain. And a post-op ultrasound shows complete resolution of the hematosalpinx, ulcus, and metra. And the advantage of vaginoscopic resection is that it has minimal intervention, and it provides complete resolution of pain, and it has the advantage of preservation of the hymen in a young, nulliparous, unmarried, sexually inactive girl.
Okay. This case was managed at your place?
Yes, ma'am.
This case was managed at your hospital?
Yes, ma'am. The case was managed at our hospital, ma'am, and the only intervention we did was in the hysteroscopic resection, and no other intervention was did. And on the second post-op day only, there was complete the ultrasound is of second day post-op day 2, and there was complete resolution of hematosalpinx, hematometra, and hematocorpus, ma'am. And the girl, on follow-up visit, the girl came in our OPD, and for 2 months she was draining, she was mensurating from the drain which was inserted. And on 3rd month, the drain was removed, and she was mensurating normally, and there was no associated pain. And on all the 3 visits, an ultrasound was done, and no collection of blood or was seen anywhere, ma'am.
So there was no need of laparoscopy. There was a hematosalpinx. It was not required.
No, ma'am. No need of laparoscopy was there, ma'am. And with this, only this single opening, all the blood was drained, and around 200 ml blood was drained at that time. And in the drain, which the silicone catheter we put, around 100 ml drain was there in that.
That's a good case, Dr. Anamika.
Thank you, ma'am.
And your poster is also very clear.
Thank you, ma'am.
Short and sweet. Yeah.
What are the long-term complications, obstetric complications associated with these surgeries?
Ma'am, one of the complication is infertility, ma'am, and the other complication, if the patient is able to conceive, there are recurrent first trimester and second trimester miscarriages. Then there is malpresentation. Then there can be, ma'am, preterm labor in these patients.
Any other questions, ma'am?
No. Let's move on to the next case.
Thank you, Dr. Anamika. Now the next presenter is Dr. Neeraj Jindal. His code is OTH10, and her topic is ovarian primary or secondary, a closed book. Dr. Neeraj?
Good afternoon, ma'am.
Yeah. Hi, Dr. Neeraj. Please start sharing your screen.
Yes, ma'am, I'm sharing it.
Is there any problem, Dr. Neeraj?
No, ma'am. Is it visible, ma'am?
No, not yet. No. Yeah, we can see now.
Good afternoon, everybody. I am presenting a case of a 47-year-old lady, para 6 live 6, presented to OPD with complaints of pain lower abdomen and right upper quadrant.
Everybody, please mute yourself except for Dr. Neeraj.
Probably has 2 devices on. You'll have to log out of one device, Dr. Neeraj.
Yes, ma'am. Ma'am, my case is 47-year-old lady, para 6 live 6, presented to OPD with complaints of pain lower abdomen and right upper quadrant. That pain was dilating since 4 to 6 months. Her previous cycles were regular. LMP were 2 months back and spotting on and off for 4 months. History of weight loss was present. On examinations, her vitals were stable. On per abdomen examination, a firm mobile mass measuring 10 into 10 centimeter was felt in left iliac fossa. On PV examination, cervix downwards, uterus was anteverted, normal size, mobile, and a firm 10 into 10 centimeter firm to cystic mobile mass fell through left fornix, and similar 6 into 7 centimeter mass fell through right fornix. Her tumor markers were within normal limits, and with provisional diagnosis of bilateral ovarian tumor, patient was investigated for the same, and the surgery opinion was also sought for pain upper abdomen. USG CCT was suggestive of gallbladder calculi with soft tissue growth of 19 into 10 millimeter that was seen in neck region, involving adjacent liver parenchyma with an axial mass measuring 9 into 8 centimeter in the right and 10 into 7 centimeter in left iliac fossa arising from ovaries. A diagnosis of carcinoma gallbladder with bilateral metastatic ovarian tumor was made, and patient was taken up for cholecystectomy and staging laparotomy. Perioperatively, bilateral ovarian mass with irregular surface, bluish in color was seen. Omental thickening was present on cut section. Gallbladder showed 2 into 2 centimeter growth. Ovarian mass showed solid cystic areas with few papillary excrescences. Histopath report suggestive of neuroendocrine carcinoma of the gallbladder with adenocarcinoma component of less than 30%, with metastasis to uterus, ovary, and omentum and lymph node. Extensive tumor deposits were seen in all these specimens, and immunohistochemistry was positive for synaptophysin, chromogranin, and cytokeratin. Thank you, ma'am.
So, Dr. Neeraj, what did you learn from this case?
Ma'am, your voice is not audible.
Okay, I'm saying, what did you learn from this case?
Ma'am, first of all, that if a patient comes with the lower abdominal mass, we should evaluate the patient as a whole, because 5 to 6% of ovarian cancer in this age are also metastatic from some other primary. So the patient was also having pain of right upper abdomen. And on investigation as well, there was suggestive of gallbladder growth as well. And on, second thing was, ma'am, the immunohistochemistry markers were suggestive of neuroendocrine tumor. That is a very rare tumor, 0.5%. And then gallbladder neuroendocrine tumor is further very rare, that is 0.5%. And then incidence of having its ovarian mets is also very rare, that is 0.2%. And we have to do immunohistochemistry for these tumors, and then we will manage the patient according to that.
Right. Your radiology did not reveal this to be a bilateral ovarian tumor. It revealed it as a single mass.
No, ma'am. No, ma'am. It showed a bilateral tumor.
The bilateral ovarian masses, you have to consider malignancy elsewhere as well, right? Yeah.
Yes, ma'am.
That is the, okay.
Any other questions, ma'am, or shall we proceed? Okay, Dr. Neeraj, thank you.
Thank you, ma'am.
Yeah. Now I would like to call our next presenter, Dr. Norul Fazila, with a code of OTH 11. Dr. Norul?
Yes, ma'am. Yes,
Yeah.
ma'am.
Achha, Dr. Neeraj, please stop sharing your screen so that Dr. Norul can present. Yeah, we can see you, Dr. Norul.
Yes, ma'am. Dr. Neeraj has to log out so that I can share my screen.
She has done it.
Yes, ma'am.
Yeah, now we can see you. Please share your screen.
Yes, ma'am.
Yeah, now we can see you.
Yes, ma'am. Good afternoon, everyone. I'm going to present a case of giant ovarian cystadenoma. Here is a 45-year-old female, para 2 live 2, with a 10-month history of increasing abdomen girth and pain. So we did an ultrasound and CT, which revealed a large abdomen lesion with a size of 35 into 18 into 13 centimeter. All her serum markers were normal. The patient was taken for staging laparotomy. She underwent unilateral salpingo-oophorectomy with the cyst removal with hysterectomy. Frozen section was sent per op, which revealed a benign disease. And her appendix was also examined at the same time, which was tense and inflamed. An appendicectomy was also performed simultaneously. The patient, all the sample was sent for an histopathology. The cyst which was removed was weighing 6 kgs and measuring 13 to 15 centimeters. The post-op period of the patient was uneventful. The histopathology of the patient revealed a mucinous cystadenoma of both ovary and appendix. I would like to conclude by saying that appendicectomy is not a necessary additional procedure in all patients presenting with ovarian cystadenoma, but it should be examined per op. And if it is healthy looking, appendicectomy need not be performed. But several studies have also proven that if the appendix morphology of the appendix is not good, and if it is left and not removed, there may be future complications with the patient. Yes, ma'am.
Thank you, Dr. Nurul.
Yes, ma'am.
Please proceed with the questions.
Yes.
Judges, kindly proceed with the questions.
I'm waiting for Dr. Kusum or Dr. Neeta to ask questions.
Dr. Kusum? Dr. Kusum Arora, ma'am?
What are the surgical interventions in these cases?
Ma'am, if depending upon the size of the tumor, it can be a hysteroscopic management, laparoscopic management, or it can be an open laparotomy. We did a staging laparotomy in this patient because her mass was really big.
As per me, this is a well-managed case. Your poster looks good.
Yes, ma'am.
Dr. Neeta has any questions?
Ma'am, unmute yourself, please.
Sorry, ma'am?
No, I'm not. I'm speaking to Dr. Neeta. I think she has muted herself. Yeah.
Mute ho gaya. Hello? Yeah, it was unmuted actually. Achha, one thing I want to ask, Nooral, if there is a borderline tumor is there, will you still remove appendix or you will not remove?
Ma'am, if there is a borderline tumor, if the appendix is normal looking, it is not. Studies have suggested that it is not necessary to remove. But I would say it always depends upon the surgeon's view, ma'am, how he feels. If he feels the appendix is enlarged, it is better we remove it.
Okay. Is there any effect on the recurrence rate on removal of this appendix?
Ma'am, if the appendix, if it is a borderline tumor, if the appendix is not removed, there are some such cases which have reported with pseudomyxoma peritoni in the later stages after 2-3 years.
Okay.
Yes, ma'am.
Next case.
Thank you. Thank you, Dr. Norval.
Thank you, ma'am. Thank you, ma'am. Thank you, ma'am.
I would like to call the next presenter, Dr. Barkha Vats. Her
Yes,
code
ma'am.
is OTH12. Barkha, are you ready?
Yes, ma'am.
Yeah, please share your screen.
Is it visible, ma'am?
Yeah, we can see you. Please
visible.
proceed.
Good afternoon, everyone. I am presenting a case report on primary fallopian tube cancer. Primary fallopian tube malignancy is extremely rare, accounting for less than 0.2% of malignancies in women, and is often mistaken clinically for ovarian cancer. Histological, molecular, and genetic evidence shows that from 40 to 60% of tumors that were classified as high-grade carcinoma of the ovary or peritoneum may have originated in the fimbrial end of fallopian tube. Diagnosis are difficult, especially in earlier stages. The rate of preoperative diagnosis is in range of 0 to 10%. My patient, a 42 years old woman, P4 Live 3A1, presented to gynec OPD with complaints of abdominal pain and distension since 4 months. Her menstrual cycle is regular. On per abdominal examination, mass equal to 24-week size were felt. Mobile cystic was palpable. CT scan was suggestive of bilateral ovarian mucinous cyst adenoma, and CA125 was normal. Patient was taken for staging laparotomy. Peroperatively, bilateral ovarian mass of multicystic consistency was present, which is shown in figure 1. Total abdominal hysterectomy with bilateral salpingo-oophorectomy with infracolic omentectomy was done, and peritoneal washings for cytology taken. Histopathology report shows high-grade serous intraepithelial carcinoma of fallopian tube involving ovarian surface. The malignant cells were positive for Ki67, WT1 and P53. Post-operatively, patient has received 1 cycle of chemotherapy in September 2020 and is on follow-up. The presenting symptoms for fallopian tube cancer are variable. LATSCO triad, which consists of intermittent profuse serosanguinous bleeding, colicky pain, and abdominal mass. Most cases of PFTC are post-menopausal, but our case was pre-menopausal. Primary fallopian tube cancer is a rare gynecological malignancy. Diagnosis of fallopian tube carcinoma is difficult due to silent features. The procedure of choice is total abdominal hysterectomy with bilateral salpingo-oophorectomy, omentectomy, and selective pelvic and para-aortic lymphadenectomy. Post-operatively, platinum-based adjuvant chemotherapy is the most commonly used therapy for these patients. Thank you.
Well done, Dr. Barkha. I just have one question for you.
Yes,
And that is, what is the prognosis for such women? You staged your case. What stage was she in?
Ma'am, she is 1C.
So you're saying it was limited to the fallopian tube. It hadn't spread beyond that?
1C, 2, 3, ma'am. 1C3.
Okay. It was high grade.
Also present on ovarian surface, ma'am.
Okay. So what is the prognosis in this case?
Ma'am, in stage 1, the 5-year survival rate is almost 80%, ma'am. In stage 1.
Okay. And between let's say primary fallopian tubal cancer and let's say uterine cancer, which one is a better cancer to have? Which has better prognosis? Let's say this was endometrioid carcinoma of the uterus, and the other is the one that you showed.
Ma'am, fallopian tube tumor is, if early diagnosed, has a poorer prognosis.
It has a poorer prognosis than other tumors. Okay, right.
What are the histological features in your case?
Ma'am, on histopathological examination, the cancer was present in mainly on endosalpinx, and the surface of ovary was involved, ma'am.
Histologically, I'm asking. Histological features.
Ma'am, papillary serous carcinoma was present.
So one thing I want to ask, Batha, what like you have not taken in your case a frozen section? Would have been helpful or not? Frozen section.
Ma'am, yes, ma'am, we didn't take it, ma'am. Ma'am,
how would that have been helpful? You have done, I think, omentectomy and your this thing. I just have forgotten. So do you think would have been helpful if you would have taken frozen section at that time?
Ma'am, actually, post-operatively, after doing bilateral salpingo-oophorectomy and TAH, we generally give adjuvant chemotherapy only, ma'am. Ma'am,
that's okay, but I think you have not done lymphadenectomy and all this in this case, no?
Yes, ma'am.
You have not done, no?
We were not suspecting fallopian.
Yeah. So that is why I'm asking if the frozen section would have been done.
Yes, ma'am. Yes, ma'am.
In that case, the surgery would have been complete, huh?
Yes, ma'am. Yes.
Okay, fine.
Okay. Thank you, Dr. Barka. Now we're moving on to the next presenter, Dr. Aditi Chawla. Her code is OTH13. Dr. Aditi, are you there?
Yes, ma'am. Can you hear me?
Yeah, I can hear you. Please start sharing your screen.
Yes, ma'am. Ma'am, is this visible?
Yeah, we can see you, Aditi, but I would say the font is very small. So please summarize your case. Just tell the case. Okay, discussion that the judges will take care of it. Okay.
Yes, ma'am. Ma'am, good afternoon, everyone. I am presenting a case on hook effect in the case of choriocarcinoma. This is a case of 24-year-old gravida 2 para-1 live on abortion, one woman who presented with recurrent bleeding per vagina since spontaneous abortion 3 months back, with history of dilatation and curettage 2 times after abortion, 1 month apart, wherein mass with grape-like vesicles was observed. On examination, the vitals were stable, the pallor was present. She had a soft abdomen with slight distension. Guarding was present with no mass palpable. On per speculum and per vagina examination, the bleeding per vagina was present. Uterus was of 10 to 12 week size with a closed cervical os. All the necessary investigations were sent, and including pelvic ultrasound and quantitative serum beta HCG. UPT was done, which was negative. Ultrasound reveals enlarged uterus with echogenic content in cavity, and there was evidence of free fluid in cavity. UPT was repeated in dilution to rule out the hook effect. The test became positive after diluting the urine 4 times. A subsequent workup showed numerous permanent nodules in bilateral lungs, likely due to metastatic choriocarcinoma. Staging laparotomy was done, wherein hemoperitoneum was observed, and on cut section of uterus from the posterior surface, multiple small perforating growths coming out of uterine cavity with fresh bleeding was seen. Frozen section was sent, and the HP report revealed characteristics of choriocarcinoma. Total abdominal hysterectomy was done, and the patient had an uneventful hospital course along with chemotherapy. 1 year after this presentation, the patient had complete remission of a choriocarcinoma. Basically, this discussion is about the hook effect, wherein the mainstay of these gestational trophoblastic neoplasia is beta-HCG. However, at times, excessive beta-HCG production may produce a false negative result, which is due to the prozone phenomenon, which is called the hook effect. Therefore, whenever we are suspecting gestational trophoblastic disease, we always have to repeat the test and dilution if it comes negative at the first time. This is because excess beta HCG is released in these cases, which saturates both the antibodies and prevents the positive test.
Dr. Aditi, that's a nice case presentation. And in fact, introduction of a concept which you say is as old as 1975, but has only been introduced to me today.
Yes, ma'am.
But I do want to know, is there a limit to which the, at which the beta HCG level will cease to be detected by the urinary pregnancy test kit? Is there an upper limit above which, and are you aware of that limit?
Ma'am, basically, beta HCG level above 25 is considered positive for pregnancy.
That's correct. What's the upper limit? So based on what you explained, the hook effect, you said if it is too high, it will not show up on pregnancy tests because the receptors are occupied based on the picture that you showed. Is that correct? Or do you want to explain the hook effect to us? What is the hook effect?
Ma'am, hook effect is basically when the excessive beta HCG production, like in the cases of gestational trophoblastic neoplasia, they can produce a false negative result, which is due to the prozone phenomena. This prozone phenomena is basically when we perform a urinary pregnancy test. It includes the beta HCG, it includes the sandwich assays, which are reported as positive if the antigen binds both to the antibody and the both to the test antibody and the capturing antibodies. Whereas in this case, if the excess HCG is produced, it saturates the fixed antibody and the labeled antibody, which prevents the sandwich phenomena.
Okay, so so you say if you dilute the urine enough, you would have enough capturing antibody and even the other antibody that you said. So it's basically two antibodies in between which the antigen is trapped, and then it becomes visible, right? So, and you say you dilute it at some level, it will be visible.
Yes, ma'am.
Is there an upper limit to the HCG level in urine below which it will be visible and above which it will not be visible? Are you aware of any such thing? Like, could it be called a semi-quantitative assay that if it is negative, you know that the values are above 50,000 or they are under 25? There's a range you are saying, right?
Yes, ma'am.
Okay, anyway, so we'll proceed with the next question.
Tell me about the details of chemotherapy in your case. Hello?
Hello, Aditi, are you there?
Dr. Aditi?
Dr. Aditi, can you please answer that question?
Hello?
Hello? I'm asking you about the chemotherapy. What are the details of chemotherapy in your case?
Ma'am, in my case,
Dr. Aditi, are you answering the question or?
Network problem.
So shall we move on to the next candidate, ma'am?
Yeah, I think there is network problem.
Okay, Dr. Aditi, thank you. My next presenter is Dr. Deepika Malik. Her code is OTH14. Dr. Deepika, are you ready with your presentation?
Hello, yes, ma'am.
Yeah, Dr. Deepika, are you ready with your presentation?
Yes, ma'am.
Yeah, please share your screen. Yeah, we can see you.
Yes, ma'am. I'm present. Good evening, ma'am. I'm presenting a case of spontaneous uterine perforation. In this, there is a 60-year-old postmenopausal woman, para 5, live 5, presented with complaint of fever and abdominal pain. Fever was associated with rigors and chills, and pain was intermittent, non-radiating, and non-colicky. And on general physical examination, the patient was dehydrated. Her pulse rate was 110 per minute, and blood pressure is 90/60, and respiratory rate is 20 per minute. On abdominal examination, slight distension present, diffuse tenderness and guarding and rigidity is present, and bowel sounds were absent. On per speculum examination, ectocervix appears normal, and on per vaginal examination, soft uterus of normal size with slight tenderness present in both fornices. After that, we do sonography. On ultrasonography, abdomen full of gases with free fluid and uterus showed minimal fluid in endometrial cavity. After X-ray of the abdomen, no gas under the diaphragm was found. So that we kept the patient in the ICU, but after 6 hours, patient gets deteriorated. So we do urgent CT abdomen and pelvis. After that, perforation in the uterus with multiple pelvic and intra-abdominal collections was found. So decision of urgent laparotomy was taken. On Paro findings, approximate 1 into 1 centimeter rent on posterior side of uterine fundus was found that was sealed by pus flakes along with multiple pelvic and abdominal collections. So in that case, we do total abdominal hysterectomy with bilateral salpingo-oophorectomy was done along with peritoneal lavage. It is an uncommon condition which is mainly present in elderly postmenopausal women. It is mainly present only when the natural drainage of the uterine cavity is compromised, especially in case of malignancy. But in our case, in histopath examination, necrotic endometrium with no evidence of malignancy was found. This spontaneous perforation, degenerative or necrotic change develop as a result of blockage of natural drainage via stenotic cervix. In this case, we diagnose only by exclusion. In our case, abdominal X-ray may show gas under the diaphragm not shown. That because of maybe because of pus flake sealed perforation. It is confirmed only by ultrasonography and CT scan. In this case, total hysterectomy along with bilateral salpingo-oophorectomy and thorough drainage and irrigation of abdominal cavity remains the preferred treatment. And in every case, in every histopathological diagnosis should always be established. Thank you, ma'am.
Thank you, Dr. Deepika. Judges, please proceed with the questions.
So what you're saying, Dr. Deepika, is that in every case of pyosalpinx in the elderly, you may not find malignancy. However, you say that a hysterectomy is still needs to be done. Is that your message?
Ma'am, in our case, patient is 60-year-old postmenopausal woman. So that's why we do total abdominal hysterectomy with bilateral salpingo-oophorectomy.
All right.
If it was a case of 30 years, then what you would have done?
Then, ma'am, firstly, we diagnose. Firstly, we found the cause of the perforation. In 30 years age, there is maybe any cause of perforation due to any DNC.
I'm asking about the management.
Let's proceed to the next case.
Okay, ma'am.
I just want to ask, in every case, Deepika, you will do this ultrasound and CT scan will diagnose the perforation? Deepika?
Hello.
Deepika, in every case, do you think this ultrasound and CT scan can diagnose a perforation?
No, ma'am. In most of the cases, X-ray was only the mainstay. In X-ray, if we found the gas into the diaphragm, then we confirm the diagnosis.
Why on ultrasound and CT scan? Why? What is like when it will not be possible to see this perforation on ultrasound and CT scan?
Ma'am, in our case, there may be the rent is.
No, I'm just asking. In ultra, is it always? You said you will do only X-ray, but why on? I'm asking why on ultrasound or in CT scan you will not be able. Sometimes you will not be able to diagnose the perforation. Okay, fine. Next case.
Thank you, Dr. Deepika. My next presenter is Dr. Shivya Jha, and her code is OTH16. Dr. Shivya, are you there?
Yes, I'm here.
Yeah, Shivya, please start your presentation.
You could skip the discussion and the introduction. Just give us your case details.
Okay, ma'am. Here a small study was conducted where the primary objective of the study was to examine a comparative pregnancy success rate between affordable tuboplasty, which is done free at a government hospital setting, versus the expensive in vitro fertilization done at private organization. The study was conducted among couples who were diagnosed with the reversible causes of tubal factor infertility. The study was retrospective observational study conducted for a period of 1 year involving women aged between 25 to 35 years of age. The inclusion criteria had women with treatable causes of tubal infertility with a fertile, healthy husband, and the exclusion criteria had women with infertility owing to non-tubal causes or tubal factors that involved large tubal segments, other comorbidities, had active infections, had non-reversible infertility issues owing to male causes. The main study methodology was I had taken 11 cases of candidates with tuboplasty or tubal recanalization diagnosed with tubal factor infertility. And the group 2 had 11 cases who were undergoing IVF treatment for the same reversible causes of tubal factor infertility without any recanalization done in them. Then the cases were observed for a period of, although I've mentioned 1 year here, they were followed up for a period of 1.5 years after the treatment or the surgery, and a comparative study was drawn up. The results showed that out of 11 cases of tuboplasty or recanalization, 6 patients had intrauterine pregnancy, that is 54.5%. Out of them, 4 cases went on to have full-term singleton pregnancy, and 2 had spontaneous abortion. The one drawback of tuboplasty recanalization out of these 11 cases were 3 cases did not conceive, and 2 cases had ectopic. Simultaneously, on the other side, when the comparison was drawn for the IVF conceived pregnancy, 7 out of 11 had intrauterine pregnancy. Out of them, 4 cases had singleton pregnancy full term, and 1 had conceived twin pregnancy. All these 4 patients went on to full-term pregnancy. 1 had ectopic pregnancy, 3 did not conceive, and 3 had spontaneous abortion. So the conclusion was that infertility treatments provided free of cost at government setting for tubal factor infertility is almost at par with private setups offering costly in vitro fertilization. What we found that many couples were not aware of tuboplasty or recanalization procedures which were offered at a very affordable rate at government settings. They opted for expensive private treatments. So this small study was conducted where we can raise an awareness as to the couples can choose the government settings first before opting for expensive in vitro fertilization.
Yeah, that's a good conclusion, but I have 2 things to ask you. One is, what is the mode of surgery you used? Was it open or was it laparoscopy?
Ma'am, we opted for before the COVID times, actually. We every month, 2 days were set up for laparoscopic recanalization procedures. We took up around 3 to 4 cases per session.
Okay. Laparoscopic recanalization.
Hanji, ma'am.
Right. Second is, so when you make this conclusion that it will be at par, are you also, I mean, based on what you've done a very strong selection. You have selected women who are good prognosis for surgery. And
Yes, ma'am. Yes, ma'am.
IVF, on the other hand, can be offered to everyone.
Yes, ma'am.
Sort of people with bad tubes, worse tubes, or good proximal, what kind of disease they have. It is that you can offer IVF, and this can be offered to only very selected patients, young patients who have good prognosis and have that factor. So when you make that conclusion, it's always with the rider. In well-selected patients undergoing laparoscopic, you have to mention your method, undergoing laparoscopic
recanalization.
And then again, it's surgeon's expertise. The results would be similar to those seen in IVF. That's my mission. Okay, well done, Matt.
Any other questions, ma'am, or shall we move on to the next candidate?
According to you, the complication of these surgery is most common?
Ma'am, the surgery main complication was pregnancy related. And the second one was it took time, around 4 to 6 months later, the patient conceived regarding recanalization. IVF, ma'am, they conceived after 2 to 3 cycles, after ovulation induction. The pregnancy occurrence was earlier in case of IVF compared to recanalization. And the second one was, ma'am, that the ectopic pregnancy in recanalization was found to be more compared to IVF.
Okay. Yeah, cases which you have selected, I think that was only the sterilization patients or tuboplasty you did in which?
Ma'am, there were 2 cases I had taken up who had prior history of tuberculosis. One was a small case, ma'am, hydrosalpinx beta, but that was a very small, less than 3 centimeters. So we had opted her, taken her up, but unfortunately she did not, she was the one who had undergone ectopic in...
and other cases? 8, 9 other cases were all
out of these 11 cases, 4 to 5 were those who had already undergone tubal sterilization and they wanted to conceive again. So these were taken up, and 3 to 4 had, one had tubal history of hydrosalpinx, and 2 had a childhood history of tuberculosis, and 1 had only 1 patent tube.
Okay. And what will you prefer if there is a proximal tubal occlusion and distal?
Ma'am, depending, what we needed here, we had assessed these patients prior regarding HSD. We had done HSD tests and all those tests. So we needed around 3 to 4 centimeters of working.
No, it's fine. If there would have been a proximal tubal occlusion or distal, what you would have preferred?
Distal was easier to operate.
I'm not talking about this this difficult tuboplasty you can't do in distal, but I'm asking if there is only a proximal tubal occlusion, not because of tubal sterilization. I'm asking if there is a proximal tubal occlusion, what you would have preferred? What is the mode of treatment in that? And if it is a distal, fimbrial, and if there is some occlusion is there, what
fimbrial and laparoscopic recanalization or tuboplasty is very easy to perform, and had it been proximal, ma'am, it required assessment. We could have undergone once and then followed by seeing the success rate after tuboplasty.
Okay, next.
Okay, thank you, Dr. Shabia. Now the next presenter is Dr. Zahida Aziz. And
yes, ma'am.
OTS 17. Yeah, Zahida, are you ready with your presentation?
Yes, ma'am.
Yeah, please share your screen.
Zahida, just once reminding you once more, no introduction or discussion, just details of your case.
Sure, ma'am. Good afternoon, everyone. Esteemed judges. I'm going to present a case of anti-NMDA receptor encephalitis with ovarian mature teratoma. It's a case of 14-year-old girl who presented with history of fever, altered behavior, change in posture, visual and auditory hallucination, and followed by 3 to 4 episodes of seizure over a period of 2 months, and also associated with involuntary movement of both the upper limbs. And Following which she went to a health institute and was diagnosed with anti-NMD receptor encephalitis, which was confirmed by anti-NMD receptor antibodies in her CSF fluid. She was given a course of IV methylprednisolone and IV immunoglobulin, and upon workup, she was found to have a right ovarian dermoid cyst of 6 into 4 centimeter in a trans-abdominal ultrasound, and she approached our institute with this diagnosis. And also, she also has a significant past history of a left oophorectomy done for 2 years ago, done for an ovarian mass, which came out to be serous cystadenoma. Hence, this was the only remaining ovary she had. Then she approached us 7 months after onset of symptoms, and she underwent, we conducted the laparoscopic right ovarian dermoid cystectomy, and the histopathology revealed mature cystic teratoma. And in this case, I would like to stress that the glial component was seen. Then finally, the patient had a normal post-operative recovery, and she was discharged in stable condition. And on 1 year following surgery, she was found to be absolutely stable with no neurological symptoms, with a modified ranking score of 0. So I would like to conclude and give a take-home message that this entity of anti-NMD receptor encephalitis should be known to neurologists and psychologists and pediatricians as well when young women present with psychiatric symptoms and symptoms mimicking encephalitis, to rule out ovarian masses, so that surgical treatment for such cases have found to have a very good prognosis. About 80% of these cases have a very good prognosis, and in others, so if not operated earlier, they would have a very bad prognosis, and sometimes even leading to death. Thank you.
Thank you, Dr. Zara.
Yes.
Yeah. Judges, please proceed with the questions.
Why do you think this case, again, I'm asking, there has been a presentation of this case earlier also, no?
Similar presentation.
So I want to know, a similar case was there. Huh?
Yes.
I want to ask why there was a delayed presentation of
Yes,
this case.
yes, like I've mentioned, the ovarian teratoma was a very like 5 to 6 centimeter size, and it was asymptomatic. And if this entity is not known widely, so there will be time for diagnosing an ovarian teratoma will be late. So once it is diagnosed, because the initial workup should also include a ultrasound or radiological investigation to rule out any ovarian mass. So if that is not done at a early stage, then the disease might progress and it will be difficult to catch this diagnosis. And thus, that is why I believe it is diagnosed later in stage and might lead to poor prognosis.
What other tests you will do?
Yes, ma'am. Other tests yes, the recent diagnostic criteria include EEG also, and CSF analysis to know pleocytosis, EEG showing abnormal waves, and other tests also include MRI brain could also be done, which sometimes shows hyper intense lesions. Then and normal CBC could also be done, and also herpes simplex viral encephalitis should also be ruled out in the CSF analysis, because that also causes recurrent encephalitis, so that should be ruled out.
What can be the worst neurological complication if it is not treated on time?
It could lead to hypoventilation and coma followed by death. That would be the worst.
Okay, actually we can proceed further. Any other question? Fine.
Okay, thank you, Zaida.
Next,
yeah, now the next presenter is Dr. Menka Verma. Dr. Menka? Dr. Menka, can you hear me?
Yes, ma'am, I can hear you.
Yeah, please share your screen.
Ma'am, please can you ask your backup team to share my screen?
They're also listening to you. The backend team, please help Dr. Menka. Backend team, do you have Menka's presentation? Yeah.
Good afternoon, ma'am. I'm presenting a case of ovarian choriocarcinoma masquerading as ectopic pregnancy. The estimated incidence of gestational ovarian choriocarcinoma is 1 in 369 million pregnancies, and non-gestational ovarian choriocarcinoma are less than 0.6% of all ovarian neoplasm. I am presenting a case of 30-year-old female para-1 live-1 with 2 abortion, who last abortion 3 years back, was referred to our hospital. Patient presented with referring hospital with a history of amenorrhea of 3 months and bleeding on and off bleeding per vaginum since 1 week. Her UPT was negative. On examination, uterus was 8 to 10 week size and no other specific findings were there. Her USG showed large heterogeneous solid cystic mass of 8 centimeter with internal vascularity arising from the ovary. MRI finding was also corroborated with the USG findings, possibility of molar ectopic gestation with bilateral thecal luteal cyst. Her beta HCG was 5 lakhs. Patient was taken up for laparotomy and proceed. On per-op, 10 into 10 centimeter lobulated hemorrhagic mass visible on the right side, which preceded with the salpingo-oophorectomy, and another mass of 6 into 6 centimeter of lobulated mass with hemorrhagic area seen on left side was left in situ as patient was young. On post-operative 3, patient was reported to our hospital. On per-abdominal examination, a vague irregular mass, hard, firm to hard mass felt in abdomen, size corresponding to 16 weeks gravid uterus. Her beta HCG was 15,000. We sent her blocks for histopath examination from our institute, and it came out to be pure choriocarcinoma. Immunohistochemistry tumor found to be positive for beta HCG, KIA67 were present in 30 to 40% cells, and positive for CK also, cytokeratin. Patient, we have given her 6 cycles of Imaco regime. Her beta HCG decreased to 2 after 5 cycles of chemotherapy, and patient has responded well with chemotherapy without any complication and side effect. Currently, patient is under regular follow-up and free of any recurrence and relapse. My conclusion is, as my patient is young and having previous pregnancies also, and her beta HCG was high, but definitive diagnosis is made between the gestation and non-gestation. Definitive diagnosis is made on the basis of genetic, molecular genetic analysis, which is not available in our hospital as it is very costly test. It differentiates between the maternal and paternal DNA that is not available in our hospital. But yes, ma'am. Yes, ma'am.
No, what we are trying to ask you, Menka, is what is the dilemma in your case, and why this dilemma?
Ma'am, as beta HCG was very high, and last pregnancy was 3 years back. UPT was negative. It was confusing because beta HCG high was in favor of gestational, but last pregnancy was 3 years back and UPT was negative. So it was more in favor of pure non-gestational.
So a lady who has not been pregnant for 3 years and comes up with bilateral ovarian masses. Wasn't that the picture? Bilateral ovarian masses?
Yes, ma'am. That was a picture, but yes, ma'am.
This was also the picture preoperatively?
Yes, ma'am. This was the picture preoperatively.
Why would you think of ectopic in this case?
Ma'am, it was presenting as ectopic because the mass was on USG, it was showing ectopic.
That the pregnancy test was falsely negative?
Yes, it was falsely negative because beta HCG was very high.
But this is a bilateral tumor. Why would you think of ectopic?
Because, ma'am, diagnosis is not because making diagnosis of gestational or non-gestational ovarian carcinoma spinal diagnosis is made on the molecular genetic analysis.
No, that's true. I was just wondering at the title of your poster, something masquerading as ectopic pregnancy. There are bilateral masses, okay, and one-sided mass with high HCG, ectopic is possible. Bilateral mass, ectopic is still possible, but heterotopic pregnancy, the incidence is 1 in 30,000, which is much less than the incidence of ovarian tumor if you have bilateral masses, right? So I was just wondering at the title, that's all.
Ma'am, in the reproductive age group, if patient is trying to conceive, and her beta SCG is 5 lakhs, and
bilateral mass is difficult, but the judges could, Dr. Neeta or Dr. Kusum could comment.
Is it necessary to differentiate between gestational and non-gestational choriocarcinoma?
Ma'am, then treatment regime and prognosis depend on the type of gestational and non-gestational.
What treatment you give in gestational and non-gestational?
Gestational will respond better to methotrexate regime, and prognosis is good in that patient. And in non-gestational, bleomycin, etoposide,
and prognosis is better in which?
Gestational is better. They respond better.
So you opened up this case as ectopic only?
Yes, ma'am. It was opened as case for taken up as ectopic.
And previous ultrasound showing, the ultrasound was showing bilateral.
It was showing a bilateral mass. One was of 6 centimeter, other was 10 centimeter.
Okay.
Okay. Thank you, Dr. Menka.
Thank you, ma'am.
Yeah, our next presenter is Dr. Ritu Bharadwaj. Her code is OTH19. Dr. Ritu, are you ready with your presentation? Yeah. Please proceed.
Good afternoon, ma'am. I'm presenting the case of the malignant mixed Mullerian tumors, which are also considered as the one of the most lethal neoplasms of the female genitourinary tract. I'm presenting the case of the 65 years old female, postmenopausal female, who presented with us in the OPD with blood mixed vaginal discharge for around 6 months. We did the per speculum examination, which showed the large necrotic 4 into 4 centimeter size, foul smelling polyp coming out through the os. When we did the per vaginal examination, cervix was dilated and the mass was felt coming through the os. Polypectomy was done then and there, along with the endometrial biopsy, the reports of which histopathological examination of the polyp showed malignant mixed Mullerian tumors. The rest of the endometrial biopsy and the cervical biopsy reports were normal. Following which the patient underwent total abdominal hysterectomy with bilateral salpingo-oophorectomy with pelvic lymph node sampling and omentectomy. On the cut section of the uterine corpus, a polypoidal mass was seen, and the histopathology of the histopathology of the mass showed the homologous uterine malignancy, malignant mixed Mullerian tumors, while the histopathological examination of the cervix, ovary, fallopian tubes, lymph nodes were found negative. Following which we give the adjuvant chemotherapy, carboplatin and the paclitaxel chemotherapy to the patient. Patient developed neutropenia after the second cycle and patient expired of septicemia. The take-home message in my case was every vaginal discharge should be investigated and diagnosed, as it can lead to the fatal prognosis, as was shown in my case.
Judges, please proceed with the questions.
What are the risk factors with these tumors?
Ma'am, the risk more the number unopposed estrogen, the more the number of menstrual cycles, the more are the risk factors for the female to develop the endometrial carcinomas.
How other risk factors?
Yes, ma'am. Hello. Excuse me, ma'am.
Yeah, Dr. Kusum, can you please repeat the question?
What are the risk factors of these tumors?
Ma'am, the early menarche, late menopause, nulliparity, the more the number of menstrual cycles, more are the amount of unopposed estrogen in the female. These are the risk factors. Diabetes mellitus, hypertension, obesity, these are the risk factors for these.
Okay. Okay, Ritu, tell me how this tumor is different from other uterine tumors.
Ma'am, this tumor is made up of both the components, sarcomatous as well as the carcinomatous components. It
okay, tell me. Yeah.
This is made up of both the components. That's why it is different, and it is also different in its aggressive nature. It is mostly found in widely disseminated in both the pelvic and the abdominal cavities at the time of the presentation. That's why it is very lethal also.
Can you tell me the 5-year survival rate of this tumor?
Ma'am, it is a 5 years. It is very low. The survival rate of this tumor is mostly as you measured in months. As the normal survival rate is 2 years for this carcinoma in most of the patients.
Okay, Dr. Banerjee, next.
Okay, Dr. Ritu, thank you. Now I would like to call Dr. Bharti Singh Sengar. Her code is OTH20. Dr. Bharti, are you there? Yeah. Good afternoon, Dr. Bharti. Please share your screen and start presenting.
How many more we have left, Sharmashta?
Ma'am, after Bharti, we have only one candidate who is designated to this session, but we have Dr. Nisha and Dr. Akansha from the previous session who missed their presentation. So we have to accommodate them also.
Okay. Dr. Bharti.
Yeah, we can see you, Dr. Bharti. Please proceed.
Good afternoon, everyone. My topic is, does every clitoral cyst need removal? The case was a 50-year-old multiparous female presented in our OPD department with the complaints of slowly growing swelling in the pubic region for last 6 months. And it was painless, not associated with any symptoms of dysuria, dyspareunia, or pruritus vulvi. And on examination, there was a soft painless cystic mobile mass origin extending up to the labia minora with regular margins and smooth surface like it is shown in the figure, and there was no ulceration. And on ultrasound of the mass, it showed a sebaceous cyst. So it was planned for surgical enucleation. There were no signs of virilization in the patient. Complete excision of the cyst was done by a reverse V-shaped incision on the swelling without damaging the neurovascular bundle of the clitoris. Then on the second post-operative day, there was a small hematoma and it was removed after cutting one stitch. Patient was discharged on the 4th post-operative day. On her histopathology report, epidermoid cyst lined by stratified squamous epithelium filled with keratinous material was found. As usual, most common etiology of clitoral cyst are trauma, but this case was unique as it was there was no history of any genital mutilation or trauma, and no history of any oral contraception used in the patient, and it was a spontaneous onset. So my conclusion was clitoral epidermoid cyst should be differentiated from many other pathologies of clitoris with an accurate clinical evaluation and surgical management on an outpatient basis would be an ideal therapeutic approach for epidermoid cystic lesion of the clitoris, for which the clinical and pathologic findings are very characteristic, although the underlying etiology can differ. Thank you.
Okay, Bharti, can you tell me, removal of this cyst will be easy or will difficult surgery?
It will be difficult as clitoris has good vascular supply. So the achievement of hemostasis is difficult. So any clitoral surgery has to be very vigilant for hemorrhage.
What can be the most common etiology of this cyst? Most common etiology.
Trauma.
Which country is it? Trauma.
Africa.
Which countries is usually found?
Like Africa and West Asia, countries in the region of West Asia, there is a ceremony for female circumcision and genital mutilation of the newborn female baby.
Okay.
Any other question, ma'am? Okay. Now we have Dr. Kagita Vasudha Bhargavi. Her code is OTH21. Dr. Kagita, are you there? Yeah, please start your presentation.
Yes, ma'am. My screen is visible, ma'am.
No, Kagita. We can't see you.
Ma'am, can you see my case, ma'am?
No, we don't see.
No, we cannot see you.
Ma'am, 1 second, please. I'm trying.
Yeah.
Shades. Ma'am, can you see now, ma'am?
No.
No.
Yeah, now we can see you.
Yes, ma'am.
Yeah.
Good afternoon, everyone. My topic is primary infertility with fibroid uterus and pituitary microadenoma management dilemma. Coming to my case, a 33-year-old nulliparous female with 12 years marital life with mass per abdomen presented to OPD with gradual increase in size and pain since 1 year. Infertility workup was done. All her investigations were normal except for raised serum prolactin levels around 1676 nanograms per ml. Her MRI all abdomen and pelvis showing 11 into 24 into 30 centimeters abdominopelvic mass arising from anterior wall of uterus with adjacent dilated uterine and parauterine vessels and mild bilateral hydroureteral nephrosis was noted. Her MRI brain with pituitary showed 2 into 2.5 mm small hypoechoic enhancing area in anterior pituitary with normal brain parenchyma. Ophthalmology referral was taken and it was found to be normal. Her serum prolactin levels showed decrease in trend from 1676 nanograms per ml to 28 nanograms per ml after using tablet cabergoline 0.5 mg for 6 weeks. Intraoperatively, 10 kgs of uterus was found, so of around 18 into 20 centimeters size, and intraoperative blood loss was around 2.5 liters. And 2 units PCV and 2 units FFP was given intraoperatively, and postoperative period is uneventful. Here we have done laparotomy followed by frozen section and myomectomy. Hyperprolactinemia may affect the fertility potential by impairing pulsatile secretion of gonadotropin releasing hormones and thus impairing ovulation. These are classified as microadenomas of less than 1 centimeter diameter and macroadenomas of more than 1 centimeter diameter. And conclusion is fibroid is a common condition in infertility and its surgical management can be complicated by medical conditions like hyperprolactinemia and a rare cause to be ruled out and managed well.
Okay.
Thank you.
Yeah. Dr. Vasudha, that's a huge fibroid you removed, but
yes, ma'am.
How are you linking prolactin levels with the fibroid? Is there a link mentioned in literature?
No, ma'am, it's just a coincidental finding, ma'am.
It's a coincidental finding.
Yes, ma'am.
And you do mention in your history, this is a case who's trying to conceive for 12 years.
Yes, ma'am.
And then you somewhere mentioned that the prolactin levels were high and they affect ovulation, right?
Yes, ma'am.
So what was ovulation in this lady like? Was it, or how would you assess ovulation? What's the commonest way to assess ovulation?
By hormonal study, ma'am, FSH, LH.
What is the one clinical feature of regular ovulation?
Regular cycles with regular cycles. Ma'am, sorry.
Dr. Neeta, please mute yourself.
Maybe okay. So I'm saying ovulation you want to assess. Let's say this was a diagnostic dilemma for you and you're trying to link. Is prolactin somehow making the growth of fibroid excessive? Is that linked? And do I need to? But basically, in the end, you say that these are unlinked procedures, unlinked processes. One is fibroid itself, which is growing independently, and the other is high prolactin level, which also has to be individually managed. But
yes, ma'am.
In the presentation, what was not clear was whether this lady was ovulating regularly. One way to know that would have been to know whether this was regular periods or not.
Say regular periods and pain during menstruation.
Regular periods is good enough. Regular periods,
yes,
eumenoric, that's what you want to know. The
yes,
second is that such high prolactin levels is again something that you need to look at. Did she have galactorrhea? Those are the two features, like primary clinical features that you need to look at in a case of hyperprolactinemia are galactorrhea and?
Galactorrhea, amenorrhea, ma'am.
These are the two things. And your
yes, ma'am.
presentation does not, unfortunately, show us that. And the link is not there between fibroid and hyperprolactinemia. In their pathologies, usually.
Yes, ma'am.
And very important investigation should have been done if there is hyperprolactinemia. Can you tell me what else is missing?
Ma'am.
Another investigation, hormonal?
Thyroid. T3T4 TSH, ma'am.
And in all the cases of fibroid, you will be doing surgery, or you have to select the cases in which you will be doing surgery and rest you will leave?
Yes, ma'am. We have to individualize the case, ma'am, regarding fertility status, size of the fibroid, and any complications due to pressure effects or location of
Role of
fibroid,
oral
ma'am.
treatment
Secondary changes in
other than
fibroid.
other than surgery, what is the role of oral treatment?
It can decreases the size of the fibroid preoperatively.
What treatment you give? Oral treatment.
GnRH agonist can be given, ma'am. To decrease the
Which
size of the
drugs?
fibroid preoperatively.
You will treat both the cases, na? You have taken microadenoma also and
Yes, ma'am.
fibroid. What
Yes,
drugs you will take? What drugs you will give?
Cabergoline and bromocriptine can also be given, ma'am.
Criteria? What is the criteria of giving these drugs? Oral, whether you will do surgery or you will do oral treatment.
Microadenomas generally can be treated with medical treatment, ma'am. And macroadenomas more than 10 mm along with pressure effects like optic chiasmal compression, any visual symptoms, then we'll go for surgery, ma'am. First, we'll try medical treatment, and if they're not compliant or it is not decreased with medical treatment, then we can think of surgical management.
So should we move on to the next one?
Yeah, next case.
Thank you.
Now we have two more candidates from the previous session. One is Dr. Nisha Yadav and another one is Dr. Akansha Gupta. I think they both have logged in and they missed their session.
क्या पूछ लिया?
Dr. Kagita, please mute yourself.
Very funny, no?
She's very happy after the presentation. So Dr. Nisha, are you ready?
Also give us their codes, please, so we can mark them.
Ma'am, I don't have their codes because they were not in my session. I will ask the candidate, they will provide us the code. Dr. Nisha, are you there?
Hello.
Yeah, Dr. Nisha, if you're ready with your presentation, please share your screen and tell us your code, please. Dr. Nisha, what is your code?
Ma'am, I don't have my code, ma'am, right now. Like I'll text it, ma'am, later, ma'am.
All the number will be given.
I'll find out. I'll find out. You please share your screen and start your presentation.
Is my screen visible, ma'am?
No.
Not visible.
Technical team, I think, just do their posters, both of them.
And Dr. Akansha, I think you have logged in from two different gadgets.
Dr. Nisha's code is CV6.
CV6. Okay, fine. Yeah, Dr. Nisha, we can see your screen and you please start your presentation, okay?
Ma'am, my case is, ma'am, case of severe preeclampsia with pulmonary edema mimicking as COVID-19 infection in pregnancy. And the case is of a 36-year-old female, gravida 3, para 1, live 1, A1, presented to casualty at 36 weeks period of gestation with previous cesarean section, with cough and breathlessness since 3 days, and low oxygen saturation with SpO2 of 72% with suspected COVID-19 disease. Patient was received in casualty, and on examination, she was dyspneic with respiratory rate of 24 cycles per minute in propped up position, efebrile with SpO2 of 72% at room air, tachycardia with pulse rate of 108 per minute, and BP of 180 by 120 millimeters of mercury. Patient had no other signs and symptoms of impending eclampsia. Patient had history of high BP recording since last 1.5 months, and she was on antihypertensive medication, labetalol, tab labetalol 100 milligram twice daily. Patient received in casualty and stabilized with antihypertensive medication and diuretics. BiPAP support was given along with resuscitative measures. Patient and her relatives were counseled about maternal and fetal condition and the need for an emergency delivery in view of poor maternal condition and respiratory compromise was explained. Decision for emergency cesarean section written informed and high-risk consent. Rapid for COVID-19, PCR for COVID-19 was and preeclampsia screening was sent. Patient had undergone emergency cesarean section under spinal anesthesia and delivered a male baby of 2.3 kg with normal Apgar, which shifted to NICU. Liquor was meconium stained. Patient was shifted to ICU in the post-op period. Patient continued to be on BiPAP support, injectable antibiotics, diuretics, and antihypertensive medications. Diagnosis of severe preeclampsia with pulmonary edema was made after excluding COVID-19. Oxygen saturation improved on BiPAP support, and BiPAP was removed after 48 hours. Thromboprophylaxis was given in post-op period. Her BP normalized on post-op day 4, and patient lived against medical advice in view of some personal reasons. But as follows: hemoglobin of 13.2 gram per deciliter, TLC of 16.6 thousand per millimeter cubes, and platelet count of 275,000 per millimeter cube, INR of 0.90, SGOT 23 and SGPT 18, serum creat of 0.78, sodium 133, potassium 6.09, LDH of 150, urine PC ratio 4 milligram per deciliter, and rapid gene expert for COVID-19 RT-PCR was negative. Thank you.
Any questions, judges?
Why do you think this case you have labeled as like it was mimicking like a COVID-19 infection?
First of all, when the patient was received in casualty, ma'am, she had dyspnea, ma'am, with the high respiratory rate, low oxygen saturation, with SpO2 of 72%, ma'am. So first, during this era, we thought of it might be a COVID infection.
What is more important in the history?
Ma'am, to mimic recordings, BP recorded as 180 by 120, and patient was received in casualty.
We need to consider history to consider it as a case of COVID-19.
History, patient had history of high BP recordings.
It's breaking. Your voice is breaking.
Hello. Hello.
Dr. Nisha, we can't hear you.
Can't hear you.
Hello.
Yeah, please speak a little louder.
Yeah, ma'am. Am I audible, ma'am?
Yeah, we can hear you.
Now audible.
Dr. Neeta was asking, what made you think that she's a case of COVID-19?
Yes, ma'am. That's what I explained, ma'am. On like patient was received in casualty. She was dyspneic in propped up position with low oxygen saturation with SpO2 of 72%, ma'am.
What is most important in COVID-19 patients in the history?
Ma'am, history of contact or travel history.
And?
Febrile, patient will be febrile, ma'am. Fever.
It was there?
Ma'am, she was afebrile, ma'am.
Okay. This one you want to ask?
How will you manage her post-operatively?
Ma'am, we managed her with the antihypertensives. Ma'am, we gave her, as she had pulmonary edema, we gave her diuretics, ma'am. And post-operatively, we continued her on diuretics and antihypertensives, ma'am.
What about the COVID part?
Ma'am, chest X-ray was done for her, ma'am, which was suggestive of pulmonary edema features, and the COVID report came in the post-operative period, which was negative, ma'am.
Okay.
Okay. Thank you, Dr. Nisha. And we are left with one more candidate, Dr. Akansha. Dr. Akansha Gupta.
Yes, can you hear me, ma'am?
Yeah, we can hear you.
Yeah, we can hear you.
Please start your presentation.
I'm sharing.
Yeah.
Yes, ma'am, I'm sharing my screen, ma'am. Is it visible, ma'am?
We can only see your Instagram post.
Very small. Teda meda.
Rotate it.
Hello. Yes, ma'am.
Yeah, now we can see you.
Good afternoon. Yes, I'm sorry.
Yeah.
Good afternoon, esteemed judges. I am presenting my poster on the topic spontaneous uterine rupture in a postmenopausal female, a rare entity. As we know, uterine rupture is common in a scarred uterus during pregnancy or in postmenopausal female with the malignancy. But here we got a patient, a 60-year-old para-5 life 5 postmenopausal women who came to us in emergency with complaints of discharge of vaginum since 1 month and severe pain in lower abdomen associated with vomiting since past 3 days. On examination, the patient was in shock. Her vitals were BP was 70 by 40 millimeter of mercury and pulse rate was 120 per minute. On abdominal examination, there was generalized abdominal tenderness along with rebound tenderness. PV examination revealed 8-week size uterus with bilateral non-tender and free fornices. On further investigating the patient, a chest and abdominal X-ray was done, which revealed dilated bowel loops and no free air in the abdomen. We got a TVS done for the patient, which revealed mild collection in uterus with moderate pelvic collection. And so for confirmation, we did a CCT abdomen and pelvis for the patient, which revealed that there was fluid collection with multiple air fluid levels in the pelvis, and there was thinning of the anterior uterine wall. Bilateral ovaries were normal and there was no lymphadenopathy. So a provisional diagnosis of acute abdomen with query uterine origin was made. We first stabilized the patient. A multidisciplinary approach was taken involving the anal medicine teams, and the patient was started on initially crystalloids followed by inotropes, and she was taken for emergency laparotomy. In the intra, we found there was 200 ml pus like material from the pelvis, and there was a, as we can see in figure 1, there was 2 into 2 centimeter perforation on the anterior uterine body wall, and the bowel loops were adhered on the of rupture. So since she was a postmenopausal 60-year female, we went for total abdominal hysterectomy with bilateral salpingo-oophorectomy, and peritoneal lavage was done for the patient. In the post-op period, the patient was in ICU for 12 hours in view of difficult extubation, following which she recovered slowly and was discharged after 10 days. On further following of the patient, histopath revealed no evidence of malignancy. There was only signs of inflammatory infiltrates and serositis. No AFB was demonstrated, and there was the pus culture was also sterile. To discuss about such cases, since it is a rare entity, only 0.01 to 0.05% cases have been the incidence is very low, and only 42 cases have been reported till date in the English literature, ma'am. The causes for these are impaired drainage of pus from the uterine cavity due to either cervical stenosis or cervical lesions or endometrial carcinoma, and generally malignant disease is present in 35% of cases. The treatment for such patients is immediate laparotomy, peritoneal lavage and drainage, and total hysterectomy. On doing literature review for these 42 cases, we found that abdominal pain was the most common symptom, and the most common malignancy associated with this was cervical malignancies, and preoperative diagnosis of uterine perforation could be made only in 31% cases. And TH was the most common surgery done for this condition, and the site of perforation was fundus. So to conclude, since it is a rare entity and the diagnosis is delayed because of the delayed referrals, and there's high mortality, so this differential diagnosis should be kept in mind when a postmenopausal woman comes with acute abdomen. Thank you, ma'am.
What are the other causes of this spontaneous uterine rupture in postmenopausal female?
Ma'am, in postmenopausal women, there can be a forgotten IUCD or any other uterine procedures that could have been done, ma'am.
Like?
Ma'am, for therapeutic DNCs for AUB or postmenopausal bleeding, patient got from outside, ma'am.
Other causes of this rupture? There can be secondaries also.
Ma'am, in a postmenopausal female, malignancy is most common, ma'am.
Metastasis.
Yes, ma'am.
Very common.
Yes, ma'am.
If it is diagnosed early before perforation, what treatment you would have advised to her? Management. If diagnosed before perforation.
Yeah, if diagnosed early, we can do pus drainage procedure can be done so that it can be drained, and we can start her early on antibiotics, ma'am.
Okay.
according to the sensitivity.
Okay.
Any other question, judges?
No.
Thank you, Dr. Akanksha.
Thank you, Dr. Kansha. Ma'am, her code was MIS 6. Dr. Akansha's code was MIS 6.
Okay.
MIS 6.
MIS 6.
Dr. Nisha's code, what was that?
CV6. CV6.
Huh?
CV6 for Dr. Nisha.
Dr. Akanksha, you can stop sharing your screen now.
And all the judges, I request you to please mail your scoring sheet to aogdvirtual.com.
Yes.
Okay.
Okay, ma'am.
Thank you very much, Dr. Sharmishta, and to the team of Gangaram for doing first time this virtual AOGT conference.
Thank you, ma'am, but it would not have been possible without you all, ma'am. And special thanks to Dr. Kusum Arora because of some communication error. I informed her just 15 minutes prior to this session, and
yeah,
she, joyfully agreed, and she did it so well. I'm seriously grateful to you, Dr. Kusum. Yeah, exactly, ma'am. I'm seriously grateful to you.
Say that we had nicely concluded the poster session.
Thank you.
I must thank Dr. Ruma, Dr. Sharmishta, and all the judges of the day because they have conducted these sessions so nicely. And I must thank all the participants who have participated in great number. Dr. Ruma just told me that we had 80 posters.
82, ma'am.
That's
huge.
So it was a marathon job.
Yeah, effort on your part.
And she has really put in very hard work together with Dr. Sharmishta, and they have really streamlined the today's program.
Yeah.
And I thank all the judges from the bottom of my heart to conduct these sessions so nicely and so carefully.
Thank you, Mala, ma'am.
Thanks, everyone.
Thank you, Dr. Mala.
Welcome.
Thank you so much.
Okay, ma'am.
Thank you, doctor.
Okay, thanks a lot.
Bye, ma'am. Take care.